Arthros welcomes you to this first Ask meeting. Please accept my sincere gratitude towards all the way making it possible and attending this conference. I'm sure the efforts our faculty have taken to make this first Ask meeting very fruitful. I'm sure at the end of the day, you will definitely add a value in your day-to-day practice. Without taking any further time, I just request course chairman Dr. Vinay Tantuway to please take it forward.
Thank you, Umesh. Thank you all, especially the faculties which are coming all the way from Bhopal, Jabalpur. I would like to introduce myself. I'm Dr. Vinay Tantuway, and we are conducting this one-day arthroscopy symposium to enhance our knowledge in the field of arthroscopy. So we have planned 4 live surgeries, 2 in the knee and 2 for the shoulder joint. Our faculty from Bhopal and Mumbai, Dr. Nagar Shetty will perform the shoulder surgeries, and Dr. Brajesh will perform our first live surgery, ACL reconstruction with SOS meniscus repair. So without delaying too much, let's start the program, and people will come later on and will join us. I welcome all of you for this Ask meeting.
Good morning. So starting with the first session, this session intends to teach the youngsters who are on the brink of starting their new arthroscopy journey. So I request Dr. Sheetal Gupta sir to moderate this session, and I call upon Dr. Tanmay sir to present his talk on the basic armamentarium for arthroscopy.
Morning, everyone. So, how many of us, apart from the faculties, I think all of you are doing already scoping? All of you, almost? Just raise hands so we know, understand. Okay. So, for those for whom they want to start or it's new for you, first thing we need to know is the basic armamentarium what we usually carry and we should be carrying and how we can grow over it. So I'll be taking you through a quick, first thing we need to know, yes, as far as arthroscopy is concerned, that's a lot of armamentarium which you need to buy. It's rather apart from when I started my practice, I almost, my presentation is since years where when I started off my own practice. And the first thing we need to have is full of pockets so that you have to invest yourself because it's your own personal setup which you are carrying everywhere. It's not like the urologists and the laparoscopy surgeons who just go and ask for demand for everything, whatever they want to have, and they just stand there and they would say, we want this, we want that, and they get it. Unlike them, we arthroscopy surgeons have so many fine-tuning small equipments which we feel over a period of time, I have felt at least, maybe my other colleagues also must have felt, that you need to have on your own. And that should be because your hand is set on that. So first thing you require is a lot of money, and then ultimately you feel when you start off you are out of your pockets. So basic theater requirements, what we need is a proper minimal access surgery, well-equipped OT. Always try and do in such a surgical OT where basic requirements are met properly. I started in those days when arthroscopy wasn't much, people weren't aware of, and about arthroscopy, especially at Indore. It's long back, 2007, me, Vinay, and everyone started off. But then over a period of time, things developed. Now we have such kind of OTs available everywhere. Almost a lot of people have modular OTs with us. So this is some kind of OT what we would be happy to work with the proper laminar flow, with proper space, and of course with proper anesthetic gear as well. So first thing is the basic optical rod lens system, proper scopes, sheath, trocar. You can have 30, 70, 90 degrees. There are a lot of things available, but mostly what we require is the 30-degree scope. At times you may require this 70-degree as well, for specifically for for PCLs, a lot of people. But then if your hand is adjusted on 30-degree, you would be able to, over a period of time, you would be able to visualize that as through the 30-degree as well. So the field of view of the 4mm scope is always choose the wider. With the standard scopes available, they are always with a wide field of vision. And different diameters are available for different joints if you are venturing into it. So the basic requirement is a 4mm, and for hip scopy and for some specific surgeries in knee, you may require a 70-degree as well. You can keep it in your bucket if you are okay with it. Before buying, always check the clarity of the scopes, check it through the lens rods proper with the light source and things, and so that you are able to visualize. There are a lot of times there are small errors or some kind of cracks there, so be aware of it. And you have to teach your assistants as well, because you won't be able to do it every time. The sheath, the obturator, it should have 2 rotating spigots for the inflow and the outflow, and it should be a high flow cannula. Always choose a high flow cannula. That will be easy for all kind of surgeries. The obturator, of course, should be a blunt or a semi-sharp thing, not a sharp one. If you go with standard companies, you will never find these issues. They are always, they have standardized their instrumentation, so won't be an issue at all. Like as far as light source are concerned, if you are xenon is one of the best. Now they have come up with LED as well. Sorry, I haven't changed it. Earlier there was halogen and other things available. Always try to have 2 bulbs, because at times one bulb gets short. You are in midst of surgery and then you lose the case. So always choose any light source which has double bulb available. That's one thing which is very important. And the cables should be long, flexible, autoclavable, E2able. So choose those kind of light cables, and always check the transmission through it. As far as cameras are concerned, if you are just not totally into arthroscopy, or you just operating like a general orthopedic surgeon, doing trauma and doing some scopies along with it and some plasties, you may initially start with basic single chip cameras as well, if you don't want to invest a lot into it. And then slowly, if you keep on venturing into more and more scopies, you can buy higher grade of cameras as well. So it should be a low lux color digital camera with proper white balance, auto gain control, shutter, and with a C mount adapter. So there are different parts of it. So earlier those surveillance cameras were available, which we are not using anymore. Now we have what we use is the high definition or the 4K scopes and the 4K camera systems. So this is the HD cameras, the monitors. There are portable monitors available if you are carrying it in your car, so that you can travel to specific places. Then always choose a monitor which has a DVI source. Always go with that. So always connect the TV, the light source, camera, scope, and the entire system, the entire light transmission system, before you venture into any of your first scopy. That's very, very important. Tourniquets, your edge march, bandages is a must. Always keep it with you. You may not get it everywhere we are going to operate. So keep it with you. Tourniquet, yes, carry your tourniquet. There are a lot of chances that people mess up with tourniquets. The OT staff doesn't understand we are going to operate. The orthopedic surgeon understands it, but his technician may not. So better carry your own tourniquet if you're traveling. If you're a traveling surgeon, always carry your tourniquet yourself. Always check your cuffs yourself and use them properly. There are a lot of punctured. This is what always happened with me. I'm just sharing my experience. I have been through a lot of When we started, there were people didn't knew much about it, and then we had to carry each and everything ourselves. Now things have improved over a period of time. Shaver systems, the blades, there are different shaver systems available from all kind of companies. What's the desired features? It should be a lightweight, easily ergonomic handle, autoclavable, soakable, and should provide at least 8 to 10, 12K of RPM, and should have a handle for the saw as well for doing your osteotomies or doing your BTB cases. So use specifically for the soft tissue removals, you'll have to be using it for the oscillating mode, and for your burr part, you should be using, or for debridement, you can use it in the forward mode as well. There are various blades, different kinds of blades come from different companies. Usually what we use is a 4 mm, this is the standard one for knee and shoulder. And for the tighter joints or maybe the small joints, for the young aged joints, you can use a 3 mm or 3.5 mm of cutters. There are synovectomy shavers, blades as well, and there are burrs, there are the long barrel, there are the round barrel, depending on what kind of procedure you're doing. And then the manual instruments, basically the probe, the different punches, all the 4 or 5 different basket forceps, graspers, loose body graspers, and the specialized instrumentation for the specific surgeries. So you should be always be having a long probe. That's a mandatory thing, which covers both your knee and shoulder. Either if you want to maintain a 2 different sets for a knee and shoulder as well, then you can keep it like that. And should have a laser marking, because you can measure it on the same time. When specifically with a very, very blunt tip, so that you don't injure, because probe is something you do it, the first thing you go into the joint and you probe it. So it should be a blunt, make sure it is blunt and doesn't have any kind of any sharp edges anywhere. Otherwise you're going to traumatize the knee you're operating. Punches are variable sizes and shapes available. These basics are straight, 15-degree up, broader one and the thinner one. Both you should be keeping because you require them accordingly. The 30-degree left and right, the rotary punches, and this is the fine punch, and there is something called as a meniscus elevator punch as well. The grasper, the loose body grasper, specifically if you have it with teeth, then nothing like it. The scissors are very important. Then the microfracture awl, these are with different angles, they are important. You should be having those in your kit. The entire ACL reconstruction set with your own reamers in 0.5 ranges, the femoral tibial reamers, the jigs for ACL, PCL, for the root as well nowadays, because we are operating a lot of root repairs, doing root repairs as well, so you should be keeping a specific root repair jig as well. So these are the jigs, the portal cannulas, and the pump. The pump is optional depending if you are starting with initially in your career, then yes, pump is something which you would be able to be happy to use it initially. And a cautery, a simple underwater cautery, or good enough, you can go ahead and take a RF. RF is the best, it's an ideal thing, of course. So this is the RF machine. This from various companies, it's available. So this is what a general trolley looks like initially. Then your disposables come in, the irrigation tubes. There are tubes with pressure gauges. You can use them as well. The suction cannulas, the camera covers, gowns, drapes. So you should be keeping a kind of a kit with you if you are a traveling surgeon. If you're operating at a single center, fine, then it's good, but you will be getting all those things. I usually operate knees with leg holders. A lot of people do it with just a thigh support. You can do it in a tikya position, or you can use a leg holder to make your life easy. As far as this is the general patient positioning for the knee. This is how, or this is the other one with the thigh support. That's what I was talking of. As far as sterilization is concerned, yes, you can be using glutaraldehyde. Now there are quaternary ammonium compounds which we are using, aldehyde-free ammonium compounds, which are kind of the best available as of now. Your Autoclave for metal instruments, your metal instruments can be autoclaved, of course, and your entire metal kit like the ACL kit can be autoclaved. Different temperatures you should be knowing these, that for how many minutes, and for because otherwise your staff or the CSSD staff will mess it up at times. As far as the best is still the ETO and the most friendly one. Formalin, almost everyone has, a lot of people, traveling surgeons do use it till date, but prefer to have a pack of quaternary ammonium compound, which now they have the latest ones which are coming. They have disinfection time of just 10 to 15 minutes. That's more than enough. So you should be using those rather than using a formalin chamber. Plasma is nothing like, but you cannot have it, and it's a costly equipment, so big hospitals do have them. Thanks. So that's just a summary of what you should be having. This is the minimum you should be having with you. Thank you.
Thank you,
Thank you, sir.
Thank you, Tanmay. Thank you for your elaborate presentation on armamentarium. I think we are running late for the live surgery, so I would request Dr. Brajesh to come. And what Tanmay has told is absolutely a valid thing, particularly in initial stages of your practice. You don't have that much money to buy the instrument when you require the best instrument. And once you are senior, when you can manage with anything, then you got the best instrument. So one main thing what Tanmay was pointing out is you should have your checklist. So this is a checklist manifesto, a book by Atul Gawande. Everybody should read it. So if you go to your checklist, you will not forget what everything you need to bring while you are starting your arthroscopy. So may I request Dr. Brajesh to start his lecture on diagnostic arthroscopy.
Very good morning, respected chairpersons. So I'll be talking about a quick diagnostic round. So this is the most important thing whenever we are starting the scopy, let it be even a basic simple loose body removal or a complex ligamentous reconstruction. We should always follow the rule that the sequential examination of each and every corner is must for even a very small case. So the first thing what we start, we start by making the anterolateral portal first. That is the first portal which we start with, and we insert our scope. So the first thing what we visit is the supralateral pouch, suprapatellar pouch. So this is how we enter in the joint, and this is the distal part of the quadriceps mechanism which inserts over the superior pole of patella. So we should examine it. Then the next thing is to look for either whether there is any kind of synovial hypertrophy or not, because many times there is a significant synovial pathologies. Then these are the patellar facets. We just withdraw the scope slightly and look upward. So this is the lateral facet of patella which we are visualizing. Then gently curve the scope towards the middle side. We look the middle facet, and then we turn the scope down. So we look for the condition of the intratrochlear notch. Then once we have examined the suprapatellar pouch, usually many times there are the loose bodies which are there in this medial plica. At times this medial plica is very thickened and it's just like a curtain. So this is a very favorite place for the loose bodies which they hide there. So once we have examined our suprapatellar pouch, the next thing is to enter in the lateral gutter. So we turn our scope down in the lateral gutter, and there the first thing what we'll see on the lateral side is the popliteus tendon. We check for the integrity of the popliteus tendon. Again, this is the favorite site of the loose bodies which they are hiding here. Then we go more deeper. So we can see this popliteal hiatus. And the next thing, these are the meniscopopliteal fascicles. So also we look for the integrity of the peripheral part of the lateral meniscus, which is there on the right. So in the lateral gutter, what we see, we look for the popliteus tendon, peripheral meniscocapsular junction, meniscopopliteal fibers, and if there are any loose body. So after suprapatellar pouch, we take our round towards the lateral gutter, and once we have done the examination of the lateral gutter, the next thing what we do, we shift our scope from again through suprapatellar pouch, then to the medial gutter. So in the medial gutter, again what we should look for any kind of loose body if it is there, the condition of the synovium there, the meniscocapsular junction, the peripheral part of the meniscus, if there is any tear, or at times there are displaced meniscus fragments like what we can appreciate here. There is a torn meniscus, medial meniscus anterior horn, which is visualized in the medial gutter. So once we have done the examination of the middle gutter, then we make our, we go through the intercondylar notch, we make a anteromedial portal, we insert the probe, then we check for the integrity of ACL. Like here in this case, this was a chronic case where complete loss of ACL was there. There's no fibers of even ACL. We hook and palpate the integrity of the PCL. We just pull it and we see whether the fibers are taut or not. So after doing examination in the intercondylar notch, looking for the ACL, PCL integrity, also check for if whether how is the condition of the intercondylar notch. At times the notch is very stenotic and that needs to be taken care while doing the ACL reconstruction or any kind of ligamentous reconstruction procedure. Now the next thing, we take a tour of the lateral compartment. So in the lateral compartment, we probe for the meniscus. We should give special attention to the these kind of hidden lesions like meniscus root, posterior root. This is the anterior root. We'll have to pull it, otherwise it won't be possible to check the integrity. Then palpate for the superior surface of the meniscus, whether there's tear or not, or it is the inferior surface of the meniscus. We should look for the peripheral part, meniscocapsular junction, as recently taught by our friend Dr. Sheetal. We should always look for kind of zip kind of lesion which are there. So now I have started seeing for this. So once we have finished our tour in the lateral compartment, checking the integrity of the lateral meniscus root, meniscus, popliteus, and the cartilage condition also, now we shift our scope to the medial compartment. So similarly, we palpate the meniscus, the superior surface of the meniscus, inferior surface. We can appreciate here the complex tear on the undersurface. It is a complete old chronic oblique radial tear, means almost it's a root tear. So this is a very chronic injury. So we are supposed to probe, palpate, hook everything on the, all part of the meniscus, so that we should not miss anything. So especially the anterior part, because they're difficult to visualize and probe. So once we have done the middle compartment scopy, now we should pay attention on the posterior middle compartment. So we push our scope in between the middle femoral condyle and the PCL in the posterior middle compartment. And this is the most important reason, because many times there are significant meniscocapsular lesions, which are called ramp lesions. So this is called the needle test. We bring our needle, just 18 gauge needle, and using this needle as a probe, we check the integrity of this posterior meniscocapsular junction, which is called the ramp region. So at times there are tears, which is called the ramp tears, and they are called hidden lesions because they are not visualized properly from the anterioscopy. So it is very essential to go in the posterior middle compartment, especially in the old ACL tears. So this should be routine. We should go in the posterior middle compartment, posterolateral compartment, even the fresh cases. So to conclude, thorough systematic examination, diagnostic examination is very important. It should be sequential. And it is important to probe each and every part of the meniscus, especially the roots, because at times the lateral meniscus root, they are torn, but they look quite flattened. So we should try to probe everything. And special attention should be given to all these hidden kind of lesions, means the ramp areas, posterolateral compartment, and these root tears. Thank you.
Thank you, sir, for your elaborate lecture. Now I would like to call Dr. Harshvardhan for ACL reconstruction basic steps lecture.
So Dr. Brajesh will be moving probably for the live surgery. So if anybody has got quick question, or probably we can take the question at the time of his surgery only. So I think we would like to see the live surgery rather than the highlights. So very nice presentation, Brajesh. See you for the live surgery.
Good morning, dear seniors and colleagues. I am Dr. Harshvardhan, and I will present a small talk on basics of ACL reconstruction. The intent of my talk is going to be very primary and focused on young surgeons. I'll try my best to cover the iceberg of this topic, that is ACL reconstruction, in a few minutes. So, basics of ACL tear: external rotation of femur on an implanted foot or tibia. 78% cases are non-contact sports. Laxity can be judged clinically. ACL deficient knee, why do we need to operate them? Because they carry a higher rate of medial meniscus tear later on, giving to significant morbidity and osteoarthritis. Factors to consider: the degree of injury, associated ligaments and meniscus tears, the age, activity level and occupation of the patient, sports, and the compliance with the rehabilitation that the patient intends. ACL reconstruction, the 4 pillars of the success: graft quality, appropriate tunnel placement, adequate fixation, and rehab. This is a basic OT setup, as Dr. Tanmay said. One can do it on a implanted foot or keep it free like in a leg holder position. These two are the most commonly used: supine with a foothold and hanging leg holder with thigh. This is my preferred basic arrangement of the OT, where the surgeon stands and where is the endo unit, so there is unhindered visualization of the endo unit, and other instruments are on the reach of the surgeon. Tourniquet is placed high on the thigh and the patient is positioned to in a lithotomy operating table following the setting of the position. Superior and medial located AL portal is recommended. The AM portal is found along the medial border of the patella tendon and upper articular line of the medial meniscus. An additional AAM or additional anteromedial portal is formed at the level of the joint line, medial to the AM portal with transverse incision via interarticular guidance. So after diagnostic arthroscopy, if there is no doubt about the clinical condition, one can go directly for graft harvest. Here I am clearing the debris and the suprapatellar fat and the fat pad around the knee joint. There can be a variety of approaches, incision. When it comes to graft harvest, here is the endo unit, as we can see, the display up front at the top, camera, the shaver system, and other accessory equipments as needed. So after diagnostic arthroscopy, here is the basic arthroscopy, diagnostic arthroscopy. Okay, so when it comes to incision, here I am giving a horizontal incision. I have palpated the pes anzerinus. The incision goes deep to the subacute fat and the superficial fascia. I generally use a medicine bomb scissor and tooth forceps to clear the adhesions and open up the sartorial fascia. Here I am using a mixture forceps to just hold the semitendinosus, and I'll tag it. The gracilis in semitendinosus can be identified as 2 separate bumps over the sartorial fascia, and you can open up that fascia and tag either of those. The semitendinosus generally lies beneath the gracilis, and it's more of a harder structure, better palpated. After tagging the semitendinosus, I'll just clear the tendon of the adhesions with a finger. Usually I find 3 to 4 vinculi, one bigger at the at initial exposure, and 2-3 smaller ones when I'm going deep towards the adductor canal. A mixture forceps can separate and bring them out individually if needed out of the wound, and they can be tagged individually. Here I have separated the graft, the tendon, from the periosteum. I have stripped it off and I'm taking it out right now. The graft can now be cleared of all the muscle tissue attached. Here I am demonstrating both the gracilis and semitendinosus. They are being cleared off of the muscles. At least 28 to 30 centimeter of the graft length is needed to make it a quadrupled one. I'm halving both the lengths of the tendon, and I'll tie each of those ends in different positions by modified Krakow sutures. Both the sides. After quadrupling those and checking the size of the graft, I'll put it up on a tensioner and soak it up with an antibiotic soaked gauze piece. One of the most crucial steps is the femoral tunnel placement. The guide wire is inserted by maybe a freehand approach or by the use of offset guide like in this one. Usually I aim for the center of the footprint whenever possible, or we can go just posterior towards the posterior of the resident's ridge and more closer to the posterior border of the lateral condyle. 4.5 mm cannulated drill is passed over the guide wire. And we are using the cover of the spinal needle. The spinal needle cover acts like a sheath. I insert it there to avoid interference by fat and other soft tissues. And through that sheath only, I can insert the 4.5 mm drill bit. And through the same sheath, I'll further insert the depth gauge. The depth gauge is used to assess the length of the femoral tunnel, and I'll drill the femoral tunnel of appropriate length and thickness further on. Here I am looking for the depth, and it comes out to be around 38 to 40 mm. I'm using a closed loop endo button in this case. It's a suspensory femoral fixation and interference fixation at the tibial end. I'm clearing out the debris at regular interval after the drilling. Now the tibial tunnel can be placed by, here in this case is an elbow aimer, aiming towards the center of the tibial footprint in ACL. I'm trying to preserve as much of the stump as possible to make it a kind of remnant preserving ACL in this case. Guide wire is passed towards the center, and I'll pass the tibial drill carefully to not damage much of the stump. A beath pin is used now to pass the shuttle threads across the passage of the graft. And I'm clearing the joint of the tissue debris. Here is the beath pin with the shuttle threads. After flipping the endo button and graft passage, here is the graft and I'm passing it through. After flipping the endo button over the femoral end, I'll check for impingement and look if further clearance of the stump is needed to avoid a cyclops lesion. Checking for impingement. Looks good. After cyclic loading now, I am tying the loose ends of the graft to make it a single unit, and that knot now acts as an anchor and a foothold to the screw. So after fixing the screw, I know that none of my limbs is loosened or asymmetrical. I'm pulling up on the threads and the knot is still there, which acts as a marker. After screw fixation, the remaining sutures are cut and the guide wire is removed. I hope I have made justice to this short presentation, and thank you.
Thank you. Thank you, Harsh. It was a nice presentation. Now I think we are open for question and answers.
So I think this is a a wonderful small gathering where we can interact among ourselves. So if there are any question before Brajesh start his live surgery, so if anybody has got any difficulty while doing a straightforward ACL reconstruction regarding the femoral tunnel or the tibial tunnel, so I think this is the right time to ask any question regarding the primary ACL. Then we will have a panel discussion on ACL as well by the time Dr. Nagar Shetty will join us from Mumbai. So in the meantime, if anybody wants to ask any questions.
Sir, how do you judge the placement of femoral tunnel guide wire when the case is very old or you can hardly see the femoral footprint or any other structure, and sometimes the patient is around 40, 42 of the age and he is having ACL tear since long and there are osteophytes around that area, and it makes it difficult to judge the placement of the wire across the residence ridge, or there are some osteophytes at the posterior border of the lateral femoral condyle that makes it difficult. How do you judge the placement in that cases?
So Harsh, first thing would, what you need to do is just clear off all the osteophytes. And I usually use a curate to clear off all my lateral condyle. And I use the technique which I have given a name as a pilot hole technique basically. So I use a zig first, put the offset guide, make a pilot hole, and just don't drill that pilot hole. Go from the anteromedial portal and check its placement. So now you want to confirm whether your placement is correct or not. So in such cases, even the resident ridge is usually visible. If the resident ridge is not visible, you can draw an imaginary line. You can go to the posterolateral compartment. You see the top of the capsular reflection and the last end of the cartilage. So once you see the posterior end of the cartilage, if you draw an imaginary line, that would be a resident ridge. Yes. So one thing is for sure that you have to be below that resident ridge. And in maximum patients, in Indian patients, if you see the footprint is not more than 12. So if you're placing your pilot hole and if your graft is say around 9 millimeter, so if you see that pilot hole 4.5, you will go below, 4.5 you will go posterior, 4.5 anterior and 4.5 shallow.
Yes, sir.
So if you are keeping the 2 millimeter of safe margin both inferiorly as well as posteriorly, yes, that means you are probably in the center of your that footprint. So even if that footprint is not visible, that is a chronic case. So at least you are sure. The first principle would be not to blow out any of the margins and keep the 2 millimeter safe margins from the cartilage. If still you are able to do at least this thing, 99% time you will be in an anatomical position.
Yes, sir. Thank you.
Any other tips, Tanmay, for femoral tunnel drilling, anatomical femoral tunnel drilling?
Go through the AM portal and then watch it properly, whether the position of the wire is correct or not before you drill. That's the utmost important thing. I think you have almost said it. Yeah. That's very, very important, because if you miss it, you may have chance, and you have to, either you can do a hyperflexion at the hip as well, if you are comfortable with that. If you're using a leg holder, you can do that. If you're not, then maybe if you're in a TCAR position, try to do the hyperflexion of the hip and the knee as far as possible. So you get the correct oblique tunnel what you want.
And if you are making 3 portals, one is anteromedial and one is accessory anteromedial, then it also becomes very easy to judge the location of the femoral tunnel. And tunnel placement is very crucial for the successful outcome on the ACL reconstruction. Otherwise, either it doesn't give stability or the graft get tear.
Always check for the blowout as well. Once you are done with the drilling, once you complete the drilling fully with your 4.5 endo drill and with your reamer, do watch the tunnel thoroughly and check for anything, any soft tissue entanglement there, or because it may damage the graft as well at times when you're pushing the graft inside.
So there are only 4 methods by which you can do a femoral tunnel drilling. The first method is a offset guide. So even with the offset guide, just don't drill it completely. Just make a pilot hole and then just check whether you are drilling at a correct position. Second method is a freehand method, in which you will see the footprint. Look for the bifurcate ridge. Just posterior to the bifurcate, just make a freehand point. Again, go back into the anteromedial portal, check it. The third method is a ruler position, ruler method, in which you have to measure the footprint, and at the junction of 60-40, you have to make your You use a owl to make a point, and the fourth method which we rarely use is a radiographical method or a fluoroscopy method. So these are the four methods. So you should use either one of them or a combination of the two methods you can use for the femoral tunnel drilling.
Sir, one more question for you, sir. Sir, does the orientation of tibial tunnel relative to the medial cortex of the shaft makes any difference? We can make it more towards the midline, we can make it more away from the midline. Does it make any difference, sir?
It would make a difference. It would increase your probably a kind of a killer turn. So if you're more vertical, so you're going oblique in the femur, and if you're going vertical in the tibia, so the graft will go like this and it will suddenly turn like this. That is acceptable if you're going a transfacial reconstruction in pediatric patient where you have to be deliberately vertical because you don't want to go at an angle in the physis. But otherwise, a decent angle of 45 degree, I think, would be a better option. So it's going to be moderator for the live surgery.
Sir, I asked Dr. Rajiv Kelkar, sir, and Dr. Ankush Agrawal, sir, to moderate the live surgery. Sir, please. Thank you, Murtuja, sir. Are we live? Yes. But yes, sir, can you hear me?
Yes, sir. We are live, sir.
Sir, Dr. Rajiv Kelkar, sir, and Dr. Ankush Agrawal are moderator for this session.
Good morning.
Good morning. So we are harvesting the semi-T graft first. This is the semi-T graft. So
good morning, Brajesh sir.
good morning, very good morning. Knife, please. Isko. Yeah, pull. Very nice. So we take a cut, make a nick in the periosteum, and we try to harvest at approximately 1.5 to 2 centimeter of its insertion. So I elevating along with the periosteum, there are two advantages. We gain a good length, and we have some
Start the
osteoprogenitor cells in the
surgical
periosteum.
video. Just change this to surgical video.
Brajesh,
Yeah.
just hold on. Dr. Harsh is
I'm giving
Just giving the history, sir.
The history
Okay.
and brief description of
Sure,
the case.
sure.
He is a 27-year-old male having a left knee pain and medial joint tenderness since last 3 to 6 weeks. And he's had a history of trauma and fall from bike 6 months back, which was associated with swelling. He is a laborer with no comorbidities, with a 23.82 of BMI. A range of motion is unhindered. Laxity is grade 3 in both the anterior and latchments. And McMurray trace is positive for medial meniscus tear. Here is a MRI showing ACL tear and medial meniscus tear in the posterior horn. Live, sir.
Okay. So this is, we have harvested the semi-T graft. This looks good in length, approximately 29. So now we'll be harvesting the gracilis tendon. Okay. Please.
Sir, you always harvest both, or at times you only go away with a semi-T?
I always harvest both because I want almost at least 9 mm thickness. 8 mm is also fine, but if it is 9 mm, then I'm very happy. So I harvest both semi-T and gracilis.
Dr. Brajesh,
Yeah.
Tanmay this side.
Yeah,
Have you ever found that you're taking after both semi-T and gracilis
knife.
together as the graft, have you found any flexion deficit or delayed flexion in patients?
Never, never.
Okay, because there are studies who mention such kind of things.
I have
that-
never seen.
Okay.
Yeah. And we are doing it since years. So we have our good own experience. Okay, fine. Artery. Artery. I always put a artery in the tail because at times you can slip this gracilis tendon especially. So, Satish, it is really important when you are handing over the graft to your assistant, because at times the graft can fall down on the ground if you are not seeing towards the assistant. Table height thoda sa up. So now I'm making the first portal, that is the anterolateral portal. I try to make this anterolateral portal slightly superior. Okay. So my scope is in, it is in the suprapatellar pouch.
So the advantage of making a high anterolateral portal is that would give you a bird's eye view. So this is a basic principle in arthroscopy. If your portal is high, whether it's a shoulder, knee or any, even if you're making a posteromedial portal, you will have a better visualization if you are having a high anterolateral portal. And the second advantage is you will avoid that fat pad, because fat pad is something like a pear shape. So the fat is more dense once you go low, and it would be less dense once you go at a higher position. So high anterolateral portal, what Brajesh is explaining, is the correct portal. If you see the standard textbook, they don't describe a high anterolateral or a tight portal. They will usually describe the portal which is 1 centimeter above the joint line and 1 centimeter lateral. So in that situation, if you follow that principle, it will be directly into the fat pad. So high anterolateral portal as close to patellar tendon as possible will give you a better visualization, and it will avoid the fat pad as well.
Okay, so I have gone through the lateral gutter. This is the lateral patellar facet, what we have discussed just now. Middle patellar facets looks quite okay. Trochlean notch, okay. No cartilage damage, nothing. I am the middle gutter. Peripheral part of the middle meniscus looks quite okay. 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 So from here I am the intercondylar notch. This is the ligamentum mucosum which is there on the top. Figure 4. So this is the lateral meniscus, popliteus. Looks quite okay. We'll probe it and we'll see it. Okay, so the peripheral part of the lateral meniscocapsular junction looks okay. Dr. Sheetal, your zone.
Yes.
Okay, needle. So now I'll be making the portal. See here, this ligamentum mucosum is quite thick, and there's almost a complete bursal curtain. So at times we can see this kind of bursal curtain. Initially this can give you trouble in first few cases. Okay, needle. So now this portal will be slightly inferior as compared to my anterolateral portal. This will come just above the medial meniscus. Okay, this, and will be going towards the intercondylar notch. I'll see whether I'll be able to reach till the ACL femoral attachment point. So I'm reaching well. Fine. Knife. सेवा हैंड कौन सा वाला है, लेफ्ट राइट है, ठीक है. Okay, the first thing what I'll do, I'll remove this bursal curtain. Oscillation कौन सा, बीच वाला oscillation है, oscillation कौन सा है, लेफ्ट राइट,
The
Sir, oscillation
down
bottom
one,
bar,
down
down.
one.
यहाँ से it is on the forward and reverse mode only. Oscillation देखना अगर वहाँ से
Oscillation, Brajesh, is the third button. That
Third
is the
button,
lower
sir,
one
down.
is the oscillation.
नहीं, that is not working here.
Acha.
Anyway, suction.
Foot switch.
So एक बार देखना अगर ऑसिलेशन हो जाए तो प्लीज. वहां से शायद आपके कंसोल से प्रॉब्लम होगा. So I'll remove this little bit of the fat pad which is coming in my way, because the first thing in the scopy is a good visualization. It is important to maintain a safe distance from the tip of our camera, means arthroscope tip, and the shaver, because otherwise we might damage the lens. Yeah. Okay. Fine. Left. बस ऑसिलेटिंग मोड के लिए दीजिए. थैंक यू डियर, थैंक यू. कनेक्ट नहीं हुआ. प्रोब. आराम से. इसका स्पीड बहुत कम हो गया है डियर. देखिए. प्रोब रेडी रखना. ओके, सो मीनवाइल मुझे प्रोब दे दीजिए. आप उसको कर लीजिए, मुझे प्रोब दीजिए. ओके, सो टेबल की हाइट थोड़ा सा बढ़ेंगे. So there is a complete tear of the femoral attachment of the ACL. See, this is the femoral attachment of the ACL, and the fibers are completely torn. Fine.
Yeah, Dr. Brajesh?
Yeah.
Do you ever repair this femoral avulsion of the ACL tear?
Yes, definitely. If the patient comes well within the time, see, for me, the cutoff limit is 3 weeks. If patients come within 3 weeks, and if he is a patient who is quite, who can understand that there might be possibility of the second stage surgery if it fails, then definitely I go for repair, and I have good experiences. Figure of 4. So now the next thing is we'll probe the meniscus. Clean करिए, clean. थोड़ा सा इसको बढ़ा देंगे प्रेशर को. So the meniscus, lateral meniscus root is fine. See, under surface is fine, superior surface is fine, the popliteus is good. Okay, so all good on the lateral compartment. All good in this peripheral part. Okay. सीधा कर लो, straight, पकड़िए. Now I'll go in the middle compartment to check the integrity of the medial meniscus. छोड़िए, सत्यमा. अलग कर दीजिए, इससे नीचे कर दीजिए.
I think these two menu are very important for lateral meniscus. You to go for a figure of 4 along with the internal rotation of the foot.
Yes.
That's why you were able to see what Brajesh has shown so beautifully, the popliteus, top of the lateral meniscus in the bottom. And for the medial meniscus, you to go for a valgus, little bit of 10 to 20 degree of flexion and external rotation.
Okay, so here in the medial meniscus, we can see a longitudinal tear at the meniscocapsular junction. These are the good tear to repair. We can,
What is your preferred choice of meniscus repair in this region?
I personally prefer doing inside out, because I think that gives me better stability, good hold. So my preferred is the inside out. Okay.
So I welcome Dr. Nagaraj Shetty from Mumbai. He has just joined. Brajesh, so Nagaraj is also here.
Good morning, Nagaraj.
Hi, Brajesh.
Hi, good morning. So this seems to be a big peripheral longitudinal tear. Okay, so we'll repair it. Fine. Okay. Or valgus? Meniscus root, medial meniscus root looks quite okay. Fine. पकड़िए इसको धीरे धीरे करके मोड़ो. So I have entered in the posterior medial compartment as we have just seen in the diagnostic round. Needle please. This is really very important because in almost 15 to 20% cases we see the ramp tear irrespective of the chronicity. Is previously it was thought that it is there in the chronic tears only, but what we have seen even in the fresh tear, significant number of the fresh tear, we see. Now I'll move the scope down. थोड़ा सा हल्का सा. Okay. Okay. So this is the area of the ramp. Okay. So here in this case it is quite intact. So we need to hook it with the needle and pull it, push it like this. Then only we can appreciate. Otherwise, just by seeing we can miss it. So this region is fine. Okay. So now first we'll concentrate on the ACL femoral tunnel. Curate.
Rajesh, you are planning a meniscus repair?
Yeah, definitely I'll buy meniscus.
What kind? I mean, all inside or an inside?
I'll have to see. As I have told, for these kind of cases, I personally prefer the inside out because I think they give me better stability. But I think here I'll be doing all inside with fast fix.
Okay, and do you do your repairs first or the ACL tunnels first?
See, what I do, I make femoral tunnel, then I make the tibial tunnel, I put a plug in the tibial tunnel, and then I go for the meniscus repair. If anyhow, if plug is not available, then yeah, we can go for the femoral tunnel first, because see, after, for making the femoral tunnel, I need to put my knee in hyperflexion.
Exactly,
so
that's
at
the point I wanted
times
to focus, yeah.
that can damage my repair. So I want to finish my hyperflexion job first. So I'll make my femoral tunnel and then I'll go for the meniscus repair, or here if I can get the tunnel blocker, I'll do the tibial tunnel and then I'll go for it.
So Brajesh, what we will do, we'll first focus on ACL, which is our primary aim.
Okay, fine.
So I think better to show the anatomy of the femoral attachment of the ACL followed by tibial, and if the time permits, we will show the meniscus repair.
Sure, sure.
Okay, right.
So this is important to clean the intracondylar notch. These all the debris. See, here I can see the posterior wall of the intracondylar notch. And this is the anatomical attachment of the ACL. So this is somewhere, it is the residence ridge. And this is the bifurcate ridge. This will be better visualized from the intermedial portal. Now I'll clean some remnants of the ACL, because just the one which is required for me, the visualization and good graft passes. Okay. Okay, fine. Size 9. Okay, so it is approximately, it is size 9 of the ACL graft. I always prefer doing a aimer. So this is the transportal aimer what I am using. So first what I do, I make a entry just at the a pilot hole just at the 90 degree of knee flexion, and then I hyperflex and go behind. Wait. Perfect, go. Bas. So this is hard 8 to 10 millimeter hole. I'll use the dilator है क्या? Owl है? नहीं है? ठीक है, okay, fine. दीजिए, गाइड वायर ये दीजिए, बीच में दे दीजिए, नीचे वो है क्या, कैनुला, ला, वेट वेट, खोल दीजिए इसको. I always put a cannula over this. Okay, this is a cannula of the 18 number spinal needle, so that I am very safe that I am not go पकड़ो, hyperflex कर लो, आजा, आप आ जाओ सत्यम उस तरफ, आइए, hyperflex. So now at this point I will थोड़ा सा कैनुला पीछे करिए प्लीज, कैनुला को हल्का सा पीछे करिए कुणाल, बस जेंटली. ओके, फ्लेक्स फ्लेक्स फ्लेक्स. प्रेशर देखेंगे पानी का क्या प्लीज, प्लीज. एक बार देखिए, एक ओपन कर दीजिए इसको, यहां से बंद है. ओके फाइन फाइन. बेटा कर्स दे दीजिए, बढ़ा दीजिए इसको, बस बस बस, परफेक्ट. इस तरफ आए, ओपन, पकड़िए. Okay, so that is the guide wire I have placed over the anatomical footprint region. This is the cannula from the spinal needle. This will protect any damage to the cartilage over the lateral femoral condyle. 4.5 drill. Okay. Okay, fine. Okay. सतीश इसको पीछे करो कैनुला को बेटा. So now we go slowly to see what is the bus 26, 28, this is 30, 32, 34. Okay, fine. So this takes around 35. Can push kariye please aap aage?
I think somewhere between 32, 34, 35 indicate
Yeah,
that
it is
your
34,
anatomical position.
Yeah.
Dr. Nagaraj, what tunnel length would you take it as a caution that suppose that the 4.5 drilling has come around 26 or 28? Would you like to change your plan or?
So I think that's a great question, and that is quite possible if you are having a shallow tunnel. As Brajesh is demonstrating, unless you hyperflex at the hip and the knee, you cannot get an oblique tunnel. So if you are horizontal and deep, then you might land up having a short tunnel. Now there is a risk of
40, 38,
more than the length of the
36.
tunnel, the
So
understanding
this is 35.
Yeah.
Okay, fine.
More than the length of the tunnel, the understanding that you are too shallow and
Let
that you are too horizontal, the risk of blowout, I think that is very important to understand. If that
Okay.
is the case, you have to change and become more oblique and
9 mm graft.
So I think a hyperflexion gives that advantage that the length of the tunnel is
absolutely.
So now at this point, I confirm, see, this is my 4.5 hole for the ACL tibial tunnel. So I think I am in a good position.
The only thing, Brijesh, which I would want to discuss.
Yeah.
You have put your scope in the medial portal now after having committed to
Yeah.
that particular trajectory and to that point.
Yeah.
Do you agree that sometimes visualization from the medial portal can give you a completely different picture than what?
Yeah. See, I personally always use the offset guide now. So in cases where I am not using offset guide, if I am just eyeballing, then definitely I'll make a small hole, then I'll enter in the middle compartment, then again, if needs, I can be corrected. But if I'm using offset guide, then I know I'm in a good position.
I think making a pilot hole first and then checking
Yeah.
sign. So this looks a perfect tunnel, Brijesh. You can go ahead with, what is your graft diameter and what is the fixation that you're planning on the femoral
Graft
side?
diameter is 9 mm, it is
Yeah,
9
that's
into
good.
31 mm graft.
And what is the fixation that you're planning for the femoral side?
On the femoral side, it is a ultra button adjustable loop. Okay, and on the tibial side, preferably it is the biaso resinous of screw. Okay, now 9 mm. So now at this point, I go in with the, see this 9 mm reamer. So I go with a free hand because at times what we have seen, we might create iatrogenic damage to the lateral femoral condyle. So I'm coming with the hand, see this in the slight extension. So now I'm sure I am not damaging the lateral femoral condyle cartilage. Then I'll turn my reamer and the intercondylar notch, and now through this, I'll pass the bead pin, okay, it's guide wire here, डालिए, flex, hyperflex, gote, okay. आ गया? पीछे, और, लेते जाओ. Okay, fine. So I think the graft length is 31 millimeter. So I'll drill my tunnel. I'm planning to put almost 17 to 18 mm graft in the femoral tunnel. I'll keep 3 mm space extra, so I'll drill to 21 mm so that if any adjustment is required, I can do afterward. Okay. थोड़ा सा pressure, please. इसको ऑन करिए पानी को, इसको सलाइन को ऑन करिए, उसको बंद कर दीजिए. Perfect, fine. Clean, please. Okay, fine. Spinal riddle दे देख. Clean. Pressure, please. एक सेकंड, spinal riddle. पकड़िए. इस तरफ से पकड़िए सतीश. Okay, पकड़िए. Okay, so there is a lot of debris. We need to clear it because. Fine. Spinal riddle देख. हटाओ इस. पीछे उसको पकड़िए. ओके, पकड़. ओके, क्लीन. मैं पकड़ा हूँ, इसको क्लीन कर दीजिए. हो गया बेटा, बस. परफेक्ट. लो स्पाइन रिडल तो फिर से. पकड़िए.
Just ask somebody to give pressure from hand on the saline bottle. I think they are not giving proper pressure.
प्रेशर पंप से करोगे ना, बहुत अच्छा. So, इसको खोलिए, कैनुला निकालिए. निकला है? Okay, so what we can do, I put a spinal needle. This acts like a small cannula. We can clean it also and we can see. So this will allow some. Okay, fine.
So I think the Brajesh is doing a very good trick. So when everything is clear, you will be able to see the marking of your 9 mm tunnel. Otherwise, if you're not seeing properly, there is chances that you may blow out the lateral cortex.
Pressure pump से नहीं आ रहा क्या?
Sir, at times is it better to use a 3-portal technique here?
Yeah, I usually prefer, you can put a cannula, a small cannula from the third portal. So
Okay. So this is बेटा प्रेशर थोड़ा बता रहा हूँ बेटा भैया हाथ से कर दीजिए हाथ से करिए ये स्पाइनल लिटरली ब्लॉक्ड है चलो जाओ so at the end we can ream by the hand so that we will have a very good control इसका ट्रोकार दे दीजिए स्पाइनल लिटरल का जाओ ना बेटा आगे गो जाइए सतीश ओके क्या हुआ इससे बताए छोड़ कर दे टाइट करिए इसको टाइट करिए बेटा पहले प्रेशर रिलीज करें उसका अच्छा हो गया छोड़ बेटा ड्रिल चेंज करो टाइट नहीं हो रहा इसका कोई दूसरा तरीका है क्या करने का कुणाल आप करिए
Dr. Nagaraj, what would be your preferred graft length that would you like to keep
Kunal
minimum
को
on the
करने दो
femoral
बेटा।
side?
So traditionally we say 15 millimeters, but there's a very good Japanese study which basically says that frankly it doesn't matter. Even in their study, a big percentage statistically significant cases, even 10 mm which
Gotcha.
remained
Sure.
had adequate amount of stability. So take home message is it's the
Confirm
healing
करो
of the
पानी आ रहा है कि
Sharpie's
नहीं यार
fibers on
सतीश
the mouth
कंफर्म
of the
करिए
tunnel rather than the amount
Absolutely.
which is there inside.
So even if you
इसको
keep
पकड़ो मैं
25
कंफर्म
for
करता हूँ बेटा
15, it doesn't matter.
Yes,
basically.
yes.
So preserving more collagen on the tibial side would matter much because filling whole of the tibial tunnel
अच्छा।
because you want to put a screw particulate on the tibial side.
इसमें कैनुला नहीं डाले
The
टनल
screw
में
is
इसको
going
क्लीन
to
कर
have a
दे
good
बेटा
hold
कैनुला
if you
डाल
put a
के
graft till the end of the tunnel.
Absolutely.
डाल
And
के फिर
more
निकाल
often than
दीजिए।
not, we know that the common tear
पूरा डाल
patterns
के
are
निकाल
mid
दीजिए।
substance ruptures
निकाल
or
दो।
femoral sided avulsions.
बस बस बस
So if you preserve the tibial sided
हाँ, पढ़े
fibers
हुए।
for proprioception, it also guides you in the orientation of that particular patient's ACL anatomy. So preserving the remnant, we always forget that it tells us what is the orientation of that patient. So if it's more horizontal, more oblique, trying to come
पकड़िए,
in
पकड़िए।
an eccentric manner and then matching it to the
Perfect.
remnant, all that it helps you.
So sometimes there is a situation in which the tibial footprint is
20.
quite
Okay.
anterior and it's almost
निकाल दीजिए।
overlapping the medial tibial
एला
condyle.
उसको टनल
And if
निकाल
you try
दीजिए
to mimic that, the tibial tunnel is quite short.
So we
If
have
you try
drilled
to put the screw is
20
sometime
millimeter
into the
deep
joint.
tunnel.
So what's your
So I think
Okay.
the
खोलिए।
biggest drawback
So
of
these कहाँ
our
हैं?
training in
Okay.
arthroscopy is that we do everything in 90-degree
Okay.
flexion. We forget that
Satish,
we
हो
have
गया
to
बेटा ग्राफ?
extend and make sure what is the anatomy of that patient, whether the intermeniscal ligament is covering up that tibial plateau.
Sure.
So extend constantly when you're doing the tibial tunnel.
Fine.
In
So-
every step you have to extend.
So
Okay,
this is
straight.
absolutely right point by Dr. Nagaraj. So if you
Shiva.
see, sometimes you feel that your tunnel is quite medial and anterior, but if you do the extension, then you will see surprisingly that your tunnel was not medial, it was actually in the center. So always keep on, use the sequential draining, 6 mm, 7, 8 mm, and just keep on checking in extension.
In fact, Sheetal, if you might remember, there was a time when we were actually visualizing from the medial portal even for the tibial tunnel.
Yeah, absolutely.
And putting the jig from the other side. So the entire idea is arthroscopy can be very confusing, giving you a two-dimensional image. So you have to make sure that you get a three-dimensional orientation by changing portals and changing the knee position.
So I think the flexibility of portal is the key for all arthroscopic procedure.
Okay, so this is how I have drilled my femoral tunnel. I'll show you through the anteromedial portal. Okay, so is it fine for all?
Perfect. British, I would label as a book picture for the perfect anatomical
thank you.
femoral tunnel.
Okay. So now we'll go ahead for, okay, suture passer. Suture passer ready kya?
So as far as
Satish, suture passer.
Sheetal and Nagaraj, I would ask, as far as remnant is concerned, what's your threshold for keeping the remnant? Because at times there are lumps, there's a clumping of the ACL tibial stump. So do you keep it really, or you remove the stump, or if there are only the fresh fibers which is oriented towards the ligament, the natural ligament, then those only you keep, or you keep the stump as well,
Right.
because there are chances of developing a
Wait,
cyclops
wait.
later on as well. So what's the, I mean, can you just explain the
delegates.
Hyperflex, please.
So great question, Tanmay, again.
So this is, I'm
in
passing
the
my
process
bead
of
pin.
remnant preservation, if I am not getting my
Okay.
anatomical tunnel right, I
Nikalo.
will not keep it. I'll clear it. If in the process of remnant preservation, I have as you mentioned, a remnant that has fallen off and likely to cause a cyclops lesion, I'm going to trim it off. So more often than not, remnant preservation for me is those fibers which are still, attached to the PCL or going to the roof of the notch and helping me with the orientation. I do not do the Samba technique as much, wherein you try to preserve everything and try to imagine where the tunnel is coming and trying to preserve everything, and suddenly you realize you're non-anatomical. I don't try to do that as much.
Shiver.
Over the years,
And
you realize that. So like in this case also, you see some fibers which are going towards the PCL, that we make sure that it helps us in the orientation. So I think true remnant preservation or bundle preservation concept is for those rare cases where there's a full bundle intact. And that's very
more of a
uncommon.
Sherman's type 1, type 2,
Yes.
and you're going almost at 4 weeks or 5 weeks after the trauma.
Yes.
So then to prevent that cyclop, what you can do, you can either tie this thing using a suture with the remnant with the your new reconstructed ACL, or I usually put one anchor now, and with that anchor I tie the remnant, and at the same time I put my graft. So it's a more of a repair, augmentation and reconstruction, the combination of 2 or 3 things. Also, but I think the best thing that Nagaraj was pointing out was absolutely correct. Don't compromise on anatomy. Even if you have to remove everything, that is absolutely fine, because the plastic deformation has already happened. So that ACL has already undergone trauma. You're not sure how much that is functional. So even if you see it down the line 2 months, patient has got a ACL rupture, and you are seeing the remnant, but still patient got some cartilage of the meniscus damage. That means probably that remnant was not functioning. So pivot is still there. So if patient is having pivot, that means that remnant was not working. So there is no point preserving that kind of remnant and compromising on anatomy.
Correct. And I think the importance of diagnostic round, finding out what is the type of remnant we have, whether it's a Sherman type 1, whether it's a remnant like we talked about only attached to the PCL, and then formulating a plan for that patient becomes very critical. So if you want to do a true remnant preservation, frankly, you can't put a quadruple semity. It could be a double semity in the best case scenario. And you should be really confident of that remnant, and as Sheetal mentioned, you need to make sure that there is a scaffold for the new graft. So it is anchored somewhere, either on the condyle, or sometimes you can take a loop stitch through the graft, load it onto the button, so it gives you the scaffold for your graft. So you need to individualize to that particular case.
Go.
Absolutely, absolutely.
Perfect.
Cyclops lesion formation is a very big risk factor.
Perfect.
And the worst part is after remnant, if you see in many of the cases we see
Straight
the whole
artery.
of the
Straight artery.
at the end of the surgery, everything is clumped up, and if you do the extension, there is no cyclose, but there is an impingement everywhere, lateral impingement, medial impingement. So then finally you have to use a radio frequency to debulk that thing. So I think there is no point preserving such a
Okay, so I have drilled my guide wire for the tibial tunnel. Okay.
And Rajesh, you use this elbow hammer or a tip hammer?
Tip hammer. So.
And would you just point out some tips for the delegates where exactly you want to put your tibial?
So it should, see here, this is the anterior horn of the lateral meniscus. Okay, posterior margin of anterior horn of the lateral meniscus. The guide wire tips should just exit in this level. So if you can appreciate, this is the line of posterior border of the anterior horn. This and this is somewhere in between the ACL substance. Okay.
Yeah.
Okay. Go. I always protect it with the curate because while reaming, our reamer might come. Okay, slow. 6 mm. Okay, fine. So I always ream it first with a 6 mm reamer. So if I want to shift it 1 or 2 mm medially, posteriorly or laterally, I can do that kind of adjustment. Guide wire, please. Artery.
Your curate is beautiful, Brajesh. Vinay has given you, or you bought by yourself?
This is my curate.
Okay.
Okay, artery, please. Badi artery dijiye. Kunal?
Sir, one question for Nagaraj sir. Sir, for those Sherman type 1 ACL tears, when you, as you said, you will double that semity and insert it. So what will be the ideal thickness of that semity intended?
So let me get the concept right here.
Sure.
If you have a full remnant, like you mentioned, Sherman type 1, it's very rare. It's very rare to do that. So a double semity typically would be around 7 mm or so.
7 mm.
7 mm or so. So the minute you are 8.5, you are going to take out the normal remnant.
See, now if I want to shift my tunnel slide posteriorly, medially, laterally, or anteriorly, so I have some modularity over here because of I drilled with the 6 mm tunnel first. Okay. Go.
This is a very good trick he is showing, and this is an important point to understand because the all inside ACL concept, wherein you come with a retro reamer, you are committed with the initial point itself, and you ream directly to the final diameter.
Perfect. Like, shaver please. Nikaliye. Okay, so it is important to shape the mouth of the tunnel because our healing of the graft is going to take in this mouth region. So we need to clear this mouth properly. Here, posteriorly, medially, some anterior part. Grasper now, please. It is important to protect the attachment of anterior horn of the lateral meniscus. If we are not careful, if we are keeping our tunnel laterally, then at times we might damage this meniscus attachment. So now I'll pull this relay passing suture from the tibial tunnel. Open नहीं हो रहा भैया ये. Open. इसको open करिए please. Okay, fine. Okay, so this is my relay suture for the ACL graft. This is the tibial tunnel, femoral tunnel. Okay. The next thing I'll be doing to clean my tibial tunnel mouth. Pakadiye, light.
Brajesh.
Yeah.
I think we need to proceed with our scientific program. It's really wonderful watching you to just pass the graph and do meniscus repair.
Okay.
So what you can do, you can record the things.
Okay.
And maybe later on, once we get the time, we can see the recording of your meniscus repair and the final ACL reconstruction.
Fine.
Because we need to proceed for your for the scientific program.
Sure.
We would love to watch your whole of the surgery, but because of the time constraint, an excellent demonstration, Brajesh.
That was an excellent demonstration,
lot
sir.
of applause to you. And any questions before Brajesh signs off? Any question to Brajesh? What are you planning fixation onto the tibial side, Brajesh?
Tibial side, it is a Regenisov screw, Biosure Regenisov, that is 1030.
1030.
Yeah, our
so
graft is.
The size 30 depends on your length of the tunnel, or in general you prefer to put.
See, for males of at least 5'4" height, I prefer 30. Short-heighted females or the persons with the males with height less than 5'3", I prefer 25 or 28 mm.
Okay, and where would you put your screw? Posteromedial, anterolateral, posterolateral?
It is the posterolateral part. So before passing my graft, I'll make a small trough in the posterolateral part so that I can, and I'll pass the guide wire, and preferably in the posterolateral part of the tunnel.
Using your magical curate, right?
Yes. Right.
Okay, fine. Thank you, Brajesh.
Thank you.
I request Dr. Vinay sir to present his case on ACL and LEAT. Sir. Yeah.
Good morning. It is a small presentation regarding the surgical technique of lateral extra-articular tenodesis. We all know that the ACL reconstructed graft restores the normal biomechanics, but sometimes this stability is decreased, and there are several factors which are responsible for the instability in spite of the ACL reconstruction. The important thing, the patients who are at high risk after ACL reconstruction only are the patients who are relatively younger, and they want to return to their contact sports, especially the pivot sports. High-grade anterolateral rotatory instability, in which we see the pivot shift, an explosive pivot of grade 2 or higher. Generalized ligamentous laxity, and the knee hyperextension or the recoverbatum greater than 10 degree. So in these cases, we need to reconstruct or do the lateral extra-articular tenodesis in primary cases. At least I prefer to do it in these patients primarily. Otherwise, in the revision scenario, I also always try to do LET along with the ACL revision ACL reconstruction. So we give an incision on the lateral aspect of the knee, extending from the Gardis tubercle medially. And this is a technique in which we can do lateral extra-articular tenodesis without any implant. So we strip off 1 centimeter wide iliotibial band, approximately 8 to 10 centimeter in the length, and then this is Craco sutures are fixed on the end, and this is passed beneath the flexor FCL ligament and rerouted from the intramuscular septum on the lateral side, and it is then reattached onto itself. So this is a technique in which we do the LET without using any implant, only sutures, and then the iliotibial band is closed. Another thing in which we do the LET and fix it in anatomical position. This is a small surgical video. You can see the Gardis tubercle, and this is the lateral epicondyle. Here is the fibular head. There is a fibular collateral ligament. Approximately 7 to 8 centimeter long incision is given. This is done after the ACL tunnels are made and the suture is passed through which the tunnels. And before passing the ACL graft, we always drill the tunnel for the lateral extra-articular tenodesis, so that we can avoid the tunnel convergence or damaging our graft. So first the iliotibial band is nicely separated from the subcutaneous tissue, and then we identify the whole of the iliotibial band. Some people also prefer to take the posterior strip or the posterior 1 centimeter of the iliotibial band. In that case, you can avoid the step of reclosure or the of the iliotibial band. So here I take the central 1 centimeter of the iliotibial band, and this strip is approximately 8 to 10 centimeter long. With number 15 knife, I take 1 centimeter wide iliotibial band strip and 8 centimeter long proximally. We can just extend it without increasing the size of incision. You can size it also. Then you take sutures on the end of the graft. It is attached on Gardis tubercle on distally, and medially we will reroute it from the lateral collateral ligament under surface. Now with the help of this mixer forceps, we identify the lateral collateral ligament, and we pass our graft beneath it. And proximally, near the lateral epicondyle, proximally and anteriorly, it is attached and inserted into the a tunnel which is made, and tenodesis is done. So this is the graft is being passed. And the proximally and little anterior to the lateral epicondyle, we'll fix it. And while passing this guide wire, we also check it from the anteromedial portal into the femoral tunnel which is made for the ACL. The graft is not, the wire is not passing through the tunnel. And once the tunnel is made, according to the size of graft, is usually the 6 millimeter wide. First we pass the ACL, and then we fix the ACL first. I usually take this interference screw on the tibial side for the ACL fixation, and fix button, endo button CL Ultra on the femoral side. And then this graft is passed through the tunnel, and it is fixed with the help of tenorizing screw onto the anterolateral aspect of the distal femur in approximately 30 of knee flexion and neutral rotation of the tibia. And this is a very simple way. Just you have to take one point in mind, that the tunnel should not hit each other. Other options like staples or suture anchors can be used for the fixation also. Thank you. Yeah, you have to. Yeah, the tunnel should starts little anterior, and the direction should be anterior and proximally.
I would like to invite Dr. Nagaraj Shetty sir to present the second case, ACL with central quad tendon graft.
Already.
So this is a small presentation that I had done in last year's Pune knee course. So the title given was that time quad tendon graft, why, how and when. So it typically covers up a situation where you need to use a quad tendon graft, what are the tips and tricks that I have gained over the years, and what are the advantages specifically. So that's my profile. I practice in Mumbai. So that's how the logo comes from. So I think all of us have very clearly understood the importance of being active in life, and that's how our patients come to us to make sure that they continue to remain active. Now, quad tendon graft is not something new. This has been there since the early 90s. John Fulkerson has been using quad tendon graft as his only source of graft since the early 90s. And these are all dissections from his articles and his publications. So the average length of the quad tendon is about 7 to 8 centimeters. Now there are some techniques of our colleagues where they have taken the full length of the quad and you're getting a big strip, but that's actually a strip, that's actually the fascia which extends. The tendon proper is only about 7 to 8 centimeters. Average it's only about 7 mm thick. So if you typically take a 10 mm blade and dip it through, it is usually going to be a full thickness in quite a few patients. Very uncommonly it would be a partial thickness. And more often than not, we usually get an average length of about 7 centimeters in an average built adult. It has been well described like I just told you, and in my practice from about 5% of my grafts being quad tendon, today it is touching almost about 25 to 30%, and I'll tell you why. As you can see on the right hand side, there's a nice image of a very thick, nice quad tendon robust graft. So there are some specific indications for this which I'll share with you. Early biomechanical studies have said that it is favorable and almost comparing to a bone tendon bone graft in terms of load to failure, in terms of its lower elastic modulus. As you can very well see, in the bone tendon bone, we are all happy with the bone component, but we are very unhappy with the tendon component. It becomes so flimsy. So you have created a big 10 mm tunnel, but your tendon portion is actually literally floating in the graft, so in the joint. So that part has always been a bit unconvincing to us. Quad tendon has got a unique advantage because it's got thick collagen. It has got the advantage of you taking a bone plug also. So best of both worlds. You're filling up the tunnel with a thick collagen and you can take a bone plug as and when indicated. So that's how typically a thick quad tendon graft appears, and it is extremely satisfactory. We are following up our patients for the last about 3 to 4 years now and seeing good outcomes. So as I told you, John Fulkerson has been showing this over the years. Initially, we also used to use a fixed loop. Even today, you can very well use this. Smith & Nephew has got this EndoCL, which is multi-utility. So you can take these whip stitches in the proximal part of the graft and literally suture those ends of it to the fixed loop and use it like a regular graft. They are going to be coming out with dedicated adjustable loop, and that is already there in the market from some other companies, and therefore you have multiple options now to fix this graft on the femur. So in summary, what are the advantages? It's 3 times more collagen than a patellar tendon. Your length and volume is predictable. Trust me, even if you take a full thickness, the morbidity is not as high as conceptually we would imagine that taking it from the quadriceps will weaken the quads. And it has got comparable and almost superior outcomes to the bone tendon bone and the hamstrings. As our experience has increased, as better instrumentation has come, we are literally taking as small as 1.5 to 2 centimeter grafts. I'll show you that I actually go longitudinally along the axis of the limb and not transverse as some surgeons have described, because if you take that with the knee range of motion, your scar actually reduces over a period of time. Not that we target a small scar, but with experience we can actually make it as small as a hamstring retrieval graft size. Advantages, like I just told you, you get a good soft tissue length of almost 7 to 8 centimeters. If you can always add a 20 millimeter bone along with it to get the advantages of bone plug also. Many systematic reviews have shown that this has got an excellent outcome. So it's been there for a while. This is how we used to do it previously. This is the left limb. Point out the patella, point out the VMO, point out the vastus lateralis, and as I told you, a vertical incision focused over the superior pole of patella. You need to understand that the tendon proper is in the lateral part of the patella. It's not exactly in the center. That is first thing you need to understand, and just make sure that your incision goes a bit laterally there. I've taken a bigger incision for purpose of demonstration here. You do the dissection, identify the paratenon, incise the paratenon, preserve the paratenon. Over your repair, if you have able to suture the paratenon, there is excellent healing. So that's how you preserve the paratenon. Use a sponge and create a plane now between the subcutaneous tissue and the tendon proper. So you can see a beautiful tendon there. Now you identify the vastus medialis obliquus. Is there a pointer? On the or press kaun sa karna hai? Ye wala. Haan. So you can see this is the left limb. These are the vastus medialis obliquus fibers. So keep a 5 millimeter bridge from there and identify the medial incision. And from there, either a 9 mm or a 10 mm length, you can plan your tendon graft. So VMO, identify the VMO, keep a 5 millimeter bridge. I use a marking pen. And then you can use these special dedicated double bladed handles. This is a 9 mm handle. And now before doing this, you have to identify the direction of the tendon. So you can put a scope here and identify where the tendon is headed. Your assistant can put a big right angle retractor and lift it up. You can actually put your head down, visualize the direction of the tendon and then direct it in that direction. You then take a 10 mm blade to finalize that incision. So that's the 10 mm blade to finalize the incision. If it becomes full thickness at this point of time, you don't need to worry. Your 10 mm blade anterior-posterior is 7 mm. So if you dip so much, you usually land up getting a full thickness. Then take a 15 number blade and detach it from the patella. Before doing this, I always check the length of the tendon which is likely to get. So if it's about 70 mm, I don't bother. If it's shorter than that, then I would immediately go for a bone plug. So that's the detachment of the tendon from the patella side. This end becomes quite bulky sometimes, so you need to trim it before you take your retaining sutures. So you can take retaining sutures, you've got commercial devices, you can take a simple ethibond, or you've got commercial devices which work like a loop. Nowadays we are using the loop. You then take an osteotome to finalize the plane. So that's the finalization of the plane. And then you've got this dedicated cigar cutters which has got measurement also, pointed into the direction of the tendon. and then you finalize your cut. So very low profile graft retrieval. So that's your thick quad tendon graft. You can do a robust soft tissue closure. Trust me, with practice, you will not have a single drop of saline coming out from this wound. You'll get a robust closure. You've got dedicated devices wherein an adjustable loop can be loaded on. And this is how it looks at the preparation way. So the concept is it's a flat tendon. Unlike what you saw in the morning with Dr. Brijesh, when you take a soft tissue graft, you can loop it around a endo button, but when you have a flat tendon, you need something like a tape over which you suture an adjustable loop. So that's the whip stitching of the sutures over the tape, and that's how it will be whip stitched. So from distal to proximal and then proximal to distal, and you will get a nice thick graft like this. Typically the length, as I told you, is about 7 centimeters. Typical diameter would be upward of 9.5 to 10 mm. So all criterion which is required is satisfied. So the advantages of this adjustable loop is that even after the tibial fixation, you can retension the graft. So tibial fixation has been done and then you can retension the graft. So if you find that any laxity is there in your construct, you can retension your graft. So that's how a good thick quad tendon graft looks like. Now, what are the indications for this? I think that is something which all of you would be interested to know, because if your hamstring grafts are doing well, why do you need to do? So what do you do when you have a high BMI, somebody like this? Previously, we used to consider this as a contraindication for ACL surgery. Somebody with a high BMI of around 35 or so. Even today, somebody with 40 plus 42 is a contraindication. But somebody of a high BMI around 35, we are never confident of the hamstring graft, because unfortunately in these patients, the hamstring graft become even thinner than normal. There is no other way out. Now people are thinking of peroneus longus, but then there is still controversy that you are involving the ankle. What are the long-term outcomes? We don't know. Whenever there is a knee pathology, it's better to stick around the knee for the grafts. Conceptually, that's what makes more sense. So high BMI is a proper indication. Multi-ligament injury, it's an absolute game changer, because you can use your hamstring grafts for your PCL, for your posterolateral corner, or for your MCL, and the quads will be used for the ACL. Quad can be very well used for the PCL also. So this is the case with ACL, MCL, high BMI, where you can see excellent outcomes, and the scar reduces in size. You can use the bone plugs. Whenever there's ligament laxity, whenever there's in revision case scenario, the quad has become the go-to graft, because in a revision case scenario, if there is bone tunnel widening on one of the components, you can use the bone plug on that component, and you've got a very thick graft even if there is tunnel widening. So it's become the go-to graft for revision ACLs. Hyperextension. This is a very common entity where there is a significant risk to stretching out of your graft, especially if there is hyperextension around 15 degrees. So when you use the quad tendon, you are actually weakening the quadriceps mechanism, thereby protecting your graft. Hyperlaxity, as I just said, if there's a Baton criterion of above 8, then you have to use bone tendon bone or quad tendon bone to make sure there is a reduced risk of stretching out of your graft. And revision ACL, like we just discussed. Take home message, it's one of the most robust grafts, very, very versatile. Adjustable loop is a huge leap in the technology. It can be used for all inside also, and with cortical fixation also. As your experience increases, there are people who are using it even in pediatric group. So John Fulkerson has even used it for pediatrics. It's an excellent graft for young adolescent girls also. So very versatile graft. I think all of us should be trained to use it whenever needed. Thank you.
Sir, while describing the quadriceps tendon, you said there is a differentiation between the tendon per se and the fascia there. So how do you define that in the surgery, or how long can you go proximally?
So, except for Rajiv Raman's article, in general, the entire length of the quadriceps is not really found to be very popular. So conceptually, you do not want to disturb anything proximal to the rectus femoris muscle tendon junction. The biggest problem with the quadriceps rehab is if your rectus femoris becomes weaker. So the patients take almost 6 months to a year to recover that function. So to answer your question, I would not prefer to go anything beyond the rectus femoris muscle tendon junction. So taking a long graft, whether it is fascia or tendon, for me is not preferred because you don't want to disturb those fibers. So I don't prefer that, and therefore
sometimes for PCL you might require a longer tendon. So you don't use this for PCL then, or you take a bone plug in that case?
So trust me, quadriceps graft for PCL is a very dicey graft to use. PCL reconstruction by itself is something where there are so many factors which are against you in terms of the kiloton, in terms of whether you should do double bundle, single bundle. Soft tissue grafts are your go-to grafts. And probably that is one area where I would look at peroneus longus if it's a high-end person who requires a double bundle thick graft and the semitic gracilis are being used for something else. So quad tendon is for those rare cases like a revision PCL, for example. And there you can use with the bone plug, and then you can use both the components of the quad as a double bundle. So you can split it and use it as a double bundle. And there you should be sure that this patient has got a long tendon portion, because even with the bone plug, it might not be satisfactory. So more often than not, you bottom out. Your graft literally goes near the aperture. So this is all the challenges you face.
Sir, two questions for you, sir. Two questions for you. Sir, is there any change in rehab protocol when using quad tendons?
Yeah, so the physiotherapist has been advised from day one to make sure the patient is working on his quadriceps from day one very religiously, more focused than normal, because we anticipate them to develop weakness and extensor lag. We don't mind using Faraday stimulation from the very beginning itself. So from day one, we are counseling him that, you're going to take time. Initially, I didn't see much of a difference, but lately when we are seeing that when we follow these patients up closely, they take almost 6 months to 8 months to match up to the hamstring graft patients. So I wouldn't recommend them for all my patients except for the specific indications, and this in mind.
So second question is, was that you in the logo doing the long jump?
Yes. That was me. I had a nice athletic career. No more now. Doesn't look that way now. But
so patient with a high BMI, short female, where already the cords is relatively, the length is not that much. And if you're trying to take a bone plug, particularly 40-45 female, where there are chances that patella still may be short, so what are your options in such cases? Would you not prefer to take CQT in such cases? Like harvesting a bone plug in a fatty female with a shorter patella, and some patellofemoral already set in.
yes, so these are the cases where if they're high BMI, short stature, probably 40 plus short stature, you're worried. These are the cases where even you're worried of drilling from inside out, because you are worried that your pin will not exit in the sterile area. So these cases probably are a contraindication for ACL surgery per se. Now, if at all they qualify in your algorithm, then you can always use cortical fixation on the tibial side also. So there's a loop on the femur and there's a cortical fixation on the tibia. Does equally well. There's no problem whatsoever.
So this is you can start. So this is going to be 3-4 cases basically. We are going to have an interactive session and a kind of a panel discussion. So I will request Dr. Nagaraj, Dr. Abhishek Kalantri, Dr. Tantuway and Dr. Vinay to have one mic with them so that we can start. So I will just briefly start with my case. This is a case of a double bundle. So a double bundle requiring a revision. So long back in 2004, the C.D. Harner has told that the double bundle is a double trouble. So double trouble, particularly nowadays, you see the double bundle is not so popular in the ACL, but still there are a few cases would have been done previously, and if they come with a failed situation, then you are actually in trouble. So anatomical double bundle ACL reconstruction revision surgery, there is a case series of 3 patients in the 40 patients, so it's a relatively rare situation that I encountered. A 21-year-old male recreational sport undergone a double bundle ACL reconstruction in 2017 August, but he continued to have symptoms of knee instability 1 year after the primary surgery, When he tried to resume the sports, there was no history of re-injury per se, and he was advised rehabilitation for primary surgeon for 6 months, but nothing was working. So he presented to us with the Ligament test positive, draw test positive, and the pivot shift test positive. So a positive Ligament and draw and negative pivot shift may indicate an isolated AM bundle tear. So you do search for what are the cause of the failure, what exactly has happened. So I follow this 5M principle. Is there any history of trauma? There is missed lesion in the primary surgery. For example, if you miss the dial test, valgus, varus stress test, or the missed pivot, there may be the chances that there is a malpositioning of the tunnel. X-ray and CT shows that the 80% reason for the technical failure is the malpositioning of the tunnel. The meniscectomy in the previous surgery is again the cause of the failure, and the malalignment in the X-ray and scanogram if needed. So coming to the investigating such patient who has come to you with a failed ACL, whether it's a double bundle or the single bundle. So what investigation would you start with, Dr. Nagaraj? Yeah.
You want me to name one, right? So that
yeah, absolutely.
So I think the first and foremost, you have mentioned the scanogram there. So probably I would talk about the monopedal stance lateral view X-ray for the posterior tibial slope, and that is probably one more single most important factor which can lead to a high failure if there is a high posterior tibial slope more than 14 degrees. I think others can add on with the whole. So we have a standard protocol.
Probably the next would be is a CT.
CT. So what you are trying to look in the CT scan?
We need to check for the tunnels, the tunnel position, the femoral tunnel position, the entry point of the femoral tunnel position on a sagittal plane, and the tibial tunnel on an axial plane.
Okay. Vinay, what would you like to see in the plane X-ray? So if you got a plane X-ray, AP and lateral view, so
in the plane X-ray, I would like to see the tunnel widening or something if it is cystic changes or something, if it is there. In the lateral view, the slope of the tibia and arthritic changes if there is some cartilage damage or the early osteoarthritic changes if there, the position of previous implants, what is there, and if we can appreciate the direction of tunnels and the location of tunnels. So these things I think it is very important to understand.
So Abhishek, apart from X-ray, scanogram and CT scan, what else would you like to add in your battery of investigation?
Definitely in MRI to find out any kind of missed lesion.
Okay. And in clinical examination, what would you search for? As a patient is coming to you with the ACL reconstruction, the first thing that comes in your mind would be what?
I would like to see his gait and of course pivoting.
So
during the
pivoting is the
clinical.
one thing which is really very important. Yeah. So in the primary surgery, if the pivot has been missed, so probably there are certain lesions which was probably missed. So coming to Dr. Nagaraj, if the pivot shift test is positive, what does that indicates to you?
So as we know, the first thing is a missed lateral meniscus root avulsion. So that is something which is contributed to high grade pivot. Pivot, we haven't understood completely as of today whether this patient had a pivot in the first surgery and that was missed, and was a good explosive pivot which was a good indication for LET in the primary surgery. I think pivot we need to understand is also got to do with the articulation of the lateral femoral condyle. The ones which are more convex are more unstable and therefore leads to the pivot injury. We still have not understood whether the anterolateral structures are also responsible for the damage. So yes, to summarize your question, Sheetal, number one, lateral meniscus avulsion I'm going to be looking for. Even a ramp lesion can contribute to a pivot. So the corners, both the corners, the convexity and the articulature of that particular patient's condyles, and significant damage to the anterolateral structures which was probably missed or there was an injury this time.
So this was the plain X-ray. The angle less than 70 degree in the femur leads to rotational instability, and angle more than 72 degree in tibia leads to loss of flexion and laxity. You can go ahead and use this Bernard Hurtle grip. 27% is deep and shallow and 34% is high and low. So MS Jacob line, which is from the center of ACL tibial tunnel, 27 to 60% is in the single bundle ACL, and in double bundle ACL it should be 30% of AM and 50% PL bundle. This was the slope basically, and the CT and MRI was suggesting that the previous medial meniscectomy was done, and there is a full thickness tear of both bundles. So both AM bundle and PL bundle was torn before the surgery. So this was the challenges, the tunnel dilatation, tunnel positioning, hardware issue and how to address. And there is an associated pathology as well, like a pivot shift. So Tantuway, so this tunnel dilatation, how much is the tunnel dilatation which actually bothers you? That is the tunnel dilatation which I am able to see either in X-ray or in the CT scan that, that will help in your planning.
See, anything more than 10 would be a challenge always, because we need to see what grafts are remaining after that, after surgery, because that is one. And does he have any associated ligament injury as well, which has to be taken care of? So we need a graft for that as well, just in case he has maybe a PLC or some kind of other ligament issues. So that also, anything more than 10 mm of tunnel would be little, well, I have to think double what to plan for, and then maybe if it is somewhere
what's
around
your cutoff,
11.
Vinay? I mean, at what?
12, yeah, 12 mm.
12 mm. Abhishek?
12.
Dr. Nagaraj? So
I think 12, because theoretically they say up to 13.
13, yeah. 13,
Theoretically
14.
it is 13, but practically it is difficult. The concept being the thickest graft you can get, for example, the quad tendon, etc., is about 10.5, and with your interference screw, probably 12, 13 you can escape.
Absolutely. Or you can use a stick screws where you can fill one tunnel with the screw and
yes,
you can manage the dilatation.
Described, but I haven't used it. I don't know how much successful it is. You can do, in the words of Andy Williams, there is no need for a two-stage ever. You can have multiple ways, but yeah, I think it should
better to play safe.
Of salt.
So what would be more challenging for you? A previous anatomical tunnel, previous non-anatomical tunnel, or something in between?
In between, obviously. In between, obviously, and therefore it's very important that, like you said, asking Brajesh to show what is the ideal anatomical tunnel, because more we train our colleagues how to create anatomical tunnels and not semi-anatomic, it is easier for us.
Absolutely.
When there's a revision, if at all.
So in such cases, Tantuway, what would be your preference? Like we are already seeing there is a tunnel dilatation of 16 millimeter on the femoral side, and on the tibial side it's 18 millimeter, because now we are combining the two tunnel dilatation. It's a double bundle. So it's actually a double trouble on the femoral side as well as on the tibial side. So would you like to go ahead and do in a single stage or a two-stage?
Preferably a two-stage. First stage would be clear the tunnels and debride it and put a bone graft there, and wait for the bone graft to heal and then go for the next stage.
And when you would like to intervene, one stage, two stage, Vinay?
Depends on patient also. So if I feel the patient is patient is having time, he can afford and he can spend time for two-stage surgery, it will be good. But if patient wants that everything is to be done in one stage, I would fill one tunnel with the screw and
second tunnel as an anatomy.
And I'll use BTB graft on both sides, the bone plugs.
Abhishek, when would you like to go for a second stage? How much gap would you prefer? Like when you will feel comfortable that now this bone graft has healed and I can go ahead and go for
at least 6 months.
At least 6 months. So that is what we have planned, what Abhishek has pointed out. We have gone for the two stage. We have removed the hide wire in the first stage. We have taken a strip of IT band because anyway I was going to remove the implant from the lateral side. So I planned for LET because he was a young patient. For the 6 month I want to be on a safer side. And at the same time we have planned for a BTB graft in the second stage after the 6 month. So this was the first stage. In the first stage there were a lot of osteophyte. There was no remnant of ACL which indicate that this was not a acute traumatic tear. So there was no remnant of either of the bundle. So medial meniscus there was a lot of previous changes of previous medial meniscectomy. Lateral meniscus was fine. So I had to curate out which I was pointing initially to Harsh, that if there are a lot of osteophytes and there's a chronic lesion. So I had to use a radio frequency in this case, this quantum device. You can see both the tunnels were very well visible. These were the two tunnels which were flipped. So I have started dilating my tunnel just to create a good bony surfaces. So this was the first tunnel, and just below it this was the second tunnel. So I decided to increase the tunnel diameter just by a little bit so that I can have a good bone, so that I can graft it very well, and once the healing is proper. So I have gone ahead slowly, and then I have decided to go onto the tibial side and the tibial side. So this was the two tunnel which was very well seen. On the tibial side again there was the two tunnel. So this was the first tunnel and the second tunnel. So while I was planning to do this was the previous screw you can see. So So this was probably a PLLA. So this PLLA, you can see this was impacted into the bone. So I have removed this PLLA screw. PLLA is no longer used anymore because this actually doesn't dissolve. They say it will dissolve, but up to, I have seen even up to 5-6 years, they usually doesn't dissolve. So this I have removed the previous screw, and there was a huge actually tunnel dilation. So femur was not much challenging for me. It was the tibial side which was challenging. So this was the final picture which was showing the dilatation of more than 18 mm what I have imagined actually. And both the tunnels were collapsed and that was coalescing with each other. And then I decided to take out, this was some more remnant, and I decided to take out the bone graft. So I have used this reamer. So these are the kind of a core reamer. So with this core reamer I have taken the multiple plugs in the shape of a bullet. And this bullet I have started filling in the tibial side as well as, so this was the tibial side dilatation. You can see it's a huge dilatation of the tibial side of both the tunnels. I packed it everything with the bone graft. And this was the post-op x-ray immediately after removing and packing everything with the bone graft. And then we have gone ahead after the 9 months actually. For 2 months patient was somewhere, he was not much willing for that particular time. And after the first stage, you can see that everything, all the tunnels were filled. Now it was like a primary ACL. So this is the advantage. You are not facing any kind of a surprises. So medial and lateral sides were looking good. This was again the previous change of medial meniscectomy. I have done the LET because I done without ACL. I didn't want for the next 8 to 9 months there should be a lot of pivot and the further injury to the any kind of injury to the meniscus or the cartilage. So you see whole of the tunnels was what very well filled with the graft. You can see the graft. Now it was like doing any standard ACL reconstruction. So I have done this ACL BTB. So for revision cases, I usually prefer a bone tendon bone graft for such cases. So basically revision bundle can be challenging. 2 stages is relatively safe and good tunnel clearance is the key for the graft. And you have to always check out what were the reason for the previous failure of your prior ACL reconstruction.
Yeah.
Just a question. Yeah, please.
Brajesh is ready with
yeah,
the
we will go in theater and then we'll come back. Yeah, absolutely. In the first stage. First stage.
OT is a live. OT ka defeat.
You are live, sir. Okay, Elga, slightly. So this is, we have done the meniscus repair. 1, 2, 3 fast fix on the top. And 2 on the inferior surface. Okay, पकड़िए, इस तरफ आइए, पानी का pressure. ACL reconstructed well, full hyperextension confirmed. Okay, perfect. Anything
yeah,
you can
thank
discuss?
you, Brajesh. Thank you, Brajesh.
Okay.
Once you come, we'll discuss.
Sure, sure.
Yeah.
Fine. Bas.
Thank you for nice
Sure,
demonstration.
great.
Thank you, Brajesh.
बस थैंक यू दोस्त आप कैनला दे दो
Sir, we can continue with the question and answer session for your case discussion.
Yeah, next case. Yeah, for revision BTB, the first case, if there are any questions or any comment on the 2 stage, 1 stage.
I feel that even though the concepts of anatomical reconstruction we are discussing for so many years, on the femoral side people go wrong a lot, including some of our senior colleagues also sometimes.
Absolutely.
Even there, if you see, the AM bundle seems to be quite high.
High, yeah, absolutely, I agree.
And then in revision you become very two-minded whether to accept that, whether to go, and more often than not we tend to cheat on one side. Also tell me, I don't know, but for whatever reason I saw you getting a nitinol wire on the femoral side from outside in? No, nothing. So
from the fixation?
For the fixation
Fixation, I always, BTB I prefer outside.
Outside in, no?
Because, in maximum patient, the graft length, the biggest problem with the challenge with the BTB is the graft length is somewhere 95, 90.
Yeah.
So if you use any other kind of fixation, your graft on the tibial side almost 15 millimeter is outside.
Correct.
So what I usually do, because BTB I'm using for high-end pivot in the sports person, anyway I'm planning to do LET at the same time in the revision scenario, or even in the explosive pivot. So I will always take IT bend strip, take it out, and then I will do through and through drilling. I will put outside in screw fixation, and I believe that if LET is a non-anatomical, the BTB achibonds which are coming, I will use it as an anchor, and I will fix that ITB strip there. So
Okay.
that will gives me double advantage outside in fixation. So that is always a good fixation for me because the bone plugs are actually on the femur side and tibia side is complete, and at the same time I can do LET at the same sitting.
I agree with you, and I think Smith & Nephew has got a very good guide called the Pinpoint ACL guide. So you can use it for your outside in drilling and for your through and through tunnel. If for whatever reason you are planning a different fixation technique, you can still use the same principle what Sheetal mentioned. Open up for your LET, use your retrograde reamers for your outside in drilling so that it avoids the original tunnel. Only thing is, in this particular case, the initial tunnel probably was done inside out.
Yeah.
How did
inside
you
out.
match your outside in drilling to the original tunnel?
Original tunnel was actually I filled up with the graft. So what
Okay.
I have done,
No, no,
I
on
have
the
drilled
femoral
through and
side.
through. Initially, I have done through and through, removed the endo buttons,
Huh.
and then I put the graft from inside out basically.
So femoral side also you have grafted?
Yeah.
Okay.
Grafted both on the femoral side as well as on
And
tibial
tibial
side.
Okay.
Sir, what would be the ideal time between those two intervals in a stage procedure and why?
6 months. Because you want that graft to get consolidated very well. So once you are sure, so ideally before taking the surgery, you can get a CT scan again. But again, in our scenario, it's not possible. So you can just get a plain X-ray done, see the check for the tunnel dilatation. A good quality X-ray is going to show you everything. If the tunnels has healed very well with the graft, so then you can safely go ahead and go for a second stage.
So actually, if you think about it, I've done quite a few CT scans and we have seen that around 3 months average, no, you get very good healing. Think about it this way, you do BTB ACL, you say at 6 to 8 weeks the bone-to-bone healing has happened.
Absolutely.
It's a very similar thing.
Absolutely.
You have created a fresh tunnel and you have put fresh autograft there. So it more often than not heals. If you want to go in early, better to do a CT scan, confirm.
And there is no upper limit to the interval? We can go for 1 year, 1.5 years?
So the risk is meniscal and chondral damage. That's why Sheetal did the LET, because you're always in your mind that you're sending an unstable patient home. So he should be counseled that he cannot have any more pivoting injuries.
And femur was not much challenging. I could have put a one screw on the PL and AM, I could have dilated, but the problem was on the tibial side. And doing, because it's a very rare to revise a double bundle, I don't want to take any kind of surprise. So I've gone with the plan that 16 mm, 18 mm dilatation is there. I'm not going to take any chance. I'm not going to do anything. I will just go ahead and do grafting and go for a second stage.
Sheetal,
Cause in that case for the failure?
Cause of failure? So the 5 principle, nothing was, everything was looking fine. I think there was kind of a biological failure, probably maybe the reason, I'm not sure. Because what Nagaraj was pointing out, that AM tunnel was relatively very high. Actually, it was above the resident ridge. So the previously which were considered as a normal tunnel, and we have revised probably, considering that that was normal and dilated that it was normal, which was actually not normal. Because anatomy was, since the beginning it was at the same place. It was always below the resident ridge. Changing concept has probably changed the scenario. So AM bundle was something high is AM bundle. I think that's not correct. Anything below the resident ridge is a better option to think.
Sheetal, what were your femoral tunnel sizes during revision, and which size graft did you match with those tunnels?
The
For
graft
filling
I
up-
have,
filling
graft I
up
have
that.
taken from the iliac crest, so it was basically plugs of around 6 mm, 2 plugs was there, and for down I have taken a plug of around 9 millimeter and by 10 millimeter, 20 millimeters in the length. And second time when I have done BTB, I always do 10. So my BTB is always fixed. I just take a graft of 10 millimeter for revision cases.
So this-
Revision even for primary I take 10. Because taking 7 or 8 in BTB is quite difficult. They say you can take 8, but once you try to do that, the graph is really very thin, and you are in worry that once you are passing that ethibond, you are pulling, the cortex get ruptured sometimes. So I always take 10.
Using this mosaic plasty set for taking out this plugs.
Taking this iliac crest graft? No, iliac crest graft, that was a core reamer kind of a thing basically. So I got a set of core reamer which is from 7 to 13 millimeter.
Okay.
So you can put that core reamer, and even you can use oats, but I use oats in one case, but that damages your tip of the oats. So you cannot use in second case for the cartilage.
Your
So
instrument
it's
is
expensive. It's a 50,000 for just taking out the iliac crest graft. Is so coming to the second case for the discussion, just let me know whenever time is over, I will stop in between. So this is a 35-year-old male. Yeah, he's a 35-year-old male. He is a financial advisor. He's got a lot of financial advisors for everyone, and he was he is into some recreational sports. Fall from bike 2 years back. He's got a locking episode and instability. He's got full range of motion. He's got ligament test, draw test, pivot shift positive, grade 2. He's got a joint line tenderness of both medial as well as lateral side. He doesn't have any abnormal alignment. So Abhishek, a joint line tenderness, how much do you rate your joint line tenderness? Any patient who is giving on sign, if you're examining there is a joint line tenderness, what's the first thing that comes in your mind, or you will go for some other test?
I'd consider it as a meniscal injury.
Meniscus,
inside.
yeah, absolutely. So medial joint line tenderness, would you consider that it's probably a medial meniscus, or?
Definitely, medial meniscus.
So, Dr. Nagaraj, in your clinical practice, do you do this McMurray's test, or MJLT is just enough for you?
Yeah, joint line tenderness is what I more rely on.
Yeah.
McMurray's and provocative maneuvers, I don't.
Yeah, absolutely. So even I don't go for a McMurray's test because a provocative maneuver. Even I don't go for a pivot shift also, because even doing a pivot shift sometimes painful and apprehensive, and actually you can damage something while doing the pivot. So under anesthesia, doing pivot gently, I think that is a better option rather than going for a McMurray's test pre-op. So medial joint line tenderness got a very high sensitivity and specificity until unless patient is in 50s, where there can be chances of some chondral damage as well. So he has got tenderness on both medial and the lateral side, which indicates probably he has got a medial meniscus as well as lateral meniscus. And again, coming to the pivot grade 2. So grade 2 is something, a gray zone. So Tanmay, what would you consider grade 2? Grade 1, we know it can be due to ACL. Grade 3 is a explosive pivot, probably some extra-articular lateral structure. So what grade 2 is pointing towards? Absolutely.
Probably there maybe we should be checking the MRI specifically for the posterior tibial condyle. At times there is bone edema there.
Okay.
That's an indication of ramp.
So this was the MRI which was showing ACL, and this was the diagnostic arthroscopy. So you can see he has got a meniscus tear which was more of a root tear actually. So you can see on probing, so whole of the root was getting displaced, but while going inside he was having the ramp as well. So this was something rare, which was the combination of the root and the ramp, which we have included in our extended classification of La Parade, which we have labeled as a type 7. We have seen almost around 4 or 5 cases in which the root and the ramp both were combined, and he was having the lateral meniscus root tear as well, or a kind of a radial tear, which was extending type 4 La Parade. So he was having a medial meniscus root tear, he was having a medial meniscus ramp tear, at the same time he was having lateral meniscus root tear. So this is how we have extended into type 7. And which is already been published, and Dr. La Parade has named it as a terrible triad. So he has named as a new entity, which is a ACL with a ramp with a lateral meniscus root, which I am seeing from last more than 3 years and got almost follow-up of 12 cases of combined this. So probably I will publish the series of terrible triad. He has labeled as probably one case that he has seen. So a patient with a combination of ramp root and the lateral meniscus root. So, Dr. Nagaraj, how you are going to approach this patient now? So he has got a ACL, he has got a ramp, he has got a medial meniscus and the lateral meniscus root. So, what are the options you are thinking in your mind for this particular patient?
So obviously everything has to be addressed here, and I have had one such case, and both the roots we did a transosseous technique itself, because I don't think the anchor technique is a very valid technique, although you have described on the lateral side and on the medial side also things have been described. I think it's more easy said than done, the anchor technique. And for your ramp, I think your inside-out meniscus repair again will be covering up for that. So here it's a radial tear near the root. It's not a root avulsion, lateral side.
Yeah, it's more of a radial.
Yes. So fortunately, there is no need for a tunnel technique there. It will be more of a side-to-side stitching there.
Absolutely.
On the medial side, there is going to be a tunnel for the root. In addition, there's going to be an inside-out meniscus repair for the ramp area, because I think that is where I can get more control rather than the regular ramp repair techniques.
Absolutely. So, and what about adding LET in such cases? It's a grade 2 pivot.
No, I don't think so. I think definitely the pivot is because of this amount of meniscocapsular separation on both the medial and lateral sides.
So this is the point. If you're having a grade 2 pivot and if you're able to see a ramp or a root lesion, probably you diagnose what exactly is causing their pivot. So absolutely there is no point adding a LET in such cases. So coming back to the question, Tanmay, if it's a grade 2 pivot and you're not able to see a ramp on the root, would you still add a LET in such case, or?
He being not in a high-end athlete, I may discuss with him there and there itself, and how he really is enthusiastic about sports, and there if he is, probably we can add
So if it's a low demand, you will not add, otherwise you will prefer to add LET even with the grade 2 pivot. Yeah, I
Yeah,
think
we
that's,
can.
yeah. Vinay, same. Abhishek?
I'll definitely add LET.
LET.
If there is no meniscus.
No meniscus ramp root. Dr. Nagaraj, it's a grade 2 pivot, not explosive pivot, and you go inside and you see that ramp root, everything is normal. So isolated chronic, which the chronic ACL actually have got some, if you do look for the ramp lesion is not there, but there's a lot of posteromedial capsular laxity. So would you add a LET in such cases?
I would add, I have a very low threshold for LET nowadays.
LET, absolutely. So adding a LET is a good option in such cases, particularly what Tanmay has pointed out is a high demand, and you are not able to see that root and ramp lesion is not there. So to protect your ACL graft, you need to get add an LET. So for adding a LET, what is your preferred option? I mean, taking a IT band strip, going below this thing, and what is your tunnel method, anchor method, fixation choice?
So I go for the modified Lemire. So I use the IT band strip, more of a central based IT band strip, not posterior based. I obviously go under the LCL. I go just proximal to the lateral epicondyle. I don't go proximal, anterior, proximal, posterior, no, proximal along the shaft. I have had very high incidence of tunnel coalition. So I have initially done with the screw technique, but shifted very early to the anchor technique. Yeah. And I'm very careful, as Vinay also pointed out, the scope is always in the medial portal when my anchor is going inside.
Absolutely.
And I in fact even don't mind dissecting and finding out the ethibond sutures of the femoral tunnel, making sure what is the direction of that and then changing accordingly.
Okay.
And one take home is, although they say initially articles that you need to direct whatever technique it is, for example a guide wire or an anchor, you need to direct it proximal and anterior. I have realized that more often than not you need to be straight ahead. Because the minute you are anterior, you're actually probably getting into the tunnel there again.
Absolutely.
And the biggest risk is that this anchor may not be even, or any technique may not be even perfectly visualized, because it violates not in the main portion of the tunnel, in the 4.5 exit area. So sometimes you cannot visualize it if there is any clot, blood clot, etc.
Absolutely.
So you need to be very careful of tunnel coalition.
So Tanmay, tunnel technique or anchor technique, which is your preferred method?
Anchor is safer for far better.
Vinay,
And
you shown the LET.
Nagar said, straight tangent,
tunnel or
perpendicular.
anchor? Tunnel technique. Mostly tunnel. Abhishek?
Tunnel technique, what I am doing is that while flexing the knee, in the ACL tunnel we are already putting a 4 mm or 6 mm drill inside, so that whenever we are drilling from outside in for the LET, we know whether it's going to hit or not. If it hits, then we change the direction.
You can visualize from the intromedial portal, or you can actually, like you do in HTO, you can put a drill so that it doesn't coalesces your both the tunnel. So in this case, with the combined root and ramp repair, we have gone with the transtibial technique. So we have made the anatomical tunnel, and what we have done, while taking the bites, we have taken the bite both from the root as well as, for this we use this shoulder scorpion. So you can take a bite from the ramp as well as from the root, and then taken the bite from the meniscus, and then taken the bite from the meniscus again. So we have covered both the capsular portion and the root here, because this was again a new case for me. So that is what I could thought of at that particular time, because it's relatively, it was a rare situation. And then once I pulled out everything using this transtable technique, the whole of the root along with the posterior ramp, you can see it's covered very well, and everything was coming back to its original position. So this was done for the medial side, and for the lateral side we have done the side-to-side repair along with the ACL reconstruction. So this was the post-op MRI which was showing this transtibial tunnel and the initial healing of the root.
So in this scenario, how do you fix, in the flexion or in the extension of the knee joint when fixing the root?
For root, I always
because
fix
you have
in.
taken the posterior capsule also.
I always fix in extension actually. Root, all cases I fix in extension. I think tibia, if anything which is not linked with the femur, I don't think so it will matter much whether you fix in flexion or extension.
Because you are
if something is crossing the joint, then flexion extension would matter.
No, because you are taking the capsule also along for the ramp.
Extension.
That's why.
So the biggest fear whenever you are plicating capsule is developing fixed flexion deformity. So in fact, you need to go into hyperextension. Go as extension as possible. Because whatever you say, these patients are going to develop some amount of pain and land up with flexion deformity. So make sure that they are always extending. Everything is an extension.
So coming to the last case, I have already shown in one of the conference. Basically, she's a 22-year-old female. She's a national level judo player. She's got fall while she was playing 4 months back. She has got instability, inability to jog and run. Range of motion is minus 15 degrees. So this minus 15 degrees above zero, that is a hyperextension. Ligament test, draw test is positive. Pivot shift was in between, so it was more of negative, I can say. Byton score was 7. Both knee, she was having a hyperextension of 15 degree and there was no abnormal alignment. And this is how do the Byton scoring system, which I have shown on the left side. And this was the hyperextension of 15 degree, probably more than 15 degree. This was the hyperextension of MCP joint and the thumb, which indicates her Byton score as 7. This was her MRI picture suggestive of complete ACL tear. So, Abhishek, do you really feel it's a difficult case scenario, or you feel that's a straightforward ACL like any other ACL?
Because of hyperextension, it's a difficult case, because whatever one is the graft choice, you should not be using kind of stretchable grafts here. So I would prefer to go for the BTB here.
Okay.
And definitely add LET along.
Okay. Vinay, what is the difficulty or what are the challenges you are expecting in this particular case?
What is the range of movement on the opposite side or the normal side?
Same. Minus 15 degree hyperextension, both sides. She's a case of a generalized ligament laxity, you can say. You can see the MCP hyperextension.
So I would like to do with the soft tissue graft ACL and along with the LET.
Along with the LET.
Yeah. Because if we will make these patients little less of a hyperextension.
And one thing you have to remember that she is a national level player for the judo particularly. So what would be your graft choice for the ACL in such situation?
Since she is a national level player and hyperextension, I'll go BTB with LET.
Okay. So why anybody from the delegates, why he has changed suddenly, listening to the judo per se sport, why he has changed suddenly from hamstring to the BTB? Anybody from delegate? It's national which is important, it is player which is important, it's a judo which is important. Anybody? So what is the important in judo? So judo is the one sport which requires a lot of flexion, powerful flexion. So you don't want hamstring to get compromised because she is playing at a national level. So there are high chances of failure. Small thickness graft, being a female, so if you take a hamstring, there is going to be a small thickness graft. Graft getting stretched out. Sports involving the deep flexion loading. So any sport which is involving the deep flexion loading, ideally hamstring should not be used. Weightlifters, judo players, it should be avoided. Coming to Dr. Nagaraj, CQT bone plug, CQT BTB.
I think I'm going to look at a height also, her BMI, a height. Looking at that, I expect that the quad tendon graft would be very short. So if I'm going to go for quad tendon, it's going to be with the bone plug for sure. So both the grafts are very valid, but to negate hyperextension, I feel a quad tendon is far better than a bone tendon bone, because you are going right in the quadriceps mechanism as compared to the BTB where you're going on the extensor apparatus. So your likelihood of weakening her hyperextension, it seems to be much higher than 15 degree also according to me.
Yeah.
So both are valid, but I would tilt more in favor of quad tendon bone if her height and if her length permits.
Okay. So ACL graft failure is 25% if patient is a hypermobile as compared to a normal. So this is a challenging situation because there are high chances of graft failure. And overall ACL injury rate was higher of around 34%. And these are the indicator, the heel height more than 5 centimeter, although Laparade has described heel height of more than 6 centimeter. So if you just measure by the scale, if heel height is more than 6 centimeter, that means this is a challenging case. You cannot just go away doing a simple isolated ACL reconstruction. Non-sports person, even non-sports person, you need to add a LET because a hypermobile has got a higher chances of re-injury. So one single factor which is important is a heel height more than 6 centimeter and MCP extension more than 90 degrees. So these are the positive predictive failure. So obviously the choices are graft. Everybody agrees that either it could be ACL with the BTB or ACL with the CQT. So will you change your tibial tunnel position because she's a case of a hyperextension? So would you cheat on your tibial side just to avoid the impingement, or?
No, not at all, because we are creating in these anatomical footprints. So therefore, there is no question of any impingement as long as you are creating anatomical tunnels.
Absolutely. What about you, Tanmay? Okay. So one thing is, particularly if you are going for a BTP or the CQT graft, these grafts are flat graft. Even if you go anterior, if you go in the routine position, even if you do the hyperextension, the graft is not going to impinge because these are flat graft. If you use a semi-T, particularly if it's a 9 mm or 10 mm, it's definitely going to impinge because it's a tubular graft. So what angle, Tanmay, you're going to fix this ACL? She's got a minus 15 degree of hyperextension. This question I'm going to ask to all panelists. What angle you're going to fix this ACL? Extension, Brajesh. Hyperextension. Neutral. Abhishek. Extension. Neutral. Nagaraj.
I'm going to go into a natural hyperextension because we did a study when I was in Korea, a 3D finite element model study. Even my natural grafts, I fix them in extension. But hyperextender is a 100% hyperextension. The reason is we have to match her to our opposite limb also.
Absolutely.
She's never going to feel comfortable if she is tighter on this knee. She wants to be tight for her normalcy, not tight for our normalcy.
Absolutely.
So I have seen patients being very unhappy even after a year if they are not getting the natural hyperextension back. So therefore, it's very important that we weaken her quadriceps mechanism so that our graft is also safe and she has a natural hyperextension.
So that is what we have planned. We have found for the BTP, and the fixation we usually prefer to do in in relatively hyperextension. So in general, rule of thumb that I usually follow, I usually go, suppose patient got a 20 degree hyperextension, I will go minus 10, that is a 10 degree of hyperextension. So that is not that much of hyperextension. Or if patient is already in a 0 degree of extension, I usually fix my all graft in 0 degree of extension, but in hyperextension is there or a generalized laxity is there, I will prefer to fix in hyperextension what Dr. Nagaraj has also pointed out. So this was a standard ACL BTB, and you see it's a flat and the thick, flat, thin and the broader graft basically. Bone to bone healing is feasible, and sometimes this is what happens. The graft size, the bone plug is 10, but the graft is relatively thin. So you can take the bone chips, and if you wish, you can fill the bone chips from the inside out, just for the better healing at the level of this thing. So this is what the literature shows, that sports which needs a deflection like a ballet, judo, use of hamstring graft should be avoided. Hamstring graft has a high failure rate if the graft diameter is less than 8, patient is young, female and hypermobility. So this patient was having all 4 factors. She was a female, young age, hypermobility, sports person, and high chances if you use a hamstring, the graft diameter is going to come less than 8 mm. So this is the cutoff point, that if the TR rate is very high, if there is a more than 6.5 degree of extension, so either you can do a ACL along with the LET. So whenever you are using a hamstring tendon, add a LET. And generalized ligament laxity is associated with a high, and BTB has got a low failure rate as compared to a hamstring tendon graft. So this is a take-home message. Use a pre-op Byton score and check for the knee hyperextension. Explain the prognosis regarding the high re-tear rate, LET if more than 10 degree of hyperextension, and use BTB for players who are engaged in deflection sports. Thank you.
Thank you, Shital. Now we will take a small tea break, and then and I'd like to thank our moderator, Dr. Kelkar sir and Ankush.
Thanks.
Welcome back everyone. Now we are starting with our second session focused on meniscus repair. So I request Dr. Ravi Gupta sir, Dr. Romit Agrawal sir and Dr. Kamlesh Meena sir to moderate this session. Romit sir. Our first talk is by Dr. Nagar Shetty sir on why to repair meniscus. Sir.
I think everybody understands that menisci are important. Probably the crux of the talks is to impress upon how devastating it can be if you land up with a situation where there is significant amount of meniscus loss. So all of us are aware of the normal anatomy of the meniscus. There is, it's a fibrocartilaginous structure which has got attachments at the roots and at the level of the intermeniscal ligaments. The lateral meniscus ligament is the lateral meniscus is much more mobile as compared to the medial meniscus because of its attachments to the meniscofemoral ligaments. All of us are also probably aware of this slide. I think this is always going to be quoted in every meniscus talk. I think we need to give credit to Steve Arnossi. In the late 80s, on electron microscopy, he identified this perimeniscal capillary plexus and told us that the meniscal vasculature comes typically up to the middle one-third in the best case scenario. Obviously, there have been a lot of modifications in our techniques to repair the meniscus to make sure that we can address the menisci all the way up to the red-white zone for achieving consistent healing. So based on that, traditionally we know about these zones, red-white zone and the white zone. More important than that is the way in terms of millimeters when we talk about the zones of the menisci, which I'll talk in the next slide. So what we need to understand from the first slide and this one is that the meniscus vasculature is precariously low towards the middle third and definitely zero as it comes towards the inner third. And we need to have some tips and tricks to stimulate this meniscus blood supply. If we are able to consistently stimulate this blood supply, then we are going to achieve consistent healing rates. So that's the take-home message of understanding what are the zones of the menisci. Now there is a Cooper classification which talks about whether the tear is in the meniscocapsular junction, outer third, middle third or inner third. This is another way we can understand. Now why is it important? Because how to communicate between surgeons and on our operative notes as to what was the location of the tear, what was the zone of the tear, all of us should understand the same terminology. So therefore it's very important to know these slides, whether it is a red-white zone, Cooper classification, and a radial tear, something like this, which goes through and through, is the one which is devastating because it cuts through all the way up to the periphery of the meniscus. So basically the meniscus gets divided into two halves in such radial tears. And this is the Issaquah's zones, which talks about the rim width in terms of millimeters from the meniscocapsular junction. So the zone 1 is less than 3 millimeters from the meniscocapsular junction. So that's zone 1, less than 3 millimeters, 3 to 5 millimeters and more than 5 millimeters. This is what we are following more consistently. So take home message, try to talk in millimeters than in terms of zones, because what is red-white zone for one is probably red zone for somebody else. So it's better you speak in millimeters and mention in your operative notes and follow up your cases accordingly. When you talk about the meniscus microanatomy, it's very, very, very important to understand. We talked about biology, we talked about vasculature. We need to have a very strong biomechanical construct. If you do not have a good combination of biology, augmentation and a strong biomechanical construct, your repair results are going to be inferior. And you will blame the repair for it rather than the techniques. So there are circumferential fibers and there are radial fibers. These circumferential fibers are arranged longitudinally and the radial, as you know, are interdigitated. So in the inner third, there is type 2 collagen, which is almost like cartilage. So it's a very thick tissue on the inner third. And there is low amount of vascularity, therefore poor healing happens in the inner third. So that's the unique anatomy of the inner third. So it's more like cartilage rather than the menisci. Now why you need to save the meniscus? This is a very good analogy. Some of you might know this. And for those who don't, imagine this is a truck with 4 wheels. This is a truck with 2 wheels. What happens is when there is a loss of meniscus, it is almost as if it's like a 2-wheel truck. So there is a point loading. So the meniscus, which functions as a load spreader and a shock absorber, is no more there to protect, and there is point loading. This point loading is the one which produces stress. There is no distribution of load. It increases the cartilage damage because of the increase in the point loading or the contact area. So that is the concept of preserving the meniscus. Literature has told it over and over again that if you do a meniscectomy, there is a high rate of osteoarthritic progression. You need to be very careful on the lateral compartment as compared to the medial compartment, because the function of the lateral meniscus in load sharing is much higher than the medial meniscus. Of course, you need to look into the alignment of the patient. So if you have a patient on varus alignment who lands up with a meniscectomy, it's going to be much more devastating. Similarly, if you have a patient with valgus alignment who has a lateral meniscectomy, it's going to be much more devastating. Take home message: preserve the meniscus, especially the lateral meniscus. Look at the alignment. When you talk about the tear patterns, obviously you need to understand now the previous slides. So these tear patterns are along the axis of the fibers when it becomes a longitudinal tear. It is across the fibers when it becomes a radial tear. This plus this combination becomes a complex tear. When a longitudinal tear goes through and through, it becomes a bucket handle tear. If any of the area gets lifted up, it becomes a parrot beak tear, and the whole thing can become like a flap. So that's how you need to understand the tear patterns. Remember the microanatomy, remember the zones. So take home message: you need to have a very strong biologically favorable environment. So all of us do a lot of rasping. In the rasping, it's important to remember not just the capsule but also the meniscus side. So spend adequate amount of rasping. Spend time on trephination. So use something like a owl or something like an inside-out meniscus repair needle to stimulate that same Arnox's perimeniscal capillary plexus. Stimulate the blood vasculature to come and heal your menisci. Use a small joint shaver blade, not a big shaver blade, in a reverse mode with suction off to clean out all that fibrous tissue. So all this makes sure that there is cell recruitment and vascularization and reduction in the inflammation. So all these need to be happening for the meniscus to heal. This is a very nice slide that I like to show. Imagine the collagen fibers, the circumferential fibers like noodles, and this chopsticks like meniscus repair devices. If you try to hold these chopsticks parallel to the noodles, it will always slip out. The best way to hold them is always perpendicular. So when you hold it perpendicular, you get the whole noodles or the collagen fibers. So take home message is always repair perpendicular to the fibers. That is vertical mattress sutures. I rarely ever take horizontal mattress sutures. I sometimes see colleagues taking horizontal mattress sutures. I really want to insist you need to practice to make sure all your sutures are vertical mattress for this particular principles to be achieved. So what are the positive prognostic factors over the years we have understood? If it's a younger age, if it's a traumatic etiology, if it's an acute and a subacute versus degenerative or chronic, and if the tear pattern is longitudinal versus if it's a radial. So these are all the good prognostic factors. But we have started pushing the limits of our meniscus repair over the years, and we are happy seeing the results if we follow these principles, and a couple of cases we will show. Never forget the importance of alignment. We have understood this importance of alignment over the years, and whenever there is a malalignment, we do a correction surgery, so they complement each other. The malalignment correction complements your meniscus healing, and both together complement the knee preservation goal that we want to achieve. So look at the angles, where exactly the deformity is, whether it's in the tibia, whether it's at the joint, whether it's at the femur, from the angles, and then take a call. As far as the meniscus root is concerned, a lot of people quote this Korean article wherein they have seen of the root healing after performing the osteotomy. The take-home message is osteotomy is the king of the procedure. You need to do it if there is malalignment. If it's a fresh, good root quality, it is better to repair it, because you are right there. With practice, it hardly takes any more time, and it makes sense to give the best of both worlds to the patient, because we have seen that even if there is a healing, it would be a part healing. It would never be like the way we repair the menisci, and a part healing predisposes the meniscus for extrusion. So alignment surgery, root repair not to be missed. This is an example of our cases being followed up over a period of time. So you can see, if you follow these principles, if it's a root tear like this, we have done the root repair, we have followed up at 2.5 years, we document the healing. This is the coronal images which shows the meniscus extrusion. So on the mid coronal image, you draw a vertical line down from the medial femoral condyle and you measure in terms of extrusion. Anything more than 4 mm is significant extrusion. This patient had about mild extrusion, and you can see the root there. And therefore, I like the tunnel technique like most of us do, because when you create a tunnel and a raw surface area, some amount of the tissue actually heals at the tunnel and not just on the surface but slightly inside. And this is pure documentation that the extrusion also has reduced over a period of time. We have done this in marathon players. They are back into action. So yes, we are pushing the limits because human anatomy is coming out with surprises. I think I will cover this particular slide in the degenerative meniscus talks of a radial tear repair. I will talk about this later. So the reason we need to preserve the meniscus is that if you follow these principles, in this particular gentleman, for example, who had a radial tear, we could actually preserve his articular cartilage on the follow-up MRI after 2 years. And the outcomes, we have data primarily from Frank Noyce, and the data coming from him is whenever longitudinal meniscus repair were done in the red-white zone in 20 years age or younger, almost 80 to 85% healing happened in the red-white zone, and up to 90 to 95% healing you see in the red-red zone. Most importantly, you need to understand there is no point doing an MRI to understand the healing of the repair, because you will see signals all the way up to year and a half. We always look at clinical signs, whether there is any swelling, whether the knee is silent, whether there is any joint line tenderness. Because even if it is incompletely healed, the meniscus will remain stable. And very rarely, if all your principles are followed, then the red zone and the red-white zone actually fail. On second look arthroscopy, this particular study showed that there is poor healing in zone 1, that is the inner zone. But as the minute there is there is good healing in zone 1, and as you come into zone 2 and zone 3, the healing rate reduces. So inside-out meniscus repair techniques is what is going to be again the game changer. For cases where there are complex tears, we rely more on this than on the all-inside techniques, because you can get robust fixation. These needles are very, very fine, and they create very less stress-rising effect. We are pushing the limits in terms of what devices we are using. So this is, I think, a lateral meniscus longitudinal tear. We are using the all-inside devices to create constructs which are stable. So you can see that the knee scorpion has been used to take a bite. We retrieve the suture from the undersurface, load it onto the knee scorpion again, and you actually do an all-inside repair with these sort of anti-grade devices. So you can take multiple such stitches. This is cost effective. It's on the lateral meniscus side, so you don't want to use blind all-inside devices. So yes, we are pushing the limits. We've got newer devices coming in. We've got better understanding of the biology. We are able to augment it with fibrin clot, with platelet-rich plasma. So this is a second look arthroscopy of a young girl. So she had an ACL, MCL tear with a very bad lateral meniscus tear on the left-hand side, as you can see. So what we did was we did a MCL repair in the first stage, and we did the arthroscopic meniscus repair. It was a tough case because she had a very convex lateral tibial plateau. So I was worried whether this is ever going to heal. So the crux of the talk is through this presentations as to second look arthroscopy. So we had the opportunity to look at her meniscus when we went ahead for the ACL reconstruction. So I was not very happy. I could put a few all-inside devices. I was worried what is going to be the outcome. So when I left the OT, I was a bit worried because of the way this went. And that's her second look arthroscopy when we went for the ACL. So as you can see, not just the red zone and the red-white zone, even the white zone seems to have healed as if there was never ever a tear. The sutures are all synovialized, an absolute boon. So we presently have the understanding, the tricks, the devices to repair. So take home message, do repair them. And obviously weight-bearing protocols can be varied, but we keep them for a varied duration of non-weight bearing, anywhere from 4 to 6 weeks. Range of motion, usually we achieve 90 degree in 3 to 4 weeks on almost all our cases. Take home message, if you repair the meniscus, osteoarthritis will definitely get prevented. Meticulous, biomechanical, strong repair will have a better outcome, especially in zone 1, zone 2. Do make sure you do biological augmentation, not just rasping, trephination, microfracture, notchplasty in the intercondylar notch, but also use fibrin clot and platelet-rich plasma to get this almost 80 to 90% success rate. Thank you.
Thank you, sir.
Thank you.
Any questions regarding that?
I think there's a very good article by Chahla now, George Chahla, that at 3 weeks post-surgery, it makes sense to give it because of the fear of dilution of your PRP with the saline. So it makes sense for cases where, young athlete who has come in to put everything that you have to allow that meniscus to heal. So whether it is rasping, etc., as I told you, fibrin clot, and if in addition PRP, 3 weeks post-surgery. No, so with the ACL there is no need whatsoever, because the entire concept, as we know, is the formation of a hematoma. So with an ACL we've got an excellent hematoma. Whenever we had to deflate a tourniquet in an ACL surgery, we know how much amount of hematoma. And the beauty is, if you see, all that hematoma actually goes towards the meniscus. It's almost as if nature absorbs that hematoma exactly towards the meniscus. So all these techniques are for the non-ACL cases only.
Thank you, sir. Now I would like to invite Dr. Tanmay sir to present the case on buccal handle meniscus repair.
So this was the case. He was a 21-year-old male guy with a history of fall while dancing. He was a dancer, professional choreographer, 6 months back, and had a repeat fall 2 weeks back before presentation, and came with just complaints of pain in the knee after the recent fall episode. Didn't have much instability somehow earlier as what he mentioned, or I don't know whether we may just have neglected it, probably. On examination, he has this medial joint tenderness with lodgement, with anterior drawer, single positive, not very high, not a 2+, and collaterals was stable both in 0 and 30, and his range of movement was restricted beyond 90, very painful. This was his MRI. As evident on the MRI, we could see the double PCL sign, very specifically the meniscus fragment, the middle meniscus fragment had gone locked in the notch, and the ACL was almost deficient as a chronic ACL because he had a 2 episode 6 months back as well. So on diagnostic scopy, this was the finding. He had a locked bucket handle meniscal tear. Seemed like a double bucket handle, was difficult to reduce as well. And if the chairman says, allow me, could it be an interactive session? I can ask questions for that, because that will be preferable for everyone. So I would just stop here and ask any of you, what would be the first thing to do once you get a locked bucket handle meniscus tear, and which is difficult to reduce in position? So what are the methods? Maybe Nagaraj, if you can help.
So the first thing is pie crusting the middle joint, the superficial MCL. That will open up the joint space comfortably. Also, it is better to use a blunt trocar. So your trocar, sheath trocar will help you. And it is better to push at the level of the mid body of the meniscus, the one that is in the notch. A nice force there with the pie crusted will almost always reduce the meniscus. The question is what happens after having reduced the other 3 buckets. So then we'll discuss that as.
Okay. Can you just run this video? It is jumping. Just play this video. Play this video. I am not able to play this video from here. क्लिक करने पे आगे बढ़ रहा है. अभी ठीक है, चलने दो. So as Nagaraj said, yes, we need first thing to do in such kind of tough locked meniscal tears, we need to do a pie crust to make it easy for us to reduce it in the proper position. If you're trying it hard and it is not, at times doesn't go, we can do a pie crusting and then allow it to move inside. Then what we need to do is, as mentioned by Nagaraj, we need to confirm the zone, what zone it is, plan it, whether we're going to repair or what. So what are your ideas, Sheetal, about such kind of meniscus? What you would be preferring, what zone it is? Can you let the delegates know?
I think it's a complete bucket handle tear. If you go ahead with the meniscectomy, it would be almost close to a total meniscectomy. So I think irrespective of age, I would prefer to at least give a chance to repair, even if it's a chronic. So chronicity and age is no more a criteria that the bucket handle should not be repaired. So I will do at least all attempt to save the meniscus.
Okay. More so for the lateral meniscus as compared to medial, right?
Yeah.
In such kind of bucket handle tears.
Lateral will prefer more as compared to medial. So medial, if it is in more of a bucket, which is more extending into zone, I would say 2 or 3, then I may go ahead and do a meniscectomy, particularly for the low demand patient. But looking at this bucket, it actually require a repair.
Okay, with such a big meniscal tear, what would be your plan? Brajesh?
Definitely.
What kind of repair you would be planning to do?
I'll prefer a good inside-out repair. I'll give a posteromedial safety incision. Okay, and I always prefer inside-out repair for this kind of large bucket handle tears.
Okay, so purely an all inside or maybe a hybrid of all inside and all and inside out, Abhishek?
Most of the time I am using all inside technique, even for the posterior horn also. So over a period we are able to exactly guide our all inside needles where exactly to point out using the safe inside out. I'm going to use inside out for all the zones here.
Exactly.
Yeah.
Any specific tips for very resistant, unstable kind of bucket handle tears? How to go for inside out, Sheetal?
I think for such cases, first thing would be to take a stitch actually. Go into the body and take a simple traction stitch so that you can reduce the thing.
That's what
the second thing that I would do is using a transillumination. First I will take that inside out cannula, I will just pass a needle so that I know where exactly my incision is going to come. I will just pass that needle so that there is a marking outside. Because sometimes it happens that your incision is, because this kind of incision should be 3 centimeter below the joint line rather than high. So low incision is always better. So I will just pass the needle, mark it, and then I will start putting my safety incision.
Okay, safety incision is one very, very important incision which you need to take before taking the inside out. If you're planning an inside out, you have to take a proper safety incision, go behind the tibia properly, go inside, reach to the capsule, you're able to visualize it through from inside out. You can maybe while making that inside out in the safety incision, you can push your scope right at the behind and the posteromedial area, and then you can visualize the light would guide you to reach to that place. Just don't do it a blind dissection there, because as you know, there are a lot of structures there, so you won't damage them. Go with the light of the scope and then properly go and dissect up to the level of the posterior tibial capsule. So you should be able to do that. So the next what we did is, as Sheetal mentioned, we did a traction stitch. Traction stitches at times do not work well with the, as said by Nagaraj, but with vertical matters you can take an horizontal material as a traction stitch. So keep it stable and allow it to stay stable with the mosquito there. Then we went ahead and did the ACL reconstruction as mentioned today by Dr. Brajesh, to do the femoral drilling first before doing your meniscus repair. Make proper tunnels. This is what I use. I use simple spinal needle cannula there along with the reamer, over the reamer, so that it takes off all the debris along with when we are doing the drilling and doesn't allow us to do a proper visualization. After doing the femoral drilling, we went ahead and started taking the vertical mattress stitches. You can start from posterior to anterior or anterior to posterior depending on what you choose from. What you can do is initially take a posterior all inside stitches, and depending on what your comfort level is. You have to take initially you can take superior stitches, all vertical matrices. But soon as you keep on doing that, you can see the posteriorly the meniscus is starting to lift out. You have to now start doing your inferior inside out stitches as well to keep the meniscus balanced and not allowing it to just lift off. So after doing that repair, we completed the ACL as we mentioned earlier. Also we have to, while I always do this, while putting my graft passage in, I always see through the EM portal, see my endo button flipping off through the tunnel, and then complete my ACL reconstruction after that. Check for the impingement always. Do not miss that. And this is was my final construct. After it was almost like a double bucket handle. As you can see, posteriorly there was a margin of tear as well. We repaired that as well. So I did it with an all inside and inside out, mostly inside out technique. So any further tips, Nagaraj, you would like to add to it?
I think you covered up very well everything. Only thing is, I always take one meniscofemoral stitch and immediately I take one meniscotibial stitch. So I go in a W fashion throughout the repair, and the reduction of the meniscus has to be as anatomical as possible. So we need to get that flounce. So if you see that you've got that flounce back. So once you get that flounce back, that means you have restored the tension appropriately both on the femoral side and on the tibial side.
Meniscofemoral and meniscotibial both. Any specific tips?
Going from posterior to anterior makes more sense because the posterior portion should be reduced well anatomically as compared to anterior portions. If you go from anterior to posterior, sometimes you feel that the posterior is bunching. So posterior to anterior is always,
here you can start posterior.
Posterior to anterior. So the posterior anatomically reduction is there, and that actually reduces the chances of extrusion even in simple meniscus without root tear if you go from posterior to anterior. It was a study in which when they attempted doing anterior to posterior, there was some extrusion which was left because posterior was not reduced very well. And second is what Nagaraj pointed, I always go in the same way, W fashion. 2 up stitches with a different color and 1 down stitch with a different color.
2:1, that's what I, 2:1 is the ratio which we should follow, 2 superior, 1 inferior, or otherwise.
Once you pull that 2 superior, the whole of the meniscus get lifted. So
Lifted
it's
off.
very easy to pass your inferior stitch.
Exactly. Okay. That's in my case. Thank you.
Thank you so much, sir. Now I would like to invite Dr. Nagaraj sir to present a case on degenerative meniscus tear.
So this is a very confusing topic in terms of the title. So degenerative meniscus tears as such are not amenable to repair, as we know. But there are a few exceptions to that rule. So I've got 1 or 2 presentations which I'd like to share here. So this is a presentation of a so-called degenerative meniscus tear. So it's a meniscus radial tear through and through the body of the meniscus. All of us know that radial tears are common near the root. But what if a tear like this happens through the mid-body? So all of us know that this is one common tear which you see in an ACL tear where there's a radial tear near the root, and you would know that we could do repair. Now, it's very important again, Christopher Hanna, a lot of publications coming out of Pittsburgh, where he mentioned that if you do a meniscectomy in the case of a radial tear, it's as good as doing a total meniscectomy. Laprade has made us understand the importance of the root, made us understand that root tears, if you do a meniscectomy again, there's a very high risk of knee osteoarthritis. As compared to non-operative treatment, repair is always better. So this is a 40-year-old male who presented with severe pain, limp, medial joint line tenderness, normal mechanical axis, no malalignment. That's the radial tear going through and through. So we expect this to be degenerative. However, there are some tears which are traditionally known to be degenerative. For example, root tears, radial tears near the root, and this particular tear. However, the patient has still not decompensated. Their cartilage is okay or just about having some softening. And if you land up missing these tears and not repairing them robustly, then you will land up with osteoarthritis and you will not be able to preserve this knee. So the treatment options for this sort of a tear, traditionally we used to use all inside devices. Then we started understanding that we need to do inside out technique. On the lateral side near the root, we could do a side to side stitch, or is it something else that we need to do? So yes, there's a lot of literature on inside out repair with fibrin clot for these sort of radial tears with good outcomes. But what do you do when a tear is like this? So observe carefully. The tear starts from the white zone. Cartilage is pristine both on femur and tibia, but it goes all the way up to the capsule. So it's as if somebody's taken a scissor and cut through. So 40-odd-year-old male, good cartilage, meniscocapsular junction also, if you see here on the undersurface also, it's a through and through tear. And the minute if you put a shaver, you'll land up with a total meniscectomy. So you need to think out of the box, because obviously to achieve healing in this sort of a repair, traditional devices like all inside will cut through, inside out may not be adequate, and probably this is where Laprade again comes to help in terms of the two-tunnel technique. So he published this two-tunnel technique for the medial meniscus radial tear. So we do this in the thigh holder position, because that opens up the medial compartment. We always do a pike rusting for all our major complex meniscus repairs. I always do it on the tibial side from the beginning, even when a lot of people used to do it on the femoral side, and now I think the trend is shifting. Everybody started doing it on the tibial side. So we get a very good opening when we target the posterior fibers of the superficial MCL, SOS, POL. So we get a very good repair. Now a lot of bulky devices are going to come in these sort of knees. So you need to make sure that there is no additional iatrogenic scuffing by your instruments. So that's the pike rusting. Obviously you're going to do the rasping, which we talked about. You're going to do trephination, you're going to put a shaver, and then you need to plan your tunnel. So there are two tunnels, one corresponding to the posterior flap, one corresponding to the anterior flap. So two tunnels is what you're going to plan. Smith & Nephew has got these dedicated jigs. I've been having this ever since they were launched. So they are there site specific for the right and for the left. And I use them with the PCL depth stopper, because you can't afford to put your guide wire blindly into the medial compartment and risk femoral cartilage scuffing. So that's the position that you're going to see. You then come with your PCL depth stopper, and then you put one guide wire through. There are offset guides, like you can see on the right side image, which helps you to drill at specific offset the second guide wire. So there are two tracks that you want to create, one corresponding to the posterior flap, one corresponding to the anterior flap. This is from the Laprade two-tunnel technique for the medial meniscus root tear, which we are using for the two-tunnel technique for the radial tear of the mid-body. So such two guide wires are being drilled. So the knee flexion is about, I think, 45 or 50 degrees. We are visualizing arthroscopically. So that's going to be the way we are going to drill. That's the arthroscopic image. So very carefully, without scuffing the cartilage, two such tunnels are drilled. So that's the tunnel. You then take the first pass mini and take a ultra braid suture through the posterior limb. You can take a different colored device and take a stitch through the anterior limb. Sorry. So ultra braid posteriorly, co-braid anteriorly, so you understand which is the two suture configurations. And then you dilate with the same 2.4 guide wire, and then you use a lasso-like device to identify that track. You don't have scope to put a 4.5 reamer here. and then you do a shuttle relay. So the posterior flap sutures go into the anterior tunnel and the anterior flap sutures go into the posterior tunnel in a crisscross fashion. So you are creating two tunnels right next to the radial tear from where the biology is going to come. In addition, you are going to do inside out meniscus repairs. Use your regular endo-CL endo button and keep the sutures from the flaps on that endo button and do your fixation near extension. This is the kind of robust repair you get, but you can't rely only on that. You go ahead and do a inside out meniscus repair like we just discussed. You do a safety incision and you do your inside out meniscus repair. You can use single lumen cannulas like this. Now you've got commercially available devices where you can fire the needles through. Previously we used to use only needle holders to push through. So cost effective techniques are available. There's a very good video of cost effective meniscus repair that I have done. It's on YouTube for the beginners if you want to watch. So cost shouldn't be a constraint now for you to do all these complex repairs anymore. So that's the kind of configuration that you could achieve. So transosseous tunnels, inside out hashtag kind of repair, both on the meniscofemoral side and on the meniscotibial side. A robust repair. You then do notchplasty and microfracture. Like Dr. Brijesh was asking, you cannot rely only on the repairs, but also create biology. So now what happens with this particular technique is that the biological factors reach right at the fracture site, at the tear site. Again, post-op MRIs, you can see that that was his previous radial tear. You can see that there is no more signal there now. Those are the transosseous tunnels. And as I showed you in the previous presentation, his articular cartilage is preserved. So in a 46-year-old person with the so-called degenerative tear, we've been able to preserve his meniscus. So radial tears, whether they are in the body, whether they are near the root, now we are capable of achieving satisfactory repair and satisfactory healing. Now if time permits, quickly I'll just show one more presentation which probably is relevant for a degenerative meniscus tear, which is meniscus centralization. So all of us know that the second most important degenerative tear which you're going to come across is a root tear, and more often than not these root tears are going to be associated with meniscus extrusion. So Hideyuki Koga from Japan is the one who needs to be credited with multiple articles on this centralization. So this is a presentation on centralization with extrusion, but primarily it's a degenerative meniscus root tear with centralization. So typical history, 55-year-old lady, the knee is just about decompensating. MRI is showing some cartilage changes. The patient is having pain for about a month or two, and suddenly they hear about a pop from the knee when they are standing from the sitting position, going up and down stairs or squatting. And there is no past history of significant pain. This is the indications that this patient has a kind of a game-changing event that has happened in the knee. And you need to catch it at this stage because they will just not be able to do any loading activity like standing or climbing stairs. Obviously, you need to look at the alignment. If there is a massive malalignment like this, obviously you're going to correct it. Anything above 5 degree is something as a threshold for me to do an osteotomy along with these repairs. That's not something we are discussing today. If it's a malalignment like this, sometimes even you need to do a double level osteotomy. But that's not what we are discussing today. What we are discussing is about the meniscus extrusion and radial tear or root tears. So that's how the extrusion looks on a mid-coronal image. Anything more than 4 mm is a significant extrusion. So that's her report, a radial tear near the root with almost 5 centimeter extrusion. So these are the different case examples. You can have a root tear without extrusion, you can have a root tear with mild extrusion, or you can have a root tear with moderate extrusion. You can also do a dynamic ultrasound because extrusion is a very dynamic phenomenon. So ultrasound can be employed because you can actually make the patient weight bearing and do an ultrasound to confirm the extrusion. Is there meniscus extrusion always with a root tear? Not necessarily, but more often than not we see that. So this is the Hideyuki Koga's article on meniscus centralization. It came out in 2017. This particular case was done as early as 3 months since the article was published. So that's how traditionally we do a root repair. So pie crusting is being done. We identify the medial meniscus root. So that's the root tear. You would then use curved shaver blade, prepare the biology. You would then take antegrade devices and take suture tapes, dedicated jigs right at the anatomical root attachment, create a transosseous tunnel. I create almost a 5.5 mm tunnel, and here again I do eccentric reaming, use curved curettes. So I do eccentric reaming, I start with a 4.5, increase to 5, 5.5, so that I can get more and more anatomical, clear out all the debris. Because from the very beginning I believed that there should be healing, some amount of healing of the tissue in the tunnel, not just on the surface. So I'm not convinced still that anchor techniques are going to work in this particular case. So that's how the initial part of the procedure is basically what you do in a root repair. This is how the centralization is being done. This is now a left knee. You take a mid portal like this. You use your Bankart liberator to remove all the meniscotibial adhesions. You then use a rasp again to remove all the meniscotibial adhesions. When you're doing this, be careful. These menisci are very thinned out, so you can have fraying. You can sometimes have to do a complete release because you need to look at the tape sutures, whether there's too much tension on your root. So your assistant is gently pulling on them. You then use something like an all suture anchor. Try to be as posterior as possible. So what you're trying to do is centralization. You're trying to push the meniscus into the joint. You then use these lasso-like devices and pass through the meniscocapsular junction. Use your hook probe from the medial portal to elevate the meniscus to visualize the lasso. And then you shuttle the sutures. You need to shuttle them in a mattress fashion. You don't want any sutures as such coming all over the menisci, preferably. So mattress sutures, make sure that the knot goes on the capsular side. So this is another video of all suture anchor. Sometimes I have used even 2 anchors, like you can see in this video, if there is significant extrusion. Now I make the assistant pull on the tape sutures and then finish off with the knot tying. You can always do this as after the root repair also. There is some discussion happening as to which is the right thing to do. I still believe that making sure the tension is maintained and tying this makes sense, and then I go ahead and tie my root repair sutures. So you can see under arthroscopic vision, we make sure that the sutures are not cutting through. The sutures are passed in the good healthy zone of the meniscus. You can see the chondromalacia and the softening and the fraying that has started in the medial compartment. And these procedures are perfectly matching for these sort of early degenerative root tears. Does this really work? That's the big question. Does the extrusion really reduce and does it remain maintained? So that's how the portal looks like. We'll not get into the meniscotibial repair. So these are the follow-ups. I give them an offloading brace for after 2 months. They use this for about a year. So that's the pre-op and that's the post-op. You can see that the meniscus root has healed. The extrusion which was pre-operatively there significantly has reduced. And you can see there is a root tissue going across at the tunnel level. So we saw this video. So the take-home message is these sort of degenerative tears start off with the assessment of alignment. If it's something where the knee is just decompensating like a root tear, radial tear or a mid-body radial tear, or for that matter a horizontal cleavage tear, this is another entity which you can repair with these tricks in mind, and always remember centralization procedure for the extruded menisci. Thank you.
Thank you, sir.
Our surgery is live right now, so we can go ahead. Thank you, sir.
Thank you.
Case profile लगा देना.
Yes. Hello, sir. Vinay, sir.
Hi, Romit.
Yes, sir.
I'm visible?
Yes, sir.
Yeah.
Clearly visible.
So I am looking from the anterior lateral portal. So
Yes,
the
sir.
portal which I have taken are the standard anterior lateral and the standard anterior medial portal, because I am going to reconstruct the ACL as well as the PCL. So I need to have global access for the tunnels as well as from the joint. So for the PCL femoral tunnel, I have to take it from the little more laterally. So I have not taken high anterior lateral portal. I have taken a standard anterior lateral portal. And similarly, I have not taken too far medial portal because I need to make, I need to go to the posterior medial compartment through this medial portal also. So ACL and PCL both are torn in this case. Can you see this?
Yes, sir. We can see clearly.
Yeah. So this is the remnant or the footprint of the ACL on the tibial side. This is for the ACL on the femoral side. You can see there is slightly lax remnants of the PCL here, and more or less here there is no PCL ligament there. Okay?
Yes, sir.
So this is the tunnel which I made for marked for the PCL femoral tunnel. So in this case, figure of 4 extension. In the medial side, if you don't extension, flexion, slight flexion, medial meniscus dikhana. This is the medial meniscus which is normal here.
Yes, sir.
Can see it?
Yes, sir. We can see.
There is no ramp lesion, no root tears.
Yes, sir.
Figure of 4. Yeah, you can see a horizontal cleavage tear here in the lateral meniscus.
Yes, sir.
Yeah? I have prepared it for the repair. I'll just put few fast fix over here after making the tunnels to
Okay,
repair
sir.
it. Okay?
Okay, sir.
So I'll just वही चाहिए मुझे. So now I'll make a posterior medial portal. I have placed my needle over here. Can you see this?
Yes, sir.
So knife. So I'll slip my knife over the needle so that I come near to it. And one thing which is to be kept in mind, that while putting the needle and knife in the posterior medial part, the knife should be tied to the handle, because sometimes we have seen that the blade is get unlocked from the knife and left into the posterior middle part. Yeah. So I switched the Visinga rod into this, and now I'll dilate it like is in the shoulder joint. I'll put a cannula over here because this will be my viewing portal for most of the PCL surgery. This is 8.5 mm wide cannula. At any point, if you want to ask any question, you can continue with that.
Sure, sir.
I'll just show a brief history of the patient, sir.
Yeah, you can.
He's a 32-year-old fellow in his left knee, pain instability since last 3-4 months. There has been a history of multiple traumas, but the recent history in October has rendered him unable to walk. He's a cargo truck driver with no comorbidities. And here is his MRI, showing complete loss of both the ligaments and the horizontal tear, as Vinay sir said.
Now, can you see this now? I have placed the cannula.
Shift the camera.
I'll
yes,
pass my RF device and will clear the tissue, will release it posteriorly. Okay. So we need not to go too much medially to create a ramp. We have to be more in the center of the posterior part of the tibia. Approximately 2 centimeter down the joint line.
So Vinay, you always make a posteromedial portal in all your PCL surgeries.
Always,
Yeah.
always.
So this is the point everybody should know, that unless you make the posteromedial portal, then only once you shift into the posteromedial portal, you will be actually able to see the anatomy of the PCL, especially the tibial insertion. So if you want to do anatomical reconstruction, you have to make a posteromedial portal. Then you got option of making a high and low posteromedial portal, a posterolateral portal, depending on the situation, how much is the remnant. So in this particular case, there is no remnant as such. So I think we can very well manage with a single portal.
Yeah.
Second thing that you are seeing, that he is always keeping the radio frequency facing anteriorly. So whatever device you are using from the posteromedial portal, either a shaver or a radio frequency, keep it facing always anteriorly.
Yeah. And now I have shifted my scope into the anteromedial portal. So I am able to see it nicely over here. And I have cleared most of the debris from this part. Now I'll shift my scope to the posterior medial portal to view from the posterior medial portal. Yeah. So you can see this ramp area. This is the medial femoral condyle. And going more medially, we will be able to see the footprint area of the PCL.
So this is the advantage of posteromedial portal. And the second thing that I was telling in the morning, this is a high posteromedial portal. So
yeah,
it gives you that typical bird eye view. So you're able to see whole of the footprint very well.
This is a PCL elevator or dissecting device, which is the most important device which I need for all the PCL surgery or the posterior part surgery. This creates a good interval between the soft tissue and the bone, as well as it is helpful for keeping my wire protected, not going into the posterior part while I am drilling the tunnels. Okay, so now I have dissected enough into down.
So what would be your landmarks for the tibial PCL side?
So tibial PCL, one thing, if you, most of the cases you can see the remnant of the PCL fiber itself.
So PCL, this is one thing that remnants are always usually there on the tibial side, as well as sometimes in this case not there. Otherwise, even on the femoral side, you will have a footprint.
Yeah. And there is a fossa in between both the tibial plateau, and it gives a good idea where is the PCL attachment of the tibia. So now I am deep enough here. Have to go little more into the joint.
So Nagar, would you debride this posterior septum in all your cases to have a better visualization of the lateral extent of the PCL tibial insertion, or
yeah,
depends?
In case if I'm not able to go there,
absolutely,
then only I debride that septum. Otherwise, mostly I try to go do it from the PCL and the medial femoral condyle interval. This is a PCL jig which I am going through in, and since there is both ACL and PCL are not here, so it is very easy to insert these instruments deep inside the joint.
So you see he is almost 20 millimeter below the joint tibial plateau level.
Yeah, you can
that
see
should be the ideal point. And until unless you look from the posteromedial portal, you cannot get this visualization just looking from the interior. So PCL is a posterior structure. You need to see it from the posterior side only.
Yeah. So you can see that I am deep enough to avoid the killer turn on the tibial side of the graft. Okay. So once I have fixed it, there is a jig in the Smith & Nephew which do not allow the wire to go deep inside, or if you have another other devices, you can always measure how much your wire need to go.
One can also calculate the depth, so we can we can avoid the perforation, penetration.
Okay, okay. रुक जाओ, खोलो. निकालो.
So here we are using protector.
Yeah. I need to debride some more tissue. So in this case, I am planning to go with the both soft tissue graft. So I have taken Semity as a quadruple semity for the ACL, and peroneus longus 2 strands plus 2 strands of the gracilis for the PCL. हाँ? मैंने थोड़ा सा सॉफ्ट जो RF दो. To better visualize the things, I'll just clean up some more soft tissue over here.
So Nagaraj, what would be your graft choice in cases of combined ACL PCL?
So I have used the peroneus longus just like how Vinay mentioned, and because in this case I'm very comfortable with the cord, so I'll use the cord for the ACL and the semity gracilis for the PCL. But I'm equally okay with using the peroneus longus if I feel that my semity gracilis is not giving me adequate diameter.
Yeah, because semity gracilis you have to use double or at least triple double gracilis because you require at least 120.
Yes, I always, in fact, if I use a hamstring, it's always 5 strand. So triple semity plus double
But
gracilis.
even with the 5 strand, particularly in Indian
Sometimes it is
patient,
not.
if you will end up in around 8.5, so
I agree.
that's a dicey situation, particularly for the such cases where remnant is not there.
I agree. So that's why I think.
Will you not prefer a CQT with bone plug for the PCL and for ACL a semity gracilis rather than cords for ACL and?
Conceptually, yes. Practically, I find that very difficult because the quad tendon with the bone plug in PCL is always going to be a bit of a challenge in terms of achieving good amount of fixation on the tibial side, especially because the bone plug, because of the length, because the bone plug will be way inside, and you're never sure of your fixation when you're putting your screw. So your heart is in your mouth that you're going to cut through or something's going to go wrong.
Absolutely. Because the tunnel length is 65, so you have to go really high.
Correct.
One more problem, particularly for the chronic cases like in PCL, there are some patellofemoral changes. So that is again a situation where we will like to avoid CQT, particularly with the bone plug.
Correct. So as Sheetal mentioned, there is something called the reverse Mackay effect. So Mackay effect is when we allow the patella to get offloaded. Reverse Mackay, because of the posterior sag, the patella gets loaded. So you have chondromalacia and some changes in chronic PCL cases.
And would you prefer to drill your femoral tunnel first or a tibial tunnel? Any preference about it?
Logically, it makes more sense to drill the femoral tunnel first so that there is no saline extravasation. But I do the tibial tunnel because that's the tougher part of the procedure. My basic principle is I always do the complex part first. So I finish the tibial for that reason only.
We can also use hammer in this last penetration of wire.
Yeah, absolutely.
To avoid. Now we can see wire very well.
So now if you gently hammer the wire, whole of the wire along with the PCL protector will push the capsule.
I'll keep my PCL protector over the wire tip so that the wire does not advance in the posterior side.
So you see, this is the correct anatomical position. You're able to see some fiber of popliteus muscle.
Yeah.
So in PCL, you don't need to go medial, you need to go more lateral because you're trying to reconstitute the anterolateral bundle. So even in the femoral side, you've seen the marking. So in ACL, in PCL, you don't go between the AL and PM bundle. You go exactly in the center of AL bundle. That what Vinay has marked. And similarly, he has gone onto the tibial side. It's quite anatomical. You can see the fibers of the popliteus. So he's more lateral rather than medial or central.
थोड़ा सा मुझे शेवर करना. निकालो इसको भी. I'll just clear off few fibers for proper passage of the graft. Rasp accurate.
So Nagaraj, do you see that champagne draw of shiny white fibers and then go below it and just try to avoid the damage to that shiny white fibers.
100%, because I don't even do the RF device like how Vinay showed. I always do entire dissection from visualization from posterior portal itself, and I sometimes use a low posterior medial portal, use a switching stick, put the entire capsule away, and work comfortably in that area. Then.
So when do you add a posterolateral portal in your PCL? Do you ever add, or?
I think only in PCL avulsion fractures, especially if they are chronic or a little bit older and there's a lot of fibrosis there, and I want to make 2 tunnels. I want to go at that lateral aspect where the popliteus, like you said, 2 tunnels if I want to manage. Or if there is a chronic PCL avulsion fracture which we want to excise and create a PCL reconstruction, and we need 2 portals to excise that large fragment of bone, such cases I don't mind taking it.
So what is one tip, if you cannot manage with single high posterior medial portal, you may go ahead and put a 2, which I routinely do in all cases, high posterior and low posterior medial portal. That will make relatively instrumentation and just pushing the capsule more posteriorly easy.
What I do, I pass SS wire loop from tibia side posteriorly and take it out in front from the anterior medial portal, and then pass it.
And what's your tunnel diameter, Vinay, on the tibia
9,
side?
9. All 9.
Absolutely, good.
Okay, so this is for the PCL tibia. Now, I always make tunnel from posterior to anterior. So, look. Now I'll go for हाथ में लेके मत खड़ा रहो, टीबिया को यहाँ नीचे पकड़ो लूप को. I'll make femoral ACL tunnel. छोड़ दो, कुछ नहीं होगा. Yeah, hyperflexion. So I have marked it. Just a minute. I have made a small mark over the footprint of the femoral side of the tibia. I'll go here. I use the offset guide, 6 mm offset guide, and use it as a guide for our wire for reaching the anatomical position. Hyperflexion. Now I'll go ahead to the hyperflexion of the knee joint. Can you see this? It's going posteriorly. धागा खींचो. खींचो हल्का सा. Take it out. इसको वापस ले लो एक बार. Just to check and confirm the position. Leave it. छोड़ दो. This is just to check and confirm the position. Okay?
Yes, sir.
Offset guide. चल. लो. लगाओ. And you have to see where what is the exit point of your guide wire onto the thigh. It should come from the lateral or anterolateral aspect from the femur. So now, as demonstrated by Dr. Dadaria, we are using this cap of the spinal needle as a cannula to protect the soft tissues as well as taking out the debris from the tunnel. Yeah. It's 40 mark. Yeah, take it out. निकालो बाहर. So this is 40. Okay. So I use fixed loop, so I'll take endo-button CL ultra of 20 mm loop, and we'll drill this tunnel by 9 mm for graft passage till 30 mm. So there will be a 10 mm yeah, 30.
So Vinay is a rigid person. Nagaraj, what about you? Are adjustable or you are too rigid?
No, I've adjusted long back.
And I'm not rigid, I'm fixed. It's a fixed loop. Most of the cases I prefer it until unless I get a very small tunnel.
Absolutely.
Sometimes it is 25. So in that case, I would like to go for with the ultra button. Otherwise, endo button CL ultra is good for me.
We used for many years the EndoCL Ultra, and I think that is very valid even
Yeah,
today.
absolutely. From years it has been giving good
Very
results.
good
So,
results.
yeah.
The only
So
advantage is
can you see the location of the tunnel?
Yes, sir, we can
Yeah.
see very well.
Happy?
Yes, sir.
Okay. So now I'll make tunnel for the
PCL1.
PCL femur tunnel. And as I have marked it in very advance, that this should be the location. Guide wire. Just suture pass karna. I need to pass these sutures. I'll shuffle this sutures from anterior lateral portal to anterior medial side.
And what's your graft diameter on the ACL side?
ACL side and PCL side, both side, khicho so. 9 mm. Both 9. That is a PL peroneus longus plus gracilis. 9 mm tunnel do pehle, little bit. क्या कर रहा है? Drill pill. So this will be my tunnel.
So
I've kept my.
He's using that 9 mm drill as a zig.
Yeah.
At that anatomical footprint. So he's just in the center of the tail bundle. He will put this 9 mm drill, and just through the center of that he will put a guide wire. So this actually is acting as a zig.
Yeah. Okay. Okay. So this will be my tunnel. I'll just check it. Can you see this?
Yes, sir.
So
So,
once
Vinay, are you going to try to do some eccentric reaming? Would you want to come more towards the cartilage?
I'll
more-
just check it where the tunnel is going to be.
Okay.
Because by 9 mm I'll reach by the 9 mm reamer, I'll touch the cartilage, brim. Yeah.
Absolutely.
This is just a guide wire. I'll check it. इसको पहले forward कर दो पहले.
So you are going to be fixed on the PCL femoral side as well, or adjustable?
PCL also fixed loop.
Totally fixed.
बस आ गया आगे. वो 4 mm का ये लो, 9 mm का लेना. ये लेना एक मिनट के लिए, just to confirm the size, location. इसको लो. अरे उसको बोलो कि सर्जरी कर रहा हूँ.
So do we prefer sequential reaming? In such cases?
Yeah. In case if my location is not correct, I'll just make a dent or make a mark on the femoral side to see where my tunnel is going to be. If it is not appropriate, I can change it right now. That's it.
Sir, I want to ask Sheetal sir, whenever we plan 9 mm graft, do you prefer sequential rimming in every case?
In TBL side, always for my ACL, I always go for a 7 followed by 9.
9, yes, sir.
So this on this side. PCL, I use a different technique. I use a outside in fixation again with the screw on both sides. On TB as well as femur, I don't use endo button because passing is relatively is more difficult. So in that case, again, I go for a sequential rimming from outside in. I go for 4.5, then 7, then 9.
Then 9.
So then you got a chance to manipulate your PCL
Yes,
tunnel. And I will just chamfer the posterior end so that the graft passage is relatively easy.
Yes.
So screw fixation I feel is more rigid because on the femoral side the bone is a metaphyseal, more of a femoral, proximal femoral side. So depend on your individual choice.
So when you pass your PCL graft, you pass it from femur to tibia?
No, I first pass from tibia to the joint first. I will take it on through the anteromedial portal and then I will relay to this thing so that avoid passage killer turn is at least avoided.
It's around 45.
Yeah, looks good.
Yeah, I'll take 20 mm loop here and 25 mm graft.
Initially, I used to do the outside in drilling like Sheetal mentioned and the screw fixation from outside in itself. So the problem with the screw fixation is that on the PCL side especially, the graft will turn over the screw.
Yes, sir.
And then you are worried because you need to see the screw tip to be sure that it is engaging through and through. So you get it all the way. And then sometimes you worry because the screw is occupying most of the tunnel and the graft has completely shifted onto one side. So yes, every technique has got its advantages, disadvantages, but traditionally we don't want the screw to occupy the mouth of the aperture. So therefore the inside-out screw techniques also have a disadvantage of occupying most of the aperture. So we need to see what best suits our hands and the anatomy of the patient.
So that is the only place where I will prefer a pick screw rather than a bio screw, particularly for the tibial side, because you know the bio screws, while you are putting a screw on the tibial side, sometimes it breaks actually.
Breaks down, yes.
That's it. ठीक है.
While using a central coarse tendon graft and you're converting that flat thing to the tubular, particularly in the proximal end, the graft diameter changes from like 9 mm to on that particular side 8 mm. So does it worry you sometimes? Like in standard ACL you're using a CQT and while you're doing the whip stitch, the center of the graft is 9 mm but where you have done the stitching is become 8 or 8.5.
Yeah, so you make sure that let us say you have planned to keep about 15 millimeters of graft on the femoral side. You make sure you don't account for the first 3-4 millimeters at all. Because that portion, as you mentioned, becomes very frayed. So you don't account for it at all. Always account 5 millimeter extra.
So you will prefer 20 millimeter graft on the femoral side.
Whip stitch up to 20 millimeters. You showed a nice trick just now. You did it fast for the delegates to catch it. So you loaded both the sutures from the tibial side and the femoral side onto the bead pin.
Yeah. So now our PCL wire is passed. I'll make a tunnel for the
tibial side.
tibia ACL. I mostly use the elbow hammer jig. This is the lateral meniscus, anterior horn, posterior margin, and it medial to this. I think this should be the point of exit of the guide wire.
So Vinay, once you're done with your ACL tibial tunnel, and
Yeah.
probably if you can quickly show the graph passage of PCL, we will sign you off
Yeah,
and we'll move
sure.
on to our lectures.
Sure, sure. So I'll just check that the tunnel is in the center and it is well posterior, it will not
Yeah,
impinge
looks
in the
perfect.
tibia. Yeah?
There is no impingement.
Okay.
Vinay, what was the angle of your jig for the PCL and for the ACL?
For the ACL, I keep it 55 degrees, and in the PCL, it's about 60 degrees. Yeah.
So if there are any quick questions for the PCL before we say goodbye to Vinay.
Yeah.
Anybody in any questions for the PCL? Femoral, tibial tunnel, fixation, graph passage, any questions?
Take it out.
You got 2-3 minutes because by that time Vinay will fix everything, ACL, PCL. Good job, Vinay.
Yeah. Thank you. I'll just now you want me to pass the PCL graph?
PCL, yeah,
Okay?
we will not see the passage of ACL because we will move on with the scientific program. Then we will take a break for the lunch.
Sure, sure, sure. I'll just pass that. Give me a spinal cap. I use this spinal cap for cleaning the debris.
Yeah, so this debris should be cleared very well in all your ACL, PCL, whatever surgery you're doing, because that will lead to recurrent synovitis.
Okay. So, yeah, hold this. Muझे graft दो पहले. PCL graft. So mostly, in most of the cases, I am able to pass the PCL graft very easily because the tunnels are not at acute angles. Loop दो ना? 20 के लूप दो जब फटाफट. हाँ. पहले से खोल के क्यों नहीं रखा तुमने?
Sir, do you use same tibial jig angle in avulsion cases?
Yes, angle of the jig is same, and angle of jig is actually variable. It should be kept in mind that both the tunnel of the tibia, ACL and tibia PCL should not collide with each other. That is to be taken care in this case. Otherwise, in PCL avulsion case, when I use two tunnel suture bridge technique, pull through suture. So in that case, that angle actually doesn't make much difference in the jig. Na? So this is a 20 mm loop. 20 mm loop.
Yeah, Vinay, we are appreciating it. Good.
So now the sutures are here. So I take 2 or 3 gauge pieces to pull the sutures. Okay. Can you see? This is going in.
Yes, sir. We can see.
चलो पुश करो वाटर पुश. ये तो चालू करना. This is in. Can you see this?
Yes, sir.
Yeah.
in. And now the button is flipped.
Yes, sir.
Yeah. So you can see the PCL?
Yeah, absolutely.
Yeah.
Perfectly anatomical, Vinay.
Yeah.
Good job. So we will, if there are any questions?
Yes, sir.
I'll just finish with the ACL and the meniscal repair.
Yeah,
and come
probably
back.
we
Sure.
will have an end look of your surgery. We will just sign off for our last lecture before the
Yeah,
lunch break.
sure, no problem.
Thank you for a very, very nice demonstration.
Thank you.
Thank you, sir.
Big pain for the ACL.
Now I
Thank
would
you.
like to invite our next presentation that Dr. Sheetal Gupta, sir, for root repair and ramp lesion.
So quickly, meniscus root tear. So as we know very well, the meniscus root tear is nothing but it's a detachment of meniscus from its anatomical attachment or within 1 centimeter. So clinical diagnosis is already pointed by Nagaraj that it is usually seen in middle to old age, twisting of knee while standing from a sitting position, a baleful popping, and ekmesis sign, which is a joint line tenderness in extension which disappear in the flexion, described by ekmesis in OJSM 2021. These are the 3 points for clinical diagnosis of the root tear. MRI, this is normal. As a normal MRI, you can see a cleft sign in the root tear, you can see a giraffe neck sign, you can see a ghost sign, which all indicate that there is a root tear. There are certain indirect signs for the root, that is a parameniscal cyst, meniscus extrusion, and a subcondylar linear bone marrow signal intensity. Extrusion of greater than 3 mm are associated with tear of posterior meniscus root. Extrusion correlate with the disease duration and is associated with the progressive osteoarthritis. The first root classification was given in long back in IGO 2000 by our own Indian surgeon, Dr. Nicholas Antau, which he is classified into type 1 and type 2. La Parade has described this classification proper in AJSM 2014 by type 1 to type 5. So we were seeing all this kind of a tear. This was a type 1 which was a partial tear, type 2A with 0 to 3 mm, type 2B was more than 3 mm. This is a complete tear. Type 2C was around 6 to 9 mm from the root attachment. Type 3 is a bucket handle tear along with the root tear, and type 4 is an oblique tear which is extending up to the root. Type 5 we were seeing is a root avulsion. So in day-to-day practice we were seeing more types of roots, so we have extended the classification into type 6, type 7A, B, and type 8, which has been published in Journal of Arthroscopy. So these are the 3 classification. We were together in Jaipur this time. So the type 1, the partial tear was seen in the 10% in our cases, but in La Parade original it was seen in the 7% of the cases. Type 3 was relatively rare. Type 6, 7, and 8 we were seeing in 6, 5 in the 3%. So type 6 we have described as a horizontal cleavage tear along with the meniscus root tear, which can be seen both on the medial side as well as on lateral side. So this is a case in which there is a lateral meniscus root tear along with the horizontal cleavage tear. So this are rare type. This is a type 7 which I have shown one case in the morning. This is another case. There is a root tear along with there is a meniscocapsular separation, that is a root tear along with the ram tear. Type 7B is basically similar lesion in the lateral side. Type 8 is a complete loss of the meniscus. You can see this is extending more than 1 centimeter, and the loss of meniscus is right from the root, extending more than 1 centimeter. So these were the 3 types that we have extended. Now this kind always require a repair because meniscus root is equivalent to a total meniscectomy and lead to progressive osteoarthritis. So what you need to do, a patient who is coming to you for the root tear, you have to see for the alignment, and if there is a varus alignment, you have to go for a root repair along with a high tibial osteotomy. So this can be done using a pull-out technique. So pull-out technique, what Dr. Nagaraj has described just now, you have to make a tunnel. You can use a single tunnel technique or a double tunnel technique. This technique can be used both for the medial side, using a different kind of a combinations, or similar technique can be used for the lateral side as well. So another technique is a root repair with a suture anchor. Anchor has got its own advantage. You don't need to put the suture anchor where you are debriding, so you denude the cartilage, so there is a good healing of the root. Anatomically, you see that meniscus is lying flat on the tibial surface. It doesn't go into the tibia, and you have to just use a kind of a double-loaded suture anchor, which you can use a simple all suture anchor, and The advantage is this fixation is very, very close to the root. The pull-out strength is equal to the root repair by a transtibial technique, and there is no bungee effect which is seen with the long tunnels. So this is how we do centralization using a suture anchor. So if suture anchor works in the Bankart, it works in the centralization, it should work in the root as well. So repair for the type 6, type 7 and type 8, which were the different atypical meniscus tear. So what we have done for the horizontal cleavage, we have used a continuous circumference compression stitch, and for the root tear, we have used again a suture anchor. So using a suture anchor will avoid an extra tunnel, particularly if you are doing a high tibial osteotomy, or if you are doing a cases in which there is a tear on the medial side as well as on the lateral side, and along with the ACL. So a simple technique in which you just put the suture anchor and use a multiple half hitches. Another advantage, you can use a mattress configuration, simple configuration, you can use a ripstop configuration, particularly if the root quality is not good. Type 7, that is a root with the ramp lesion. For that particular cases, we use a double tunnel technique. So it's a basically two tunnel technique, but in the two tunnel, we are not using the two tunnels actually, we are using an anchor on one side. So you see, we will use, medially we will use one anchor, and on the lateral side, we will use a tunnel. So this is more of a hybrid technique in which we are using a suture anchor as well as we are using the tunnel as well. So once you are done and you have passed your suture anchor, then you can just take a bite. Like I shown in the morning, there was a different case. You will take the bite from the capsule as well as you will take the bite from the root as well. And once you do, you pass a suture lasso through your tunnel, and you take all the suture and relay your all the suture which you have passed via anchor to the root as well as to the capsule for repairing root and the ramp. Once you pull, you see there was a lot of meniscus extrusion. Once you start pulling it, everything will come back to its original position. He was having a MCL tear as well, which was reconstructed, and later on you can see there was less opening and the root and the ramp was covered together. Now type 8 was something which was really atypical for us because there was a loss of substance. We were not sure what to do in such cases. We have gone to the literature, and for such cases we have done a root reconstruction. You cannot repair this root. So for repairing such cases, we use the gracilis graft. You can use a Perinus or Semiti as well. So we have done the two tunnels. The first tunnel was close to the body of the meniscus, then second tunnel was exactly at the anatomical site. And through this 4.4 millimeter tunnels, we have relayed this gracilis graft, the double gracilis graft, and we have passed through both the tunnels. So this was independent of the root. And now we have, what we have done, we have tied this graft with the capsule, we have tied this graft with the remnant of the meniscus to make it a single entity. Still this is in more of a, I would say in a more of an experimental stage because we were not having any choice. So you can do a root reconstruction in the original technique which is described. You pass that gracilis graft through the meniscus substance, but we were worried if you pass, then there may be cutout of the meniscus. So we have done a complete reconstruction of the root and then joined this using a fast fix, the body of the meniscus and the capsule and the graft that we have used for the reconstruction. So this way we need to have a follow-up. Another technique that we have described, which is again published, is a double row root repair technique, in which we use the first row as an anchor and the second row as a knotless anchor. So that will give a better healing. It will give a better stability because it's equivalent to, again, the two tunnel technique which is described by the Laparet. So equivalent to the two tunnel technique, we are doing a double row root repair technique using the two anchors. One is a knotless anchor, one is a knotted anchor. Again, the same hybrid technique that I have shown you. Again, this was a patient, again with the same type 7 that we have classified the type with the root as well as a capsular disruption. So these are the three cases already I am showing today with the type 7. So it's not so rare to see this rare type of root which is involving root as well as ramp. You can see again using a hybrid technique, using anchor, then pulling it back, everything will come back to its position. So again, it's being published in Journal of Isocos, a hybrid tunnel technique, double row hybrid tunnel technique. So anchor gives the advantage of there is no bungee effect, no interference with the bone tunnel, and less elongation of the suture. So this is the protocol for the root repair, grade 1 to 3. You can conserve very well. If there is a varus alignment, you need to do HTO. If there is a neutral alignment, you can go ahead and do a root repair alone. Thank you.
Thank you, sir.
I will go for my ramp presentation, or there will be some questions and then.
Is there any question regarding the root repair?
I can go for the ramp, then we can have questions, I think. Okay, sir. So ramp, it was originally with Dr. Pankaj Vyas. He's not there probably. So I have taken his lecture of this ramp repair. So this is nothing but a capsular detachment of the posterior end of the medial meniscus. Is a frequently missed. That's why it is called as hidden lesion. So it is diagnosed by a fluid signal bone bruise on the posterior medial aspect of tibia. You cannot see this lesion from the anterior aspect. So what you need to do, I am looking from the anterolateral portal, I am palpating the superior as well as inferior surface of the meniscus. I will go into the posteromedial compartment. Then you can see there is a huge ramp which I would have missed if I had not gone into the posteromedial compartment. So now doing a needle test, I can see this is a huge ramp lesion which need to be addressed. So you need to enter into the posteromedial compartment. What you need to do is enter into the triangle between the PCL, MFC and the tibial spine. First do a valgus force in the flexion, then in extension. Then do a slight internal rotation. Then you will be able to see whole of the posteromedial compartment. Then you can, using a transillumination, you can put a needle and you can do a needle test that will confirm whether there is a ramp lesion or not, which has been shown in the morning beautifully by Brajesh. So this is again another patient. Everything look fine, but what Brajesh has pointed, until unless you do the needle test, you will not understand that there is a lesion or not. So this is looks normal. Another patient, once we do the needle test, everything looks normal, but you see on the careful doing a needle test, there is a huge ramp. So by looking, everything was looking normal, but while doing a needle test, then we realized that this is a ramp lesion, which needs to be addressed. So Thunet has classified very well into different types, type 1, 2, 3, 4, 5, 6, 7, 8. So these are the different type you can see, and we have simplified by reclassifying into stable and the unstable tier. So stable tier are the classification in which unstable tier in which the tibial condyle is exposed. On probing, there is a displacement of more than 5 millimeter. There is a abnormal pivot shift, which you can see arthroscopically. On flexion extension, there is a movement of the meniscus. You can see this is a pivot. Knee is pivoting. So there is a reduced space between the femoral condyle and the tibial spine. And on flexion extension, the tibial condyle is exposed. So these are typically cases in which the meniscotibial ligament is exposed. So these are all unstable ramp which needs to be addressed. So surgical option is you can use a suture lasso along with integrate suture passing device. If you're not able to negotiate, then you can use a simple suture lasso. With a suture lasso, you can pass the sutures in one go and just relay the suture and do alternate half inches. So these are the technique in which you are using a single posteromedial technique. So the disadvantage for the single posteromedial technique, although we have done the repair, but on seeing from the high posteromedial, we have realized that still there was some ramp which was still left. So from low posteromedial portal, we are doing a further repair using a suture lasso. So routinely for all ramp repair, we use a two-portal technique, high posteromedial portal technique and the low posteromedial technique. Again, we have published it as a no implant pass, park and tie technique. So in this technique, you can see very well there is a ramp lesion, which you are able to see from the posteromedial aspect, but to see it completely, we will put a low posteromedial portal. From high posteromedial portal, we will put a Wissinger rod. We will switch our scope. Now see, we are able to see it something like a Bankart's. We are able to see very well that there is a huge ramp lesion. So we use a scorpion device. We pass through the meniscus, and then we pass through whole of the capsule and include the bunch of some portion of the meniscotibial ligament as well. We are taking the full thickness of this capsule. So if meniscotibial ligament is disrupted from the tibia, we will use a suture anchor. Otherwise, this meniscocapsular repair is sufficient. Now we are parked it into the anterolateral portal, because if you tie it right now, you will not be able to do the passage of the next suture. So you keep on passing till the time you are finished up with whole of the ramp. Again, pass the second set of suture into anterolateral portal. Again, use the scorpion, take the third bite. Still, we have not done the tying yet. So you can use a scorpion, you can use a simple suture lasso kind of a device if you're not comfortable with the scorpion. But doing it as a passing and then parking will give you advantage that you can pass the next set of suture very comfortably. Now you can start tying from medial to lateral or lateral to medial, it doesn't matter much. Then use a suture cutter. So you can see by doing this technique, we have used the 3 sutures, and on probing it looks quite stable from high posteromedial portal. From low posteromedial portal, this probe is coming. So to avoid the 3 suture, we have modified the technique and named it as a shoeless technique, which is published in Video Journal of Sports Medicine. Again, looking from the high posterior portal, my scorpion is coming. So this is the first suture, so I'm taking one, bite number 1, then 2. So 1, 2. Then the first suture is loaded again on the scorpion, then taken the bite from the capsular side, then suture number 2nd, I label it as a 1 and 2. I mark it with the methylene blue or from a marker so that I identify which suture I am taking. So I am just keeping alternatingly on going from the meniscus side and to the capsular side. So with a single suture, it will give a watertight closure, which will give a better healing. And once I pull it, you can see it looks like a shoelace, so that's why I named it as a shoelace technique. Then you can simply use an alternate half inches, and your repair is just finished with a single suture, which is a cost-effective technique. If you have to use an all-inside device, you have to use at least 3 devices in such cases, which can be managed with a single suture. So to conclude, the posterior portal and the needle test should be done routinely during a ACL reconstruction. If you fail to diagnose the ramp lesion, it may lead to concomitant ACL reconstruction failure. 2 portal will give a better visualization, and there are simple techniques which are inexpensive, implantless, quick, and give the better stability. Thank you.
Thank you, sir.
Sir, before question and answers, the surgery is done now, and Vinay sir is ready to show us the results.
मुझे उधर का audio नहीं आ रहा. शीतल.
Yeah.
Sir, can you hear us?
Hello, शीतल.
Yes, Vinay, we are here.
So this meniscus is repaired using fast fix.
Just wait for a moment. We are still not live.
Aniket? Yes.
Yeah.
Yes, sir, we can see you, sir.
You see this? This is repaired well. Okay?
Yeah,
and
absolutely.
and ACL and PCL reconstruction is done also. Okay?
Excellent.
Thank you,
Excellent,
sir.
Vinay.
Thank you.
Awesome, sir.
Thank you, sir.
Thank you, sir.
So is there any questions regarding
Any
meniscus,
questions to
root
Dr.
and
Nagaraj
ramp?
regarding that meniscus repair, degenerative repair, bucket handle, root, ramp, anything
Any
about the
meniscal
meniscus?
question?
Just for discussion purpose, in your variety of techniques that you have shown very well, how often have you seen that after finishing off your posterior work, when you come into the anterior arthroscopy and put your probe on the meniscotibial side, not on the meniscofemoral side because you've got a very robust repair. On the meniscotibial side, you feel that your meniscotibial ligaments are still loose. And how much importance you give that to restore?
So any time if meniscotibial side is lifted, I will always add on an inside-out repair in such cases. Because whatever you're doing is basically meniscofemoral, because ramp is a meniscofemoral disruption basically, primarily. So if the meniscotibial side is damaged, you have to add either a reverse fast fix onto the undersurface of meniscus like you do for all inside out, or you have to go for an inside out stitches in all cases.
So when we talk about ramp as an entity is on the superior surface. But when there is a through and through tear, only then you can do all these techniques.
Yeah,
Otherwise
absolutely.
it's never possible.
Absolutely.
So that it effectively means when there is a through and through tear, it involves the meniscotibial side also. Because in my experience, what I've seen is whenever we do all these techniques on the femoral side, anteriorly, I'm not very sure that not putting a stitch is okay. So I always make sure that on the tibial side also there is a repair.
So once you're taking the bite from the capsule, the bite is actually quite thick and it actually takes the part of a MTL as well. Because if you're using a suture lasso or even if you're using a scorpion and taking a dip bite, so once you go anteriorly, you see that everything is closed up. So if everything is closed up, then nothing needs to be done. If it's still there is a thing, you can add on inside out stitch. This is basically preventing, you see, the original La Parade is, even for the ramp, they are using an inside out technique. Up, down, up, down, up, down. But for ramp going so much posterior, it's very, very difficult for inside out, one thing. Second portion is using a fast fix kind of device. You have to actually use a lot of device, like Brijesh finished up using 5 today morning. So he used 5 for that kind of a tier. So in typical Indian setup, for 5, putting a 5 is really, really expensive job. So this technique gives you advantage, like it's a relatively cost-effective technique. There are no implant per se. You are able to see everything directly, and if still feel that anteriorly something is there, you can add on the stitches.
I feel that the ideal indication for an inside-out repair is probably the type 5, no? Type 5, where there is a root, where there is a ramp, extending, becoming a bucket handle.
Absolutely.
I think the inside-out repair is ideal for those case scenarios. And having done inside-out, even in those cases, I feel that with practice, of course, this is only when you have done quite a few cases, even near the ramp, you can do the inside-out repair. Now, just a point, again, for discussion purpose. Many a times what happens, there is a ramp tissue at the level of the meniscus, and sometimes the ramp tissue has fallen down. So for the fallen down technique, anything that pulls it up makes sense. But if it's at the same surface and there is no need to pull it up, then an inside-out repair also can be done.
Yeah.
And here it's valid to mention Dr. Anand Joshi's technique, where he's actually using the inside-out with a grasper from posterior and lifting it up in every.
Absolutely.
That is again making it even more difficult.
Yeah.
But I think it's important to understand this entire concept in the repair.
So absolutely. So the only problem is, like, if you're using a fast fix kind of device from the anterior, you actually need to use a grasper or needle to just lift your capsule so that both are at the same level, so your fast fix actually holds. But once you're doing that, you're not able to see posteriorly because you're passing it from anterior. So you're able to see the meniscus, but you're not able to see posterior. So you're actually lifting, but you're not sure whether that fast fix is actually holding that capsule or not. So I think just with the, like we do in the PCL, high and low posterior middle portal gives me the better visualization. That's why I shifted to.
Thank you, sir. Any other question? So now we will proceed for a lunch.
We'll start with session 3 after lunch.
After lunch.
Okay. I thank you, Dr. Romit sir, Dr. Meena sir, Dr. Ravi Gupta sir for their moderation. Thank you, sir. सर आगे बढ़ सकते हैं।
Continue with the session now. Anupam sir. I call upon Dr. Devanshu Goel sir, Viren Chandore sir, and Arjun Jain sir to be the moderator for this session.
root with high tibial osteotomy?
Hello. Good afternoon, everyone. So I'm presenting here a case of medial meniscus root tear along with HTO. So this is a 48-year-old male who presented with pain in his right knee since 3 months. And there is difficulty in bending knee and he is unable to do squats and sit cross-legged. There is no history of a significant trauma. It was a trivial episode that he had a little bit of pop while getting up from a sitting position. On examination, medial joint line is tender, flexion 90 degrees quite painful, and otherwise joint is stable, no hyperlaxity, and patellar gliding test and patellofemoral joint is normal. So let's take this case as a case for discussion one-to-one. So Tanmay, what would you like to do next for this case?
It is in a proper standing AP, single leg weight bearing X-rays,
Okay.
along with a valgus.
So this is the X-ray.
Skyline I can't see, but I think you said already it's okay. Scanogram.
Any comment on this X-ray?
Slope is okay, but anyways the middle there is no
Required.
it's
What are you
actually
thinking this patient can have? What is the diagnosis, clinical
It's a
diagnosis?
clinical way with a degenerative medial meniscus posterior root tear could be because of the patient is having pain on flexion. That is
Okay.
one thing. That could be because of the bone marrow edema. That could be because of the cartilage loss. That could be because of the root tear.
Okay. So what next for this patient?
Would get in a MRI and a scanogram straight away.
Okay. Scanogram, you would like to go straight away or only for MRI?
Stress X-ray I would prefer.
That's what I said.
Stress
X-ray.
X-ray.
Valgus stress X-ray.
Patient doesn't have any hyperlaxities. Gait is almost normal. There is very minimal thrust which is there. Okay. Okay.
Divyanshu,
Okay.
would you consider this case because this, I mean, there are few surgeons who does plasty, UKR, and
I was coming to that, so I would always do a valgus stress view just to see how tight my MCL is because it's almost bone on bone. So I would like to see a valgus stress view.
His
not
knee
just
is
bone.
quite stable.
So still you are thinking something at the age
No,
of
no,
48
no.
in the
I am not thinking.
Valgus stress view.
No, but if Tanmay, if you're not thinking in the terms of UKR, valgus stress say is anything is there. Anyway, you are going to get an MRI in which will show the status of lateral cartilage. So what is the significance of Divyanshu? So for all UKR, you will always go for a valgus stress view to see
Do a valgus
whether
stress
this
view if I'm
correctable or not.
If it's always in the back of my mind, so I would always do a valgus
Would you
stress.
comment on the lateral, like say, how do you see in the UKR and what is
Yes,
the?
yes. So
it's
I
more
do
of a
not think,
AMOA
yes,
or
it
it's
is
a-
not looks like an indication for UKR because on the lateral X-ray, the tip, it doesn't seem like there is anteromedial OA here.
48.
48.
So depending upon the physical activity, the actual, like, I will not go by the number, I would go by the activity and the demand of the patient more than the number of the age, like 40
So
or
it's
50.
more of a physiological age
Yes,
that you are
physiological
going to
age is more important.
So MRI, I think would.
Okay, here's the MRI of the patient, which shows the meniscus, medial meniscus root tear and the changes
Go
of.
back to MRI film
And the changes of medial compartment arthrosis.
Absolutely. So it's a MOA with PCL and ACL is absolutely normal, and you see there are a lot of bone edema is also there both on the tibial side as well as on femoral
So I would
side.
discuss the options with the patient, what he wants and what his activity level is, and accordingly, because this is showing anteromedial OA, very classical.
This is the scanogram of the patient, which shows the MPTA on the right affected side 80 degree and LDFA 85. So it's basically a, almost 7-degree deformity, completely varus is in the tibia only. Okay, femur is almost normal. These are the intra findings. Complete root tear which is there. Almost grade 2 arthrosis. Actually the compartment was very tight. We have already done the pie crusting, so we can see this.
So I think
So this is the meniscus root
if
tear.
I am planning a STO, I will not do pie crusting. Anyway, I am going to open from the medial side and release my MCL. So I will not directly jump to root. First, I will do my basic preparation of STO. So MCL is released. Now you can go very well inside and then you can do your root.
Okay, so you want to take it these stitches afterward.
Yeah, because once you do everything on the medial side, then the joint is so open that you can actually use any kind of instrument very comfortably.
Okay.
And with the pie crusting, what will happen? Anyway, you're going to release distally that MCL. Now you're doing pie crusting at upper level, so there would be MCL would be disrupted 2 places.
Okay. Stop.
No, I'm talking about do the exposure. You have seen that there is a root repair. You just do the exposure, release the MCL, prepare everything, don't start your STO, go back in the joint. Now everything is very simple.
Already you have opened medially because we have exposed.
Exposed, yeah. Open MCL release, then go for. Yeah, so that life will become very easy.
Okay.
I mean, just a tip basically. If STO you want to combine.
So we have done, after taking these stitches, we have not fixed the root yet, and we have done the STO and fixed this with a plate. So these are his post-op X-rays. And this is the result at 8 weeks. There is no medial joint line tenderness and flexion extensions completely free, painless. And this is his walking ambulation status at 8 weeks.
Do you keep these patients non-weight bearing for?
Non-weight bearing for 1 month. If I put a Tomofix, then I can start them partial weight bearing right from next day also. These are the Indian plates.
Along with the root repair. Along with the root repair, you will make him bear weight.
Yeah.
So will it change the protocol post-operatively or not?
Yeah, definitely it will change the protocol. At least 1 month non-weight bearing. This is his walking status. Right knee has been operated.
So Devanshi, you can see the physiological age. Still, you would
It's
like to go for
completely
UKR or
pain-free,
STO.
walking without pain.
He's got wonderful result at 8 weeks. His knee is absolutely neutral. Looking at his profile, probably he would want to squat, sit cross-leg. He want to do all
That's
his
what. So I would ask and discuss with the patient what his demands are, and accordingly I'll take that call. And I do have that bias for plasty, but then it's never a bias as far as the decision-making individual for a patient is
He's
concerned.
like a farmer. I forgot.
So
to
I would
mention.
go for a
heavy
HTO,
labor.
Yes, yes.
So that is the message basically, because for the male patient, particularly young age,
Yes.
I think even with relatively bone on bone, you can always explain the prognosis and at least save the knee doing a high tibial osteotomy.
Exactly. Any questions regarding this?
How do you pass your screw? Like root, you already made the tunnel, so how you can avoid that root? Have you used some, can you give some tricks or tips? Like once
the
you are
one
doing
screw, 1 or 2 screw will give you the problems in the plate which you are putting anteriorly. So most of the time we require to take out 1 screw if it's impinging in that. Plus we are putting that Indo button or fixing those threads on the other side on the lateral aspect. So most of the time, one screw need to be, we take out one screw, and then we reinsert that screw. And during that, those threads, we prevent those threads by putting 4 mm drill bit over the thread, so that while again tying the screw, it should not cut those threads.
So that is the best idea. Put your endo button drill itself
Exactly,
inside, so that
exactly.
screw doesn't cut your threads.
Exactly.
So what's your opinion before we go for a root repair? You just make a tunnel and afterward you put screws and all. Before, after HTO?
No, we only take the, I have taken here the stitches only in the meniscus root, which I have fixed after fixing the plate.
Yeah.
Then I have drilled the tibial tunnel.
Okay.
Position of what? Tibial tunnel for root. No, it should not compromise. We are going to use that jig exactly at the site of the root, and we can change the side.
You gone from the lateral side, right?
Yes, I have
He's
gone
from
lateral
the
side.
not from the medial side.
Yes, sir. It's a great, I think, 2C type of tear. I mean, it's completely, the patient has got main complaints of having pain during flexion, severe pain in the flexion. So that is because of this root. It's like half-hearted job. Half-hearted job. Root repair takes just hardly 10 minutes of time. Root repair doesn't take, it's basically the HTO which is taking time. Tunnel management is, that's where it takes little bit of time. Last issue you need to take out, then again drill tunnel. Okay, good idea. Yes. So that's.
I prefer, if I do root repair along with the HTO, I use biotic plate. It has a variable angle construct in the screw side. So it gives me freedom to adjust the size of the screw in the plate.
This is the same plate.
Yeah.
We have used the variable angle plate.
In that case, I put a drill bit or a guide pin into the tunnel of the root repair, and then I put the screws.
Exactly what has been done here.
So okay, you have made the tunnel beforehand, before doing fixation with the HTO plate.
After fixing the plate, I have made the tunnel.
So I make tunnel first,
but
and then
when I
fix the
came
plate.
to know that it is impinging or it's converging in that, then I take out the one screw and then put in the drill bit there.
Okay.
Yeah, a little bit.
Plate, yes.
Screw direction we can change always.
Yeah.
Or we can keep it there. Same thing. Thank you.
Thank you.
Thank you.
Yeah. So in 5 minutes we are going to start the live surgery. Any case presentation or we can go to the lecture?
Sir, one question from my side. How often do we tie those root threads to the implant itself, to the plate itself? Do you guys do it?
How often?
I want to ask if you guys do it or not. Are you tying those
Get your
threads?
question.
Are you tying those threads to the tomofix or the plate, or use a separate endo button for it?
The planes are totally different. Your tunnel is not going to be that medial.
But we can tie those threads. No,
Why do you want to do that?
Additional fixation? Is this a valid concept?
Fixation for?
I just need to ask if this is a valid concept.
Like all the threads are out. Now there are two options. Either put an endo button, or if you don't want to put an endo button, there is a plate below which you can take your threads and tie. The only issue is that the security of that knot is not much, because plate is not going to make it stable. If you fix it with the plate and then just try to move your ethibond up and down, you will see with the artery everything will move up and down. So that's why better to use a separate fixation. Don't fix it with the plate. Yeah.
सर आप सब आपको सुनना चाहते हैं सर
हो जाएगा, then it will make more sense for the rest of the audience about the surgery also. I mean, if somebody is not that well oriented with shoulder.
also I have seen Vinay sir doing 3 screws distally for that plate and Kalanti sir have fixed 4 screws. Does this make any difference? No? Doesn't?
For that, what I do is I don't put a locking drill bit for that cortical screw. I put the normal cortical screw, and after that, on that only you're able to negotiate a locking screw. So don't drill it again. So then your hold will not be compromised.
So this is a small lecture regarding the successful cuff repair and why it is important, because the spectrum of disease is variable, and these tendinosis becomes partial tear and then complete tears, and it can lead to cuff arthropathy also. So timely intervention and identification of the cuff tear is important, and after repair, failure rate is very high in the rotator cuff, because most of the cases we see the chronic cuff tears and the patients are usually in the older age. So it becomes very important to understand how we can how we repair that it should heal it. Otherwise there are a lot of problems after failure. So because of low cellularity, degenerative changes and poor blood supply of the enthesis, there is a high failure rate. And in the muscle there is a inflammatory cells, so there is apoptosis, muscle retraction and fatty infiltration of the muscle belly, which also makes it very difficult situation to heal, and results are usually poor in case of the chronic cuff tears. Usually in the first phase there is an inflammatory response in around 1 to 2 months, then the proliferation, and after 3 months only the cuff starts remodeling. So in the rotator cuff tears, the rehabilitation should also be considered, because early rehab sometimes leads to poor failures. Factors that affect the healing of cuff is basically the age, tear size, fatty infiltration of the cuff, muscle tendon retraction, and other factors like smoking, osteoporosis, hypercholesterolemia and diabetes. Surgeon-related factors, there is a debate on the single bundle or double bundle, single row or the double row repairs, and the rehabilitation. And biologics that can affect this, studies are coming that the platelet-rich plasma, the PRP injection in the cuff, or BMAC in the cuff can give better results for as far as healing is concerned. So patient-specific, we cannot change the age, but it is important to understand if the age is more than 65 years, then the chances of healing are poor. So we have to consider this thing before committing to the patient, and considering the age is very important in terms of rotator cuff repair. Tear size, large tears usually have a poor outcome in comparison to the small tears. Fatty infiltration, Gotelier grade 2 or the higher fatty infiltration has significantly associated with the high poor healing rate after repairs. Retraction, retraction has a role in case of it is a chronic retracted tears. It is very difficult to bring them back onto the footprint, and if you over tighten or overstretch the tendon to repair, it usually fails. So the tension on the repair should also be the minimal, and over tension should be avoided. As far as literature is concerned, there are literature which supports the double row repair in many cases, but there is no significant difference has been observed in terms of functional outcome in single versus double bundle technique. Early aggressive rehabilitation have been shown to result better early outcomes in early aggressive rehabilitations are also associated with a higher incidence of tendon re-tear. So that has to be balanced. PRP, bioinductive materials like Regentin patch, and these things are also showing good results for the tendon healing. So to prevent the structural failure, the tendon suture interface should be strong enough, poor tissue quality should be considered, and there should not be a gap between the bone and the tissue. Anchor fixation, which is very important. In case of the bony bone quality should be considered. Osteoporotic bone has poor pull-out strength for the anchors. So in such situations, we should usually use screwing anchors and anchors with a larger diameter so that they can hold well. Once you try to repair this repair, you have to understand what the pattern is, because understanding of the rotator cuff tear pattern is very important in the repair. Sometimes it's C shape, L shape, reverse L shape, and sometimes these are the irreparable sort of repairs. So you have to identify those things, then you have to mobilize them. You can mobilize it from the superior aspect and as well as from the articular or the inferior aspect of the cuff. Then if you find that there is a difficulty in bringing this cuff tissue towards the tuberosity or the footprint, you can medialize the medial row. Up to 1 centimeter of the medial row can be medialized without affecting the outcome in the patient. Margin convergence sutures is very good technique for irreparable looking tears. Margin convergence allow them to get access to the footprint, and the repair can be done in irreparable looking like tears. We can use the luggage tags, we can use single row tears, but it should be tension free repair so that the healing is good and the re-tear rate is low. In case of retracted tears, you can do the intra-articular releases, you can do the extra-articular releases. Anchors, usually these perforated or helicoil-like anchors allow the blood flow and the mesenchymal cells to come from the bone so that they heal well. Anchors of the small size are very important because sometimes larger size anchor covers most of the area of the tuberosity, leaving less area for the tissue to heal. But at the same time, you have to consider that the pull-out strength of anchor should also be very good. And in the last, I do the subacromial decompression in most of the cases, and burring of the tuberosity to bring the fresh blood supply for the tissue healing. Thank you. And basically all the steps I have asked Dr. Nagaraj to start case from the beginning so that we can see all the steps step by step which will be covered. So over to you for OT.
Are we audible there?
थोड़ा सा लाइट फोकस करिएगा प्लीज.
OT, are you audible?
Dr. Nagaraj.
Yes, sir. Yes, sir.
We didn't get much time for the diagnostic round. I've just entered the shoulder.
Yeah.
So can you guys visualize everything?
Yes.
So let me take you through the history of this patient. This patient has had a traumatic injury to his shoulder. He's got a fairly good passive range of motion, except terminal forward flexion and external rotation is restricted. His active movements are significantly weak, almost pseudo-paralytic. And we have just entered the shoulder. So can you see the outside picture?
Yeah, Nagaraj, Dr. Divyanshu, Dr. Arjun and Dr. Virendra is going to moderate your live surgery.
Okay.
So over to them for the live surgery.
Okay.
If you could just focus your light from outside on the portal area so that we can really see the landmarks and the portals better while you're describing them. Yeah, thank you.
Dr. Divyanshu, you can see the images, right?
Yes, yes, we can. We can
So-
see the intra and the outside as well.
Right. So दिख रहा है उनको. OT में थोड़ा silence रखो. दिख रहा है उनको. दिख रहा है. This is the posterolateral corner of the acromion. This is the anterolateral corner. This is the lateral border. This is the lateral border of the acromion. This is the spine of the scapula. This is the lateral and clavicle. This is the coracoid. Whenever I am doing a rotator cuff surgery, I try to stay more closer to the acromion. Whenever I am trying to do an instability surgery, I try to go further away medially. Now we are in the shoulder. Can you see the inside picture now? Inside
Yes.
picture, please.
Yes, yeah, we can.
So the humeral head is on your left hand side, the glenoid is on your right hand side, the biceps is here. That's the rotator cuff tear. When I'm in the joint itself, I create my lateral subacromial portal, which comes exactly in the center of the tear. So now you can see this is the area of the cable. Can you see the cable?
Yes, yes.
This thick structure is the cable,
Yeah, yeah,
and
we
the
can.
tear is in the crescent. Because the tear is in the crescent and in the critical zone near the anterior cable, this patient has got a pseudo-paralytic shoulder. Hardik, can you take it out?
Sir, can I just show the MRI for a sec?
Yeah, I'll just show it to you.
I have it uploaded, sir.
So if somebody could, so as you can see on the coronal images, before I go there, I'll go there. You can see that I'm just debriding the cuff with the suction intermittently to take out these frayed edges. So you just take out some frayed edges up to here.
Make a big video.
So I'm happy with that. Just gentle.
So
Before I go into the subacromial space, so that's the subscap insertion. Akram, camera pakdo. So all of you can see that. Now look at my arm. Outside picture dikhana. Idhar dikha raha hai?
Yeah, we can see both.
So
Yeah.
whenever you want to see the subscap, you need to do a posterior lever push. So when you do a posterior lever push, if there is a leading edge tear, it will be well visualized. Okay, so there is no subscap tear. Pakdo. Can you see the MRI picture दिखाओ अभी?
We have seen, we have seen. They had uploaded it here. We have seen, yeah.
मुझे pointer एक दे दो कुछ दिखाने के लिए उनको.
So you always take your shoulder cases in the lateral decubitus?
Always lateral decubitus. So can you see the coronal images now?
Yes.
So this is the biceps tendon. You can see an intact anterior portion of the supraspinatus. Second section also there is intactness, and there is a critical zone tear here. Can you see that?
Yes.
So there is a complete critical zone tear here, here, and here, and here. So supra, and the anterior edge of the infra. That much amount is stone. On the sagittal oblique images, you should see the Y view. Can you see this? In the Y view, you can see there is a
Camera
good.
person, please focus.
Idhar
on
focus
MRI,
karo.
yeah.
Thank you.
This is good one.
Yeah, so you can see a good occupancy ratio. You can see the muscle occupying the entire supraspinatus fossa. There is no fatty infiltration at all in the supra, infra, or in the teres minor. So this is a classic traumatic critical zone complete tear. On the axial image, ये image दिखा दो. You can see the intact subscapularis. You can see the biceps well in the groove. So there is no biceps subluxation and there is no subscapularis tear. Okay, so we'll go ahead with the further steps in the surgery. Now, shaver aap hi do, Hardik. So what's important unique thing, different rather, is that I do the debridement from the visualization from the joint and the instruments coming from the subacromial space, because of which I am able to see this bird's eye view. Another thing is, this is a lateral decubitus orientation. Mera haath dikhana, camera, ye haath dikhana.
Yes. We can see.
When you do this, you get a beach chair orientation, and most of the surgery, I will try to do this beach chair orientation, so I am oriented like a anatomical orientation, okay? Biceps is mildly frayed, so nothing very abnormal per se, and there is no slap lesion per se. There is an impaction injury in the cartilage here, other than that nothing much. Hold. And this is the intact infraspinatus. Can you see that? That's the bare area where you can see the alveoli, which is the vascular nutrient foramen which is coming in, and that's the posterior cuff. That's the capsule, that's the posterior labrum, that's the superior labrum. So that completes the diagnostic round. So basically we have got a complete supra tear from the critical zone, and we have got an anterior leading edge of infra tear. Hardik, hold this. Trocar rapido. So now we will enter the subacromial space. So to enter the subacromial space, we will just withdraw a little bit and enter into the subacromial space with that maneuver. Could you see that?
Yes, good visualization.
So having done that, we will enter the subacromial space. So now you can see we are in the subacromial space. We can visualize the undersurface of the acromion. So that's the undersurface of the acromion and the frayed CA ligament. And that's the inflamed bursa. The minute you see this much amount of inflammation, I will use the RF now. RF api do please. Arun, ye receive karo. Or Hardik, RF do. Arun will receive and keep it in line. And Hardik will help me to get the instrument. Footpad aage kar do. So that's the CA ligament fraying, indicating that there is some amount of impingement component, and more often than not, there is always some amount of impingement in the background for this sort of a traumatic tear. So what we need to target is the anterolateral corner of the acromion. So that is right there. Keep the anchors ready, please. Helicoil double loaded. Helicoil, plain helicoil, not
Nagaraj sir, Dr. Virendra here. So you are going to perform subacromial decompression first of all?
Yes, so as you can see, the coracoacromial ligament is frayed.
Okay.
So whenever I see there is a fraying, I will do a soft tissue acromioplasty, meaning I will just do some buffing of the coracoacromial ligament, not a bony acromioplasty. On the sagittal oblique view, I have noticed that he doesn't have a type 3 acromion, he just has a smooth acromion. If you go here, you will come into the area of the clavicle there, okay?
Okay.
So that's the acromioclavicular area. So if you want to do any AC joint surgery, you need to go there. So now it's very important that we have a nice space to work. So this is the internal deltoid fascia. So you can see that's the tear. Can you see that? So that's the rotator cuff tear, and that's the acromion. That's all the bursa. That's the internal deltoid fascia. So this is very important maneuver because you want the deltoid to go away from you, and that's your enemy. Helicoil double loaded peak, 2 anchor ले लो please. Lateral row के लिए knotless helicoil ready रखो. First pass ST ready. Please feel free to ask questions. I think this is a wonderful teaching program arranged by Vinay, arranged by Smith & Nephew.
Sir,
and wonderful
you always
contributions.
going for this RF cautery over the deltoid fascia?
So as long as you are on the fascia, it is okay.
Yeah.
And of course, that comes with some experience. So as you can see, that's the muscle, that's the fascia. So the minute you reach the muscle, you will obviously not use the RF. And it's very important that you use a nice bloodless field. I've got excellent anesthesia here. Dr. Vinay has given a good block. Dr. Rahul Jain.
So you never use shaver in this place?
I will, of course I will use. So I'm going to show you the use of the shaver in a minute. But as you know, when you use the shaver, there is some amount of bleeding, and then once there is a bleeding, there is a red out phenomenon that happens. It's the Bernoulli effect. So So if you want to avoid the Bernoulli effect, you need to make sure that as far as possible, you avoid some bleeding that is potentially likely to happen in this area. So you can see now suddenly there's a lot of space for me to work. Again, this is the bursa. We need to differentiate the cuff from the bursa. Arun, isko aise ghumao. Did you see what happened?
Yes, sir.
When you zyada mat ghumao, bas. When you rotate the humeral head, what moves is the cuff. What doesn't move is the bursa. So you can see nicely I am able to differentiate the bursa from the cuff. I am able to excavate the cuff from the bursa.
Good visualization.
So that's the lateral release. Shaver ready karo, Hardik.
So till what level do you like to dissect this bursa?
So there is something called as a posterior bursal leader. I probably just release that posterior bursal leader. So this much I am going to do from this portal. Mera 7 mm cannula ready karna hai, Akram.
I think even with the RF, if you are RF, even if you are dealing with some delta, it doesn't matter. In open surgery, you use the cautery, cut hole of the delta, and they go inside. So
sorry, Sheetal, you need to speak louder.
Yeah. So I was just telling them that even if RF touches the deltoid, it doesn't matter. In open surgery, you use the cautery, split hole of the deltoid, and then you go inside.
Correct, correct. So just a soft tissue buffing of the acromion. The idea is to create space between the cuff and the acromion.
Nagaraj, what is your preferred angle of abduction while you are doing this kind of surgery, particularly while you are
So
fixing?
typically it's about, I would say 35 to 40 degree abduction, about 10 to 15 degree forward elevation. So say 45 degree of abduction and about 10 to 15 degree of forward elevation. So what's important to note is there is a subscap surgery. I'm going to put it into a little bit of forward flexion. Internal rotation chhod do beta, RF ready karo.
Nagaraj, it looks like a juicy cuff. You should give party to Vinay.
Ah, Vinay, yes. I have thanked him during our discussion also. He is really treating me. I am a visitor to Madhya Pradesh, so next time you call me to Bhopal, you are also supposed to do the same thing. I will reciprocate when you come to Mumbai. Shaver, please. Even the OT staff is excellent. Arun is here. Dr. Vinay is fellow. Hardik is here, my assistant Akram is here. All of them are helping me. So that's the preparation of the tuberosity now. So we have already debrided from the joint side. Now we are debriding from the subacromial side. So gentle buffing, no excessive clearance per se. So I think I have done a good subacromial decompression. I am ready to go ahead with my assessment of my cuff. मेरे को एक eye strong दे देगा. So that's the reduction. So it's a nice crescent shaped tear. It's in the critical zone, so we have to understand that although this is a juicy cuff, the biomechanics have to be perfectly restored for this to be perfectly working. I'm going to decompress more of this CA ligament. I think it's an impingement mediated plus traumatic tear. मेरे को RF देना बेटा. So you can see some amount of prominence in the anterolateral corner and some amount of the hypertrophy of the CA ligament. So we need to make sure that there is no more impingement once the cuff is repaired. So I think as of now it looks good. मेरे को एक straight artery दे दो अभी. So now we have to decide what should be the viewing portal. Traditionally everybody takes a posterolateral portal, but I have a slightly different way of approaching this. मेरे को spinal needle देना अभी. Knife उनको दे दे, knife दे दे उनको, और rod दे दे और 7 mm cannula दे दे. So that seems to be the good trajectory for my cannula. निकाल. मुझे अभी खड़ा रहना पड़ेगा अरुण, प्लेटफॉर्म मुझे देना पड़ेगा तुमको. So that's the end on view now. Can you appreciate the cuff?
Very well.
So now we are
Nice
ready to take.
demonstration.
Knife दे दे बेटा. ये निकाल. Rod ready करो.
Do you use cannulas during your...
Now I will use. Until now I don't need it. Now I will use.
All right.
Rod पकड़ के रखो. So I'm using a 7 mm cannula from Smith & Nephew. Cannula पकड़ो. मेरे को पीछे से एक बार शेवर दे दो. અહીંયાથી આપી દે, અહીંયાથી આપી દે. तो अभी एंकर का तैयारी कर दे. स्पाइनल नीडल, रॉड. So that's the posterior bursal leader, the last bit of the release that is left. So it's very important that you create a normal tension in your repair. You don't want to over tension your repair. Also, you don't want to go into the vascular part of the bursa. You can see the muscle tendon junction is coming in there. Okay.
Yes, good visualization.
Yes,
Yeah.
that's the muscle portion, that's the tendon portion, that's the bursa. So you need to make sure that you don't unnecessarily dissect near the muscular portion where the vascularity is coming from. But at the same time, you need to make sure that you've got adequate space to work and the deltoid falls off so that you can do a good job. यहाँ पे दो. अभी मुझे शेवर दे दो यहाँ से, कैनुला से. And Hardik, you have to continuously hold the cannula now. Okay. Depending upon the situation, you might have to withdraw. Withdraw a little bit. Hold this for me. Hold this. इधर ध्यान देना है, वरना नहीं दिखेगा. हाँ बेटा. Arun, इधर आ जाओ.
You're planning a single anchor on the medial footprint?
No, mostly I will use 2 anchors.
Or a single triple loaded?
Yeah, so mostly I'm going to use 2. Let us see. मुझे अभी ये देना, curate देना पीछे से.
Before putting anchor, you mark with a RF or something?
Yeah, so what I'm now doing is, I'm making sure that I have a good preparation. So I'm just using a gentle curate. I like to get my anchors right at the edge of the cartilage, where, as you know, there is excellent bone, and there will be a low tension repair also. So gentle, nothing more. That's the biceps. That's the anterior edge. That's the posterior edge. मुझे एक हुक प्रोब देना अभी अपना वाला. So now, very good that you asked this question. Now, if you realize this is the leading edge of the infra, there is a deeper lamina which is intact and the superficial lamina is torn. I would like to dedicate 1 anchor for the infra. I would like to dedicate 1 anchor for the supra. Not compromise with a triple loaded. It would make my job easy, but biomechanically that would put a lot of stress on that 1 anchor. Spinal needle दे दे. Rod, फिर helicoil. So outside picture you can show now.
Yeah, it's visible.
Yes, we can see.
Yeah, we can see.
So that's the perfect dead man angle if you see.
Yeah.
So I'm able to reach exactly at that 45-degree angle. Okay. Knife आप ही दो. Out. टोचा. अरुण मैं बताऊंगा तभी अडक्शन करना है. निकालो. बताता हूँ. उधर देखते रहो. अडक्शन करो धीरे से. अडक्शन नीचे नीचे. करेक्ट. रुक जाओ अभी. एंड अक्रम गो. इसी से करता हूँ. गो गो. बस. तो एंकर ले ले अभी और थोड़ा सा ठोक दे. Okay. I am also going to create some crimson duvet now. Adduction maintain करना है बेटा. So going to make a few bone marrow vents. जा. ठोक ना. So थोड़ा सा और जा. Go 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 go. Okay, so you can see the fat globules coming in. I think that's the key for a good repair, good biology and good biomechanics. So, okay, fat globules from everywhere. मेरे को भी anchor दे दें. Now, this is the helicoil anchor. Can you see this?
Yes, yes.
This is the only anchor which is completely open architecture. So it's complete, not just vented, it is open architecture. So that allows the bone marrow elements to come into your repair. So enter your anchor with a screwing motion. Try to remember the trajectory. So this is the only anchor where you, as you put in, your hands get sticky because the bone marrow elements start coming onto your gown, onto your gloves. So actually you can have the bone marrow elements coming into your gloves. Can you see that?
Yeah. So you prefer the peak anchor or bioregion soft material anchor?
I am okay with both.
So what is your choice?
What is my choice? Bio if it's affordable, if there's any cost constraints, then peak. I don't think there's much of difference though, but yeah. Bio if the patient is affordable. Good quality bio, any doubts, peak again. Now, it's very important to understand the reduction of this tear now. मेरे को आइस्टॉन्ग दे दे. Kingfisher भी ready रख. आप पकड़ी रख हार्दिक. आप भूल तो नहीं हमने, हाँ? Don't forget this part. So, now is the time when we do a reduction. We have already understood the tear pattern. So that seems to be the reduction of the infra. That seems to be the reduction of the supra. So this seems to be the way it is supposed to be reduced. Okay? मेरे को भी arthropause दे. Straight artery पहले दे दे. Okay, arthropause. So now it's very important to stay away from the muscle tendon junction. So that's the muscle tendon junction. We come right at the 3 to 5 millimeter away from the muscle tendon junction. Take both the laminae and then make sure there is no deeper lamina here. Okay? That way. That way. Make sure there is no deeper lamina. Use the tip of your arthropause to negotiate the sutures and take the suture that is easily available to you. Observe this movement at the anchor level, not outside. So I am confident I am retrieving because I am observing the suture at the anchor level. Was that evident for you guys?
Yes. Yeah, very clear.
So now we are ready to march forwards. ये suture खींच ले. We are ready to march forward. So I am going to show you all the devices which are available for cuff repair. So I am using the Arthropause like device now. इसके बाद क्लेवर रेडी करना, उसके बाद आर्थ्रोपियर अपना एक्यूपस. सो सेम कलर सूचर ये लगा दें. अभी मुझे क्लेवर दे दें. लेफ्ट साइड क्लेवर दे दें, लेफ्ट साइड. सूचर्स खींचो. सो नाउ दैट्स द क्लेवर हुक. इसके बाद एक्यूपस देना. अगेन मसल टेंडन जंक्शन, लेफ्ट साइड एक्यूपस. नहीं शटल. So this is a clever hook. It's clever because it opens on the undersurface. Once again, once I've done this, I observe the movement. Can you see the sutures are moving? In this case, you have to wait. Outside picture dikhana. Can you see the outside and the inside?
Yeah.
Now, when you pull this, the suture, other suture is moving. That should not happen. So don't worry. So Hardik is worried I'm going to offload, but we need to observe there. Okay? If you are observing there, the chances of you offloading is bare minimum. इसको mosquito लगा दे. अभी next एक्यूपस दे दे. इसको खींचो और मस्कीटो उसको दे देगा, वो लगा देगा, होशियार है वो. Now that's the acupus, that's the retrograde device, retrograde shuttling device. Once again, we penetrate that layer deeper to the cable. Can you see that?
Yeah.
There, deeper to the cable.
Nagaraj, what is the distance between the two sutures that you are keeping?
So about 5 millimeters apart, and I'm trying to make sure that I have a good spread out of my sutures, and I planned it also for my second anchor. अपना इसको खींच लो, पकड़ा है? रुको 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 रुको, पकड़ा है? So we have shuttled. That's another technique. Okay, second anchor, mosquito लगा दो. अरुण हाथ को एंकर के बाद रिलैक्स करना था, कोई बात नहीं, अभी मेंटेन करना. Spinal needle. Now there's something very important to understand. In the process of preserving the number of anchors, don't compromise on a second portal. So I'm always going to take a second portal. Did you see the trajectory? So that trajectory, मुझे टोचा फिर से दे दे. अब उसकी ज़रूरत नहीं है. ये निकालो. The trajectory has to be anterolateral. Okay, so we are away. It's a different direction. Adduction करो अरुण और थोड़ा. Again at the edge of the cartilage. ठोको अकरम. रुको रुको रुको. दूसरा एंकर. जाओ. Helicoil.
How much distance you keep between the two anchors?
About 5 millimeters again. So every centimeter of width of the tuberosity exposure deserves an anchor. So anywhere between 5 millimeters to a centimeter, you need to place another anchor. So I like to distribute the stress of my sutures. So therefore, even though this is technically demanding to put two anchors in such a narrow area, I think the ultimate outcome is going to be far better in terms of reducing the stress on one suture. Guma nikalo. So you can see I had changed the orientation for that anchor, and now I'm back into my end-on view.
Nagaraj, any preference from going from posterior to anterior, putting anchor posterior to anterior, or depending on the tear pattern you will change?
Yeah, depending on the tear pattern I will change, but more often than not I always march from posterior to anterior. I strong. Now I'll show you the first pass ST, which is the antegrade device. So that's the only device now left to demonstrate. So we have shown you direct antegrade passage, retrograde passage, clever hook, and now the ST. Can you see the ST? So this is a antegrade device.
Can you zoom out the outside view?
Outside view.
So this is the first pass ST.
Yeah, now we can see.
Yes.
So it's an antegrade device. So the suture has to be loaded onto the center by forming a loop. Do a half fire to lock the mechanism. Cannula. Slack nikal. रुक जा. Now again you can take a nice bite, go away from the muscle tendon junction, few millimeters away from the previous suture, and fire. So this is what, okay कोई बात नहीं, पकड़ो कैमरा पकड़ो और लंबा suture दिखा दे. Correct. नहीं कोई बात नहीं. ओपन नहीं हो रहा है बिकॉज. चलो ये लो, मुझे आई स्ट्रॉन्ग दे दो. So that has completed the almost the second last pass. I strong, rod and 7 mm. Saline पे ध्यान देना. Rod and 7 mm. Mosquito लगा दे. ये सुचर को पूरा खींच ले. अभी जो आया वो सुचर दे दो. अभी जो आया मस्कीटो कौन सा है? ये वाला है. पूरा खींच लो. 7 mm. Hold the cannula. Hardik, hold the cannula. Now we'll take the cannula behind Hardik. I'll do it. Now pull on these sutures. eye strong de do. So now all the sutures will go in an antegrade fashion. Cannula holding beta? Yes. Okay. First pass mini again. Camera. इधर ऐसा कर. So once again the jaw opens, we enter into the deeper layer. We make sure we are not taking the biceps in the bite. Can you see that?
Yes, sir.
You need to be sure that you don't take the biceps in that bite and then fire. So it's a very simple, straightforward pass. Sorry, pakad. Eye strong. पूरा सूचर खींच आ गया है ठीक है फर्स्ट पास
What is your preference for suture passage? Like any of these or first
all
pass?
of these I'm
Okay.
not just demonstrating for demonstration purpose.
Okay.
This is exactly how I do my cuff repair. Because I feel that each of this instrument is meant for each of the areas of the cuff. So I'll just show you what I mean. So now that's my anterior stitch.
Sir, for those posterior sutures,
Yeah.
Why don't you use first pass?
Yeah, so I don't think I can do a good bite like this. You can see this?
Yes, yes.
This is meant to go straight. It
Yes,
is not
sir.
meant to go like this. You can do it, but then there is a compromise. I like to come perpendicular to your bite.
Yeah, the difference in trajectory makes.
Yes, I want to be perpendicular to my tissue that I want to capture.
Sure.
Cannula thoda piche le lo. Sorry, pakdo camera. Wait. Eye strong. खींच लो पूरा पूरा खींच के बांधो so that's my last bite कैनुला पकड़ा नहीं है हार्दिक ने निकल जाएगा बेटा चल कैमरा So once again enter the mouth, stay away from the biceps, that's the anterior most edge and fire. Cannula पीछे लो चलो sorry पकड़ो camera खींचो correct super hold. So now it's a good idea to see इधर एक loop बन गया eye strong देना. So you can see sometimes there is a loop like this. So just pull on this end and it will unloop itself. खींच ले उसको. Mosquito cannula पकड़ी रख हार्दिक. So now I have to decide which suture I want to tie. So now I'm going to look at the reduction. This is the reduction. So the most perpendicular suture to this reduction is the light blue from the second anchor, from the first anchor. So I'm going to take the light blue from the first anchor, Akram. Can you see that? That is the one that is going to be reducing the repair. So that's going to be my reduction. Cannula thoda पीछे. Yes. Okay. हाँ वो हाथ को रिलैक्स करना है. कैनुला पकड़ो, कैमरा पकड़ो. So this is a mattress stitch, so you can use any of the two. Knotting दिखा देते हैं outside picture. So because it's a mattress, you can use any one of them as a post. So as you can see here, for the sutures I use a SMC knot. पकड़ा है? So SMC is a self-locking sliding knot, unlike the other sliding knot. So that's the self-locking knot. We make sure that we've got a nice knot.
Can you demonstrate the knot pattern for the beginners?
Sorry?
Sir, can you demonstrate again this knot pattern?
Yes, we will have 3,
Yeah.
4 more chances to show you.
Yeah.
Yes. Okay. कोई भी चलेगा. Crab claw है. So now we will station these sutures as per where they came from. So this is my portal of my anchor, first anchor. I am going to station one of the sutures into that for the lateral row. वो पीछे ले ले. And eye strong दे दे. So the entire idea is to avoid confusion, right? Eye strong दे दे. The other suture will go into the posterior portal. अभी second anchor का dark blue दे दें. ये जो ऊपर का इसको खींच के पकड़ो. Right. Second anchor dark blue. So now when I am tying, I tie as per the reduction that I wish to achieve. निकाल दें. Hold. So as you can see, it's nicely reducing onto the tuberosity. छोड़ दो जरा सा. So that's going to cover up almost the entire level of the tuberosity. Camera पकड़ो. पकड़ा है? So post, we attach the knot pusher and the mosquito. Can you see this?
Yes, yes.
So shorten the post. Now I am looping, I am creating a triangle. So one triangle, another triangle, come from outside in, and there is a triangle in the middle. Pass from outside in that triangle. Throughout you are not leaving the post and then doing the reduction. So now we will use the anterior portal for stationing these sutures, which is right here. Knot pusher थोड़ा पीछे ले, wait कर, निकाल, eye strong दे दे. मुझे अभी आई स्ट्रॉन्ग दे दे फिर से. ये जो स्टेशन किया है खींच के पकड़ो. सो द फर्स्ट एंकर डार्क ब्लू दे दे अभी. Camera. So that's going to reduce my infraspinatus. Can you see that?
Yes.
Nagaraj, looking from the central portal and working from posterolateral gives excellent visualization, but it doesn't hurt your shoulder a lot?
So I'll have to come for my cuff repair to you.
No, seriously, I mean, I'm not joking because...
So basically, if your table goes low, unlike here, this doesn't go all the way low, but if your table goes low, there's no problem. So now I'm tying a non-sliding knot, as you can see. So two in the same direction, one in the opposite direction, and you reverse the direction of the post by pulling on the other thread. So once again, same direction, opposite direction, and now you pull on the other one. So you reverse the post. So that locks the suture. Sure.
So medial row will never be knotless for you. You will always knot everything.
Very rarely, Sheetal, because as you can see, even though it's a small tear, it's under significant tension. So we need something to anchor it on the medial side. We want that cable restoration. I don't want the cable to be elevated. This patient is so weak because of the anterior cable disruption. So the last suture, and we are done actually with the single row repair, we are already done. But we are going to do the double row. So first anchor, second anchor, light blue.
So if you understand the concept of rotator cuff anterior cable in the whole of the crescent should be restored very well. So any tear which is extending into anterior cable will lead to pseudoparalysis. So previously there was a thought that mainly all rotator cuff tear are asymptomatic. So those asymptomatic tear were actually not extending into that anterior cable. So that was the reason. So anytime that will extend into anterior cable, patient will end up into pseudoparalysis. So I think all traumatic tear, irrespective if they are symptomatic or asymptomatic, should be dealt with surgery. Otherwise later on they are going to definitely progress to the anterior cable and then the repair will become difficult. What's your opinion, Nagaraj?
Traumatic tears, complete tears, pseudoparalysis, absolutely. Like I don't know where we were discussing this, operate them fast because sometimes they come, I think we were discussing in a meeting, sometimes they will recover from the pseudoparalysis and they will ask you whether to get operated or no.
No, but it's still,
yeah, but I agree with you. Yeah. We should operate traumatic tears which are complete and symptomatic. So that completes my, मुझे आइस्टोंग दे, एक सूचर इधर ही रहने दे. Cannula pakdi rakh, ye nikal de. So now we are preparing for our lateral row. So I'm taking one of each suture. अरुण ये देखो ये इस तरफ एक ये डॉक्टर हार्दिक की तरफ now we'll take one from here ये कैमरा पकड़ अरुण ये तेरी तरफ कर पकड़ा हेलिकॉइल नॉटलेस रेडी डाल दो सेल्फ टैपिंग नहीं रे वो पीक वाला चलो पकड़ो. So we are ready for our lateral row. We have dressed our sutures. Can you see this? So light blue, dark blue, light blue, dark blue. Camera outside picture, please.
No, inside view. It's okay.
So light blue, dark anchor le. Dark blue, light blue, dark blue. Helicoil knotless. Helicoil region swab na wahi na. Right. Chalo. So now that's your lateral row, okay? So all the sutures are going to come and we are going to have a fixation somewhere around here. So that's going to complete our repair. Something
Any
like
specific
this.
landmark for putting the lateral?
So this is what I'm doing now. I am tensioning on the sutures. I'm deciding whether this is better, this is better, this is better. So if you see here, this seems to be the best point. So anterolateral, I'm planning a single anchor. So anterolateral seems to be the right point for this particular patient. Agree?
Okay, sir.
Because this is the line of pull of the supra. Can you see this? It is retracted in this direction. That's the spine of the scapula area. That's the supra. So that's the one. Okay? Cannula pakadi do. Tocha, please. Rod, please. Another small trick. We will use this Wissinger rod as a retractor of the deltoid. Arun, apna right हाथ आगे करो. So, एक मिनट रुको. हाँ, ये ऐसा पकड़ा आपने. सलाइन पे ध्यान देना प्लीज. चल. टोचा दे दे. छोड़ बेटा. छोड़ जरा सा. अइया. आ लेवल ऊपर. अइया. ओके. अइया. ध्यान रखिए. हाँ. टोचा. सूचर्स एक हाथ की साइड में करी दे. लेफ्ट हाथ की कैनुला पकड़ी ले.
Nagaraj, how down you are going depends on the tension on the cuff that you decide, or?
Great question. So, what all I try to see, tuberosity is usually weak as you come upper here. It gets a bit better as you go lower down.
Absolutely.
And moderate tension, not over tension, not moderate. Everything that I do now, Sheetal, is somewhere in the middle. All thought processes somewhere in the middle.
Yeah.
Go.
Middle path regime.
Middle path regime. पकड़े?
One more advantage of anterolateral, the bone quality is relatively good as compared to posterolateral. Just posterior to the biceps, hold is relatively, the hold is better as compared to posterolateral.
Especially in the elderly, like this is a relatively young patient.
So you can see all the marrow elements that my crimson duvet is weeping out. My anchors are all vented. So that is what we want, a good biology with low tension. Now guys, can you see this? This is a helicoil knotless.
Yeah.
With regions of material with a peak tip. So they have one with a self-tapping and one with a...
Cameraman should focus on the anchor.
sutures हमना मैंने feed करवाना है तो आम राखी दे tip देखाड़वाने. So as you can see here, it has got a peak tip, a regions of screw. Okay, so we'll show you how to use this. So it can take at least about 4 to 5 sutures. So we've got 4 sutures in this case. So load it with a mosquito clamp. Pull on the sutures. एक बाकी है.
So there is one question, Nagaraj, why a parachute, why not a suture bridge? Like taking rest of the sutures and using a 2 pair of anchors on the lateral side as well.
Just a second. Yeah, so a W configuration or an Xbox configuration very well can be done. A single suture आपी दे बेटा. Any हाथ में चाहिए क्या? एक वक्त feed free करीने देखाड़ बने. Complete free करी. तो बाकी का टिप पकड़ के रख. मुझे अभी डायरेक्शन दिखा दे. रुक जा, रुक जा, रुक जा. ये खींच के पकड़ ऐसे. ये भी निकल गया है क्या देख ले. तो एक ही डायरेक्शन में पकड़. अरुण कैमरा पकड़ ले. अरुण कैमरा पकड़ ले. तेरी तरफ ले. अभी फीड करो आप. Okay, पूरा मत ले, छोड़. Yeah, so I can always do the Xbox configuration, but I think this tissue is under some tension. We don't want so much amount of tension to be created. एक mosquito लगा दे वहाँ पर. दूर लगा दे. Tip पे लगा. हाँ बस. Now all निकाल. हमारा तो sutures पकड़ी लेते हैं. हाँ, gentle इन्हें slack काढ़ी ना. Okay, so that's the suture array. I'm extremely happy. You can see the sutures getting tensioned.
Yes, good one.
Hammer de. So now there are 2 times when you can cut the slack. So I am entering into the bone. Hold किया. So that's just entered. So now is the time. Hardik will give me individual sutures. Mosquito काढ़ी ना. ये ऐसे पकड़ शांति से. उधर ही focus कर. So we are tensioning each suture now. So you can see.
Yes, sir. Good presentation.
Beautiful.
Yeah.
And now the other suture. There. Okay. So I'm happy with that. Akram will show here. Now we have to lock the peak suture into the anchor. So we dial the black one. Outside picture you can see. So you start turning the black dial until you hear a audible snap. So we heard the audible snap and now you turn the orange dial. Cannula thodu pachad le to ja. Suture chhodi de beta. So that completes our repair, guys. So hammer. That's a beautiful footprint repair, low tension. I'm happy to answer any questions.
Thank you very much. Very well elaborated and nice demonstration.
So you can see absolutely
Yeah.
footprint repair, exactly
very
where we
nice
want it, away
fixation.
from the muscle tendon junction, low profile, and managing all the components. So no more impingement, low profile, double row repair.
So can you ask assistant to move arm so we can say yeah.
What?
Rotation.
Rotation. So
of
you
it.
can see I'm moving in abduction, I'm moving in internal rotation, I'm moving in external rotation.
Yes.
More than the more than the repair reduction, it is the low tension that is important. We don't want them to develop reflex pain post-op. So you
Yes,
realize
sir.
I am not purposely going too deep in my sutures, and that's why I'm not doing a double lateral row also. I
It's very
just
nice,
want enough.
beautifully fixed, sir.
Yeah, I just want enough tension, enough repair. That's all.
Thank you so much. Very sad.
Thank you.
In this patient, what will be your rehab protocol?
So this sort of repair where I've got such good reduction, I don't mind them doing activities of daily living with good scapular hold as early as 2 weeks. So they can start, having food, having a cup of water, wearing their spectacles, washing their face, going up to the forehead types. At the same time, we will start with passive range of motion in the supine position because the scapula gets automatically stabilized. And at about 4 weeks, 5 weeks or so, based on how much passive range has come comfortably, I will start with active assisted. So stick exercises and exercises with the other hand. So by 7 or 8 weeks, we are allowing them to come out of the sling and doing all the active movements. By that time, they should have good scapular hold. And then formal strengthening starts around 3 months. Isometrics will start around 10 weeks. Of course, this is all individualized. You have to understand that once you see this tear, we record it, we tell our fellow to speak to the rehab specialist as to it is a faster rotator cuff rehab program, slower rotator cuff rehab program. You've done a SCR, you've done a biceps SCR, etc. It will be slightly slower. In this case, if you see here, even in adduction, it is absolutely stable. Can you see that?
Yeah.
Yes, sir.
It is not a tensioned repair. So even a simple arm pouch is enough for him. But in some cases, you might have to give an abduction pillow, in which you will have to go a bit slow. So everything is individualized.
Yeah, very nicely done. Tanmay is saying that he will allow him to play volleyball from day one.
That is all because all good friends are here. That's the reason why I wanted to come yesterday, but I couldn't make it. So sorry, maybe next time we will have a better time together.
Thank you very much.
Thank you guys. Thank you,
you, sir, for nice surgery.
Thank you so much.
Thank you.
Guys, before I leave, I need to thank my team here. First of all, heartfelt thanks to Dr. Vinay Tantuway. Excellent program, excellent setup, excellent team that he has here. Thanks to Smith and Nephew, thanks to Rajneesh, thanks to Mayuresh, and thanks to the team of Dr. Vinay. Brother Arun is here, his fellow Dr. Hardik is here, anesthetist Dr. Rahul Jain, and my assistant Akram. Thanks to everybody, and signing off from the OR.
Thank you, Dr. Nagaraj. Thank you very much for coming all the way from Mumbai. Thank you very much.
Thank you.
Yeah, now we'll break for tea. Thank you.
Good job, guys.
Sir, we will start with our next session now, which is based on shoulder instability and its repair. So, I call Dr. Pankaj Vyas sir to moderate this session with Dr. Manjit sir, please. And I invite Dr. Mukherjee sir. Sir, I request you to moderate this session, sir, please. It is based on. Sir, okay. I call Dr. Brajesh Dedera sir to present his talk on anterior instability with Hill-Sachs lesion.
हाँ प्ले कर दो भाई. Okay, so very good afternoon. I'll be talking about the anterior instability, means the Bankard's lesion with the Hill-Sachs defect. Bony defects of the glenoid and humeral head are common injuries. They are associated, many times they are associated with the anterior glenohumeral instability. The Hill-Sachs defect is an osseous defect in the posterior-superior part of the humeral head, and that is typically associated with the anterior dislocations. It is because of the impaction of the posterior-superior part of the humeral head with the anterior glenoid rim. And the incidence of the Hill-Sachs lesion is approximately 45 to almost reaching up to the 100% in the cases of anterior traumatic dislocations. And this incidence increases as the recurrence increases if there's a delay in the reduction and those patients with a decreased bone mineral density. To diagnose, nowadays MRI is there, that is the most important tool, but historically these Hill-Sachs defects has been diagnosed in the X-rays, and there is a typical Strachus notch view which was very useful. So this is the Hill-Sachs defect which can be diagnosed in Strachus notch view. 3D CT reconstruction is very important tool that will give us a detailed information about the humeral as well as the glenoid bony defect so that we can plan accordingly because in many cases there is a bipolar lesion. In MRI, definitely, there is a detailed information about the capsulolabral tear as well as the Hill-Sachs defect. So, in cases where there is a bony defect, it makes the clinical scenario difficult because in these kind of cases, the only soft tissue repair, capsulolabral repair, it is not going to work. So it is really important to assess any kind of bony lesions, let it be Hill-Sachs or on the glenoid side, because these bony lesions, they increases the chances of recurrence. To evaluate the importance of Hill-Sachs, whether that is a clinically significant or not, there is a concept of on-track and off-track Hill-Sachs defect. This was proposed by the Yamamoto and Easy et al. They have studied the importance of Hill-Sachs lesion, and they have found that 85% of the humeral head, almost in most of the cases, it makes the glenoid tract. If any lesion, any Hill-Sachs lesion, which is in this on-track mapping, so it won't come in contact with the anterior glenoid rim and it won't engage. But if there's any lesion which is off track, means it is extending beyond this glenoid tract, so that will be engaging lesion and this will increase the chances of dislocation and recurrence. So these off-track lesions, they need to be addressed accordingly. So it is the location and orientation of the lesion which is more important rather than the depth and length of the lesion. If the lesion is medial, it is more important than the lateral lesion, and let it be very deep lateral lesion, that is not of clinical significance. And if it is a small lesion, that is medial and superficial, but if it is engaging, that is of more clinical relevance. So the treatment options for these Hill-Sachs lesions, I'll be focusing on the Hill-Sachs lesion only. The treatment options for these kind of Hill-Sachs lesion, historically there has been derotational osteotomy. These are the indirect procedure which does not address the Hill-Sachs defect directly, but the purpose of all these treatment strategies were to make this engaging Hill-Sachs to non-engaging Hill-Sachs. So these indirect procedures are derotation osteotomy, capsular shift procedures. There are certain procedures which address the defect directly. Either it could be resurfacing or prosthetic replacement. Humeral head augmentations are possible if there is a large Hill-Sachs lesion, means those lesions which covers more than 40% of the humeral head defect. Direct filling the tissue, that is the tissue filling procedures like remplissage, which is most common procedure for this kind of Hill-Sachs lesion. There are certain procedures which address the glenoid bone loss, like Latarze or ICBG, iliacrus bone grafting. These procedures, they increase the glenoid arc. So they prevent the engagement of this kind of Hill-Sachs lesion to the anterior rim of the glenoid. As I told, these in rare cases where there is a very large Hill-Sachs defect, means which is more than 40% of the humeral head and there is no bony loss. So humeral head augmentation can be done either with the allograft, which is not possible here, or with the autograft from the iliacrus. Although I have not done it, but it is a very rare scenario where there is a large Hill-Sachs defect without a glenoid defect. So for me, the treatment plan is, in cases with anterior instability, means patients with labral tear, if there is no bony lesion or there is a small, very small lateralized non-engaging kind of Hill-Sachs, then my treatment choice will be standard Bankard's repair. If there will be large engaging Hill-Sachs lesion with a subcritical bone loss less than 15%, then my choice will be to add remplissage along with the Bankard's lesion. If there is a large Hill-Sachs defect, but it is associated with more than 20% bone loss, means it is critical bone loss, then we'll have to increase the arc of the glenoid. So we'll have to do either the Latarze or the ICBG. So in many scenarios, most commonly what we see, it is the engaging kind of Hill-Sachs and the Bankard's lesion. So that in these kind of cases, the capsulolabral repair alone is not sufficient, because the Hill-Sachs defect we keep on engaging, and it will be responsible for the failure of our labral repair. So in these cases, we need to address this Hill-Sachs defect which is engaging and we'll have to make this engaging Hill-Sachs defect non-engaging. So the most common procedure which we do, it is a remplissage procedure. Remplissage, it is a French word, it means filling. What we do, we fill this intra-articular defect with the infraspinatus tendon. So it is a tenodesis, capsulotenodesis of the infraspinatus tendon in the defect to make this intra-articular defect extra-articular. So this is the video presentation of the combined Bankard's repair and the remplissage procedure. So after doing a diagnostic scopy from the posterior portal, we make the anterior portal. So this is anterior-inferior portal, anterior-superior portal. Our working portal will be anterior-inferior portal and the posterior portal, and anterior-superior portal will be the visualizing portal. After confirming the capsular tear, now this what we see, this kind of lesion, this is the large Hill-Sachs defect which is quite medialized. So definitely this is the engaging Hill-Sachs and we need to address it. The first thing what we do, we direct our cannula towards the Hill-Sachs lesion. The first thing is we remove all the fibrous tissue so that there should be good biological healing. So all fibrous tissue is removed with the help of a curate. Then with the help of a small microfracture awl, we create the bleeding points, what we do in the rotator cuff area. And now in the we make a pilot hole for our all suture anchor. I personally prefer either the triple loaded anchor or the double loaded all suture anchor. So a pilot hole is created at the center, slightly towards the articular side, and this double loaded all suture anchor is placed in this defect. Now what I do, I make another posterolateral portal that is more lateral towards the attachment of infraspinatus over the humeral head, and pass a cannula it is a 6 mm cannula which I pass, and from that I pass a Birdweak. And these suture limbs are taken. It takes the bite of infraspinatus and the posterior capsule. So it is in the plus fashion, means one limb from superior to inferior and one pair from medial to lateral. So this is the most lateral one. Now you see. So this is how I have taken the 4 tissues from 4 tissue bites, 4 suture bites from superior to inferior and from medial to lateral. So once I have taken all these bites, then I'll go ahead with my capsular repair, with the labral repair. So before touching my labral repair work, I finish my remplissage work, means I pass the anchor, I pass all the suture from the desired places, and then I shift my scope in the anterior compartment and start doing the labral work. So this is how the only thing which is remaining here after finishing my labral work, I'll have to tie the suture over that. All the sutures are passing through the different cannula, and I'll have to just tie the knots. Now I shift my focus on the anterior work. So this was a capsular labral tear. So with the help of suture tissue liberator, I release all the adhesions of this capsular labral complex deep down up to the subscapularis level, means we should be able to see the subscap muscle fiber. In most of the cases, I try to extend the tear almost to 4 to 5 mm so that I can have a good north-south and east-west shift. The next thing is I do rasping. So rasping is done both on the glenoid side, on the neck, and also on the labral side to make a very good of instability, because this is my protocol. I don't want to break my protocol. Even my staff knows if it is a patient of instability, so he requires a MRI, he requires a CT, he requires a CT of the affected limb. Also, he requires a CT of the opposite side at the level of limb. Yes, we have done so many, and we have never seen the limitation of movement. We start early mobilization, and while at the time of tying the knot, I'll try to keep the arm slightly external rotated, and that's why I get, rarely we have seen limitation of the movement. Okay, so after doing, making a good bony preparation, I just check for the reduction. If I'm happy, so what I do, this is a slightly controversial step. I remove almost 2 to 3 millimeter of the cartilage from the anterior rim of the glenoid, so that we can have a good healing on the face of the glenoid. I want this labrum to be healed on the face of the glenoid. I know many surgeons, they don't prefer doing it. Now the next thing is to place the anchor. At this 5:30 o'clock position, I place my first anchor. Most of the time, I prefer putting a double loaded anchor. So in almost 80% of my cases, I prefer putting double loaded anchor. And the first bite which I take, it is from the posterior portal. So this suture lasso is coming from the posterior portal, because see, from this place I want to take bite, and this is not possible for me to take bite from the anterior portal. So this is the suture lasso coming from the posterior portal, and from anterior portal I bring a probe, so that will give a counter, so that I can easily negotiate my suture lasso. And this is the proline which is passing. And over this, I'll relay one of the suture that is towards the labral side. See, from here, it was not possible for me to take a bite from the anterior portal. Now, second limb, I'll take from the anterior-inferior working portal. So now my suture lasso is coming from the anterior-inferior working portal. And I'm taking a bite. Again, I bring my probe from the posterior portal, so that will give a nice counter. And this is my second suture limb. So in almost more than 80% of cases, my inferior anchor is the double loaded. And now I'll put the knots. So I want a good shift from south to north and from east to west, because until unless we get a good this kind of labral repair, our purpose is not done. So after putting first knot, this is the second knot, second suture of the inferior anchor. So once I have achieved this kind of good repair of the anterior-inferior part of the labrum, I think my 60% job has been done. Now I place the second anchor, which is the single-loaded anchor, and the same steps are repeated. So this is the third anchor which will be placed. And for third anchor, we can take this lasso, or directly from the ortho piers or the bird beak, we can pass the suture limb and we can place, put the knot. So once we have done a good labral repair, after finishing with the labral repair, not the only job remaining is to tie the anchor, tie the knots over my past suture, which has already been taken for the remplissage. I have already placed the anchor, I have already passed it. So at the last, I just pass the, put knots on my sutures. That's all. So to conclude, all cases of anterior shoulder instability should be assessed thoroughly for the bony lesion, because in almost 80 to 90% cases, there's some bony involvement is there. And engaging Hill-Sachs lesion can be very well managed by adding a remplissage procedure along with the standard bank cards repair with very good outcome. Thank you.
You always take one anchor for remplissage, or sometimes two? If you feel
most of the time it is one anchor, means almost my 75 to 80% it is one anchor. But if it is a really large defect and I feel the tissue is very lax, then I'll take the two anchors. They're one superiorly and one inferiorly. But it will be two double loaded anchors.
Okay.
Thank you, Vijay. Now I call Dr. Nagaraj Shetty for his 2 lectures, and then we will proceed with the surgery, live surgery.
So I've been asked to cover about bone loss and instability. I think one of the most important topics which we've been discussing for the last almost 1.5 decades now. And the 2 talks are decision making in shoulder instability in the presence of bone loss, and basically the entire spectrum of instability with bone loss. So I have a case-based discussion. So 2 to 3 good cases which covers the entire spectrum of bone loss that you are going to encounter. So I think that will be a nice thing to show. So this was a panel discussion that I had conducted. So the first case scenario, 21-year-old male, known case of epilepsy, 10 to 15 episodes over 3 years, He's had sleep dislocations. He dislocates very easily. Literally, even if he has a big sneeze, he will dislocate. So that kind of instability. The neurologist has made sure that there is a seizure-free period of 9 months. He's completed that and clearance has been obtained. So we all know that this is a bone loss scenario whenever an epileptic comes. Even if there is minimal or a subcritical bone loss when it's an epileptic, we are not confident enough to do the Bankart and remplissage which Brajesh just pointed out. So that's his bipolar bone loss. So you can see that on the glenoid side, the anterior border is straightened. There is a chronic bony Bankart, and he's got a large engaging Hill Sachs. Literally, even in the MRI, you can see the head is literally subluxed out. So this is the kind of bipolar bone loss he has. So it's not just a glenoid issue, it's also a humeral issue now. So the bone loss is only about 15%, okay? And the Hill Sachs is almost 50% of the circumference of the humeral head. So what are the treatment options for this particular gentleman? So you can see the instability in mid-range. So whenever there's instability in mid-range at about 45 to 50 degree abduction, then obviously you've got bone loss. You need to do something for that. So Bankart repair is very, very unlikely to work. Latarjet, if you do the Latarjet, it will take care only of the glenoid side. What about the Hill Sachs? Yes, on the increasing of the articular arc, some amount of Hill Sachs off track will become on track. But this is a different entity, as you can imagine. So almost 50% of the humeral head circumference is involved. Iliac crest bone grafting. Now there's a lot of discussion, and there's a very good take home here, that whether you should do Latarjet for an epileptic or a iliac crest bone grafting. Because an epileptic will have, if at all, a recurrence of epilepsy even after your surgery, he'll have a violent contraction of his conjoint tendon with the elbow. Your bone graft is likely to rip off. So there's a lot of talk now that we can do a ICBG, an iliac crest bone graft, especially for epileptics with bone grafting. Now this was done almost about 2 years back. At that point of time, we didn't have the newer Smith & Nephew iliac crest bone grafting system available with us. So this is what I decided for him, that I will do a Hill Sachs remplissage and a Latarjet. So what are the sequence of steps? So you do it in the beach chair position. That's the anterosupralateral portal. You need to orient yourself. Unlike in the lateral, in the beach chair, to do this is a bit tricky. So the same thing which Brajesh showed, that you place your anchor, pass the sutures through the infraspinatus capsule and the infraspinatus, and don't tie the sutures. You then come anteriorly, finish off your Latarjet. I always do a capsular shift, so I place an anchor in between the 2 screws. So 2 screws, an anchor comes, and the entire capsulolabral complex is further created like a capsular shift, which he showed arthroscopically. So you are giving a nice bony effect, you are giving a nice capsular effect, and then the conjoint tendon sling effect, the triple effect which is classically mentioned. Sometimes I even do a double imbrication. So the capsule is sutured with the anchor, and the superior layer of the capsule is sutured to the CA ligament. So you've got a double breasting also, and this is especially helpful for patients who are extremely lax. So if there's a capsular laxity like a gaugey hyperabduction sign or an abnormal external rotation, then a routine Latarjet can be further supplemented with this capsular shift. So all that was done for him, and then you come back and tie the Hill Sachs remplissage. So bone loss, bipolar bone loss, epileptic, we discussed a few points as to how you can manage them. So this was his post-op X-ray, did extremely well, like all the Latarjet patients, how they do. They regain the range of motion very quickly. But there is a twist in the story. He did well for another 1.5 years or so. He stopped his anti-epileptic medicines. Actually, this is not did well for 2 years. He did well only for about 8 months or 9 months, and then he called me that he stopped his anti-epileptic medicines and he had a full-blown grand mal epilepsy. He was throwing seizures for literally 20 minutes. And then he was admitted in the hospital, and I obviously, as expected, I felt everything is broken, graft has come off, and he's dislocated. But he was not oriented to tell me what happened. I called him, got his X-ray done, so you can see that his superior screw has broken. The graft is looking dicey, so we got a CT scan done. On the MRI and the CT scan, on the MRI we can see that the remplissage is healed well, and the CT scan fortunately shows that the graft is intact. So what has happened is, luckily in the 6-month time period, with good graft preparation, his graft had healed. So in spite of throwing a full-blown epilepsy, the load was taken by the screw, but the graft didn't rip off. Take home message, Latarjet versus ICBG, it's an ongoing discussion for an epileptic with bone loss. Probably today I might do an ICBG because I'm going to show you cases of how we are going ahead with the iliac crest bone grafting. take home message, you need to make sure at least there is a 6-month critical seizure-free period in these patients. If your bone graft heals, you are lucky. There's not going to be any major complications. So he just needed some reassurance and he was back to full function. I hope he doesn't call me back again with another epilepsy episode. So case presentation 2, 33-year-old male, fall from bike, dislocation self-reduced, nearly 6 months since injury, 5 episodes of subluxation since then, and dislocations in the abduction external rotation position. So fall from bike, recurrent dislocation and subluxation events, range of motion is full, cuff strength is normal. Now look at this. Is this a bony Bankart? Is this a glenoid fracture? Anybody? And what could be the difference and why we should differentiate? So if you see here carefully, this is a glenoid fracture simply because it is involving almost 50%, almost 40% of the glenoid anteroposterior diameter in the lower portion here. Unlike a bony Bankart, which is like an avulsion fracture, a glenoid fracture is a different animal altogether because this fragment has the entire capsulolabral complex also detached along with it. It is too large in the superior inferior direction, it is too large in the mediolateral direction, very difficult to go arthroscopically and repair this. Over and above that, this is chronic, it's almost 6 months old now, and he's dislocating at ease. So any from my colleagues, any inputs? 6 months or almost 8 months old glenoid fracture, young adult, dislocating easily, what would be the plan? So obviously we are thinking of variety of things. We are thinking of making sure this heals back. Let me put that as a take-home message. Do not think of Latarjet in these cases. Latarjet is reserved for attritional bone loss, for patients who have repeated dislocations and there is attritional bone loss. It is not meant for bone loss secondary to a glenoid fracture, or for that matter bone loss secondary to a large bony Bankart, unless that bony Bankart is so chronic that it has osteolized, it has become very small, irrelevant, and there is additional attritional bone loss. So what you need to do is tell your radiologist to incorporate this in the CT scan and tell once this is incorporated whether there is any bone loss left. So once this is incorporated, imagine imaginary healing of the fragment. So measure this to this, measure this to this, add. If it recreates the anatomy, that means there is no osteolysis, there is no attritional bone loss, and these have to be repaired back. You can't do it arthroscopically, so this is one of the rare indications for an open fixation and an open instability surgery. In the US now, there is a big section of rugby players, American football players who are preferred for an open instability surgery because of the tips and tricks that you can do, which I'm going to show, which is ideal for them. You can create a wonderful capsular shift in an So the entire idea is to keep the audience engaged. The DAS procedure is something which, so I am among those colleagues who, I take a procedure up very in a moderate speed. I don't take it up the minute it is launched by relying on Western literature. I would rather rely on our own literature, find out what our colleagues have to say, see some of their failures and then take a call. Now, biceps as a structure is so important. We always make sure we do our tenodesis, we are using it for SCR, and then suddenly it becomes less important. You sacrifice it and then use it for a different purpose. It doesn't resonate with me. As you know, there are two ways the DAS procedure is done. One is a surface fixation, so simple swivel lock and they are fixing it on surface, so a point fixation literally. And then now finally they are creating a tunnel. Now creating a tunnel using an endo button, going near the nerve, putting some tendon inside, I am a bit concerned about the outcomes of this. All of us get good outcomes in short term, that doesn't matter. What matters is the long term outcome. So coming back to this case, so chronic dysplasia, no attritional bone loss, we decided to go for an open surgery. Now when you go for an open surgery, you need to do something very bravely. You need to do a tenotomy in a young patient. So when we do tenotomy in shoulder arthroplasty, it's totally different from a young male where we are doing a tenotomy. So you actually have to do a good tenotomy, create a plane between the subscap and the capsule, do a T-shaped capsulotomy of the anterior capsule. This is the right shoulder, this is lateral, this is medial. So this is a T-shaped capsulotomy. You are creating two flaps. The subscap has been tenotomized, the sutures of the subscap are here.
Having done that, I'm using a liberator, and this is a chronic fragment, so there is a lot of fibrosis and adhesions here. You're elevating, liberating it. You're using a burr to create a fresh surface of healing. And then I use the double row, double pulley technique. This is the arthroscopic technique for bony Bankart, which I utilize for this glenoid fracture. So one anchor distal to the bony Bankart fragment, one anchor at the fracture crater, one anchor above. And basically you pass all the sutures of this anchor through the capsulolabral junction and suture these sutures to this individual, this sutures here. So it's a double row, double pulley technique. It's available on arthroscopy techniques. So the same thing I applied here. So place suture anchors, one below the fracture fragment, one at the fracture crater, one above the fracture crater. I used Mayo needle and passed the sutures around the fragment like so. So all the sutures were passed from the middle anchor through and around the fragment. I then placed headless screws because it's a huge fracture. I could put actually 3 headless screws here. So from Arthrex and from Synthes, I used these headless screws. And then over and above that, I tightened the sutures. So screw fixation plus, so it's like a hybrid fixation that I could achieve. So double row, double pulley technique plus screw fixation. I then placed an anchor on the attachment of the capsule on the humeral head. And this is what I meant about the American football players who surgeons are preferring to do an open instability surgery. If you place an anchor here, the T-shaped capsulotomy is here. You can create a capsular shift of the inferior leaf all the way up, and the superior leaf can be sutured down. So you are creating a pants over vest kind of imbrication. So this is considered to be ideal for a person who is constantly involved in overhead abduction, significant impact sport. So the principles of bony Bankart fixation, the principles of glenoid fracture fixation, and the principles of open capsular shift, all that I employed, followed by good subscapularis repair. So that's the capsular shift. So very concerned when I did this. We were discussing in our shoulder group. So a lot of people didn't really have clear answers for this because it's very difficult to do this arthroscopically, especially when it's chronic. So that's the subscap repair. I was myself very concerned of the outcomes. Now that's his glenoid fracture fixation. So that fragment is meant to be there. So take home message, don't take it out. Do not do a Latarjet in these cases, it's going to fail. Think out of the box. Do not try to venture arthroscopically, in a chronic case especially. Doing an arthroscopic screw fixation is possible, but again, not so easy. The trajectory is very risky. And that's his outcomes. We always document these bony procedures with CT scan. We have got the healing, we've got good range of motion. And fortunately, his subscap has healed well. Do we have time or are we ready? Okay, so a nice case again. Case presentation 3, 42-year-old male, anterior instability. He's undergone an open Bankart repair 15 years back by some senior surgeon. And he's always been apprehensive. He's never been happy about that shoulder. He's one of those guys who's restricted his young lifestyle completely. Never played sports because of his worried and apprehensive. So multiple subluxations, sleep dislocations, cuff is normal, huge anterior scar. So never been happy. Probably the days of the putty plot operation, something has been done. So that's his MRI report. There is 15% bone loss. So we are discussing a lot about subcritical bone loss today. So we all know that anything about 20% is critical and that requires a Latarjet. What do you do about subcritical, especially if there is an anterior scar like this? Doing a Latarjet arthroscopically or open is fraught with risks because of the amount of fibrosis that is there because of the surgery and multiple dislocations. So your musculocutaneous nerve and your axillary nerve are at risk in terms of your surgery. So there is something unique that you need to do. And that is what I thought out of the box again. And now we have the system of Smith & Nephew which is available. So that's his level of instability. Again, significant mid-range instability. He's got a significant hill sac, subcritical bone loss, chronic surgery. So the arthroscopy showed literally frayed anterior labrum. So nothing is there to repair. So this is the arthroscopy in the lateral decubitus position. So previously all these surgeries I had to do in beach chair because the Latarjet is done in beach chair and the instability surgery in lateral. Now fortunately we have these options now. So I went ahead with the iliac crest bone grafting. So as you can see here, we are using the burr to clear out the anterior glenoid. So the visualization is from the anterosuperolateral portal, the working is from the anterior-inferior portal. This is the left shoulder. We have taken a traction stitch through the capsule, like you can see on the left-hand side. There's a traction stitch through the capsule which increases the space here to work. You need to make sure that there is a clear, flat surface to receive your bone graft. So that's the traction stitch.
and that's the preparation. These are the special jigs which are available from Smith & Nephew now to create a nice transglenoid drilling. So just like a ACL jig, this comes transglenoid and 2 cannulated drill bits are placed. This is 5 millimeters distal to the cartilage. You need to plan it in such a way that there is perfect apposition of the graft in the inferior half of the glenoid, because that's where the instability and the bone loss is primarily seen. Shuttle sutures will pass through. This is how the bone graft looks. So you take a 2 by 1 by 1 centimeter or 2 by 1.5 by 1 centimeter graft. These are the button systems which is available. So 2 buttons on the anterior portion and 2 buttons on the posterior portion. There's a nice cannula which receives your graft, and the assistant pulls on the sutures from behind, and then you load the button from behind. You put a knee knot. So that's a knee knot, and then when you pull on the sutures, the button is delivered into the posterior glenoid, right? So, and then so you're continuously visualizing arthroscopically, and you can titrate your reduction. So you can see here that you're titrating your reduction. If you're unhappy, you can further adjust your reduction so that it is perfectly flush, and then you put 2 buttons, one at the back, one in the front, and continuously you're making sure that you are nice and flush and in a tensioned manner. And the beautiful part of this procedure, what I like, is that you can do a bank cut repair over it, and then you can also do your Hill-Sachs repair. So you're doing everything that you do in instability, and you're addressing the subcritical bone loss arthroscopically in a person who's undergone an open surgery in the past. So this is how the post-operative picture looks like. There are also other systems available which are without any implants. And most of these patients, they do extremely well. They don't do their rehab as much as other patients, because they feel suddenly very confident and they achieve their range of motion, etc. very early. So that's about most of the bone loss scenario. I've got a couple of other cases, but I think we have time. Right. So any questions until now? Otherwise it will become like a didactic thing. Any points, any criticism? Right. So on the anterior glenoid, whenever you are dealing with these fragments, you are fearful of comminution. You are fearful of breaking it. So this is not a very robust bone, which will take like your Latarjet screws, like a 3.75 or a 4 mm screws. They won't take it. You need small profile ones, 2.75 or 3 mm ones.
Okay.
So the risk is when you're tightening, you don't want to break that fragment. So that's why I preferred the headless screws. Again, thinking out of the box, because the regular Latarjet screws are meant for the coracoid or for the iliac crest. It's not meant for this sort of glenoid fracture. Although, if it's a chunky fragment, you can use it, but I would be worried that you will break it in the last tightening, etc.
Okay. And so what will be your indication? Since one case you have shown combined Latarjet and the Remplissage.
Yeah.
And that was really huge Hill-Sachs.
Yeah.
Other than that much huge Hill-Sachs, what about in how much amount of Hill-Sachs defect you will use Remplissage plus Latarjet? How often you use that?
So that's not a very common surgery to do, because if it's a humeral head circumference about 40, if the defect is occupying about 40% of the humeral head circumference, from that stage onwards, you are worried that the creation of your increased articular arc will not compensate for the off-tracking of the Hill-Sachs. Up to that point, your Latarjet will make the off-track lesion on track, because the head will not engage, because you are providing that much amount of extra bony arc. But if the defect is occupying almost 40 to 50% of the circumference, then even your Latarjet will be inadequate. You can argue that a iliac crest bone graft, if you put a big iliac crest bone graft, you can further increase the articular arc. But then with that comes the risk of osteolysis. So you need to balance everything out. You cannot put a big graft compensating for some other function.
Okay. And how you're doing your Remplissage? Means single, double or triple loaded anchor, or with the suture bridge kind of repair?
Both actually, but my workhorse is triple loaded single anchor.
Okay.
Like when I asked very large Hill-Sachs, I don't mind using 2 anchors also, but my workhorse is a triple loaded anchor. I feel that is better than a suture bridge because you have a good suture array and you can have a very nice coverage of the entire defect. Although the suture bridge double row, double pulley also works well.
So we have approximately 10 minutes to start the live surgery.
Okay.
If you can.
Of course, I've
yeah,
got
please.
cases, so we can keep going. Yes. So this is another nice case. 53-year-old right hand dominant male, presented 9 weeks.
Screen. AV person. Screen.
Rather than this, I think I'll present something very interesting.
So what are the long-term results of this iliac and iliac crest bone graft with the button technique or with the all suture without implant, and comparison it with the two screw technique which was initially described?
Right. So the largest data we have is from Taverna, Ettore Taverna. He is the one who has invented this technique. And the button technique came from Pascal Boulot. So if you think in terms of the biomechanical fixation of the button versus the screw, as you know, Pascal Boulot has published it innumerable number of times that the button and the screw are almost equally strong. In fact, the button is, according to his studies, even stronger than the screw. So there's adequate data on the biomechanical strength of the button. Now the question about the long-term effects of the iliac crest bone graft. Taverna says there is a very good outcome. We have to see our data. So following up of my cases is what I'm going to understand and I'll be able to answer better. He's been doing this for almost a decade now. They've even gone ahead and started using xenografts. In order to reduce the morbidity of iliac crest bone graft, they've gone ahead and started using xenografts to make it like a regular implant. You know, you open an implant, take care of the bone loss, do the bank-cut repair, do the remplissage, and you are done. As we know that allografts have also
Hello, Sheetal.
Hello, Sital sir, you are live, sir.
Okay. Yeah. So, Sheetal, can you?
Yeah. So this is
tell us-
basically a case which has got more of a MDI and a very small anteroinferior labral tear along with a very small hill sec. So you can see I have got a lot of space here. Whole of the ligament is legs. You can see this is the IGHL. This is the labrum. So this is the posterior standard posterior portal. So I have made this posterior portal. I am looking from the antero-superior portal in my radio frequencies coming from the antero-inferior portal. So you can see whole of the labrum is looking quite good except for a very small antero-inferior labral tear, which we probably going to do a capsular plication along with this. So it's more of a, looks like a more of a MDI with an anterior component. Pakad ke rakhna. Give me a elevator. You can see I got a lot of space here. Rest of the inferior labrum, posterior labrum looks normal. My elevator is, you can see this is whole of the labrum. And this was the antero-inferior labral tear. So you can use either this labrum and you can just try with the capsule, or you can actually put the anchor and do the whole of the capsular plication, including probably we may have to go for a rotator interval closer in this case. So it's not exactly this the classical Bankart lesion. It's more of a labral tear, antero-inferior labral tear along with a MDI with a unidirectional component. She has got a history of dislocation, 2 dislocation recently and a previous dislocation. So what we are going to do is basically do some kind of a labral mobilization, but not exactly that we do in the classical Bankart and go and see the subscapularies, because see it's all the capsule are here. This is the labrum, this is the IGHL. Even the posterior IGHL, if you see, it's quite lax. So we'll start putting the anchor and we'll start doing the capsular plication. This would be the plan, particularly in this case. You can see here also the labrum looks quite normal.
Yeah. So, Sheetal, do the patient have Hill-Sachs lesion?
Hill-Sachs lesion is there, but that too. पकड़ना इसको. निकालो. Rotate.
So, Dr. Nagaraj, what is your opinion in such kind of cases? Can you show?
I think it's more of a capsular plication and followed by the rehab actually. You see, the Hill-Sachs is quite shallow. You see, I would not label it actually as a Hill-Sachs lesion. See, it's a very shallow.
And very voluminous capsule.
Yeah,
Like
see, I'm able to see everything on every corner. I'm able to go so easily. So roughly what I'm planning to do is just curate the articular cartilage margin little bit using a combination of radio frequency and a curate, and just stimulate some. So in this particular case, we have to take precaution that your cannula is going to come out frequently because it's a very, very lax capsule. So this is basically the face of the glenoid. So I'm just trying to do some curettage.
Have you seen on the humeral side the capsular attachment?
Yeah, that is fine. That I have seen actually.
Okay.
Sheetal, Nagaraj here. Can you show the capsular attachment coming onto the labrum? Do you feel that there is a capsular rent or a stretched
Yeah,
out
there is
capsule?
some capsular rent which I am going to probably include because it's a very, very lax capsule.
Correct. So
you can see this is the attachment on the humerus side. You can see, appreciate this.
Yes.
So there is no Hegel lesion per se. This is, you can see the volume of this whole of this capsule. So it's a more of a lax capsule. So in such cases, what I prefer to do, even you can use a labrum as an anchor. So because this labrum looks fine, but at least for antero-inferior portion at 5:30 and around 4:30, we would like to put an anchor. ये बंद हो गया. We'd like to put an anchor because that will give a better fixation. And we'll try to include as much capsule as possible, but not too much of the capsular plication because that is going to restrict her natural movement and that will convert into a more of a stiff shoulder. So we'll just try to take a bite close to the labrum, include that bite into the labrum along with the capsule. Give me the RF, liberator. Liberator. No, liberator.
So you see, I have made the enter-infra portal in a such a way that all my instrument will automatically go towards the 530 position. So I am just removing the layer of the cartilage which I was not able to remove with the curette. See, so this was the small rent that we could identify and which was visible in MRI as well. So don't need to go that deep down like we go in the routine Bankart lesion. Outflow चालू कर दो, छोड़ दो, लो. Give me a radio frequency. So I will use radio frequency on the face of the cartilage. See, this is the face of the cartilage. So I will just remove a strip. चल रहा है यार? Taking care that not to damage the labrum. You can use any method. I just mark it with the, this is a marking for the placement of anchor as well as this will help me in see this is the technique which is described by Dr. Sanjay Desai only, in which he created a turf kind of this thing on the face of the glenoid. So this is the face of the glenoid. I have created a very small turf and I will use a curette again. So in all suture anchor, you have to take precaution that you cannot create a deep trough because all the hole is there on the top of the cortical in the cartilage. So just you see, you can hear the sound. See?
Yes, we can hear.
Outflow चालू कर दो 1 मिनट के लिए. So keep the Q-fix ready.
Q-fix anchors are the preferred choice of your anchor?
Yeah, always. All suture anchor is always my preferred choice.
Straight or curved for the inferior?
Straight.
Okay.
You can very well approach this angle actually. So you can see I have prepared up to around 330 position and I am planning to put a sleeve over here. बस इसको निकाल लो. थोड़ा हैमर कर दो हल्का सा. I will just go. Q-fix ready. So Q-fix has got auto stop. Go. Remove. Go. So don't change the direction. Go. Yeah, no, that's done. Yeah, go. So you can hear the sound. Yeah, so there is a one click and probably a second click will also come that will deploy the anchor. So it's got a rigid shaft. So even if you miss the trajectory, you can go back. You can hear the second sound as well. So hold the cannula.
So this is a double loaded anchor or single?
It's a single loaded anchor because we just want to do a simple plication kind of a stitch. Give me a suture. So this is my parking portal basically. Suture manipulator. So what I will do, I will park one which I wish to pass through this. And again, what Dr. Nagaraj was pointing, that while I am taking this out, nobody should hold this. Can you see the outside vision as well?
Yes, we can see
If
that.
somebody has clamped it or somebody is holding it, then you will not understand which one you are pulling. So I am pulling this one, which is close to the labrum, and I am just checking the movement of the anchor. So if there is no movement, that means I am taking out the right thread. Otherwise, that will lead to the deloading of the anchor. So advantage of Q-fix is a very long thread
So chances of deloading are relatively very less. Passer? Left to right, yeah. इसको साइड कर लो, टाइट करके रखो इसको साइड में.
So advantage of this Q-fix anchor is it has very strong pull-out strength, and it creates very small hole into the bone.
Yeah.
Okay. So at times you
So you see, I have taken the IGHL, and along with this, I have taken the labrum as well. So I am trying to tension that IGHL. Hold this. And what I will do, I will just take a suture retriever. So you see, my portal was relatively inferior, so that my suture manipulator will go in the right direction. I don't have to go at an angle. So we are using the simple relay techniques. You can see the bite is, hold the cannula. पकड़ना इसको. Cannula पकड़ लो. So I taken the bite both through the, right? So now give me a suture manipulator. One more Q-fix ready. So I'm just going to park this in the posterior portal. One more Q-fix. पासर तो एक बार और. नहीं देखो हिलाना नहीं इसको. पासर. So I will take the passer again. So if you are not able to negotiate, you can take the capsule in the first bite, and then in the second bite you can plan to take the, hold this. Hold this. Hold the camera. Hold the camera. Keep one more Q-fix ready. So you see, I am pulling this. So this is the right suture. I will again tie this suture. Tie karo. There is no point creating a bumper over here.
So you are taking a mattress sort of.
Yeah, absolutely. Tie karo. Achha tie.
So since the labrum is well attached, so keeping the labrum in its place, just plicating the capsule.
Yeah, absolutely. See?
Yeah.
So I have taken the two bites, some more of a matrix configuration. Give me a suture manipulator. I will again repark it in the posterior aspect, that is in the posterior portal. So once you do this, you can see there is a IGHL which is approximating.
Yes, very nicely.
Yeah. So I will go ahead and give me a suture anchor. Yeah, again, drill. So till the time I am comfortable, I will operate from this portal only. Once I feel that it is very difficult to go from this angle, I will change and I will go into the posterior portal. Okay?
Okay.
Yeah, go. वो देखो ये हिल रहा है, लाइट नहीं हिलाओ, चलो जाओ, निकालो, रिमूव, गो. गो शो, जाओ, जाओ, करो, कोई भी करो. So again, this is the second Q-fix. So it's a very comfortable anchor which gets auto deployed just by this screwing movement. Sure, yeah, done. So you are able to see very well from the anterosuperior portal. In your working portal is an anteroinferior portal. Nikalo. Yeah. Go slow, pakad lo. Yeah. Hold the cannula. You can see this anchor, okay?
Very nice. End on view of the anchor.
Yeah. Usko side kar lo dono ko. The first pair will lock and will try to go just superior to this, and I will again hold this and park it again here, and I will take the passer again, and further I will try to take a bite of IGHL. Just take precaution that cannula doesn't come out. So it's even you see the quality of capsule is not very good. Nagaraj is there?
Out. Yeah.
So
Nagaraj has a flight.
Okay.
Yeah. So he just left.
What would you do in such cases, Vinay? I mean, the capsule is quite lax.
Yeah. I don't think nothing else can be done.
Absolutely.
Yeah.
So there is one DAS procedure which is described. I don't have any personal experience, and probably in future, once more of the literature is available, probably we will start thinking and doing this direct anterior stabilization using a biceps. But fortunately, unfortunately, it must be having its own merits and demerits. So it's a simple just tying the knots and relaying our suture. You are able to see the outside view?
Yes, we are able to see that.
So the first we have taken mattress. Probably this we are going to take simple. Take a shot. So you see now the whole of the capsule is getting closed. Suture manipulator. So as of now, what I will do basically, I will just identify the post. So rest of the principle is going to remain same, not pusher. So one suture which is crossing from here. So what we will do, just खोल दो इसको, open कर दो. दोनों छोड़ दो. Suture manipulator. Hold this. Okay. So I will tie this first and then I will tie my mattress suture. So if you use a sliding knot in such case, that is going to further cheese grate effect your capsule and the labrum both. So in such cases, the preferred option would be using a non-sliding knots. First we will identify the pose. So we are sure that this is the pose. You see, I am closing whole of the capsule onto the labrum, which was initially looking very lax. This is nothing, it's a simple half EHS that I am trying to put and try to keep my knot onto the capsular side rather than on the labrum side. Okay. You see, we are creating the almost same bumper effect, but along with the IGHL tensioning. So So first two are forward, then reverse. Then you have to change the pose. So changing of the pose you can do by two methods. Either you can actually shift your knot pusher, or you can see under vision. And you can see I am changing my post. You can see the flipping of the knot?
Yes, yes.
So this way I am changing my post. So the fourth would be changing of the post. Fifth will be again under hitch. And the top one would be again a change of the post at the same time. So I will go like this. And this point of time I will change the post. So changing the tension on one of the suture will reverse the post. I will cut the suture now. So you have to tighten, but you don't need to do too much of over tightening, because that's going to hamper her natural laxity, which is probably going to have in both the shoulders. So you can see the IGHL is now actually looking anatomical. It was previously quite lax, which is looking anatomical and exactly attaching up from the 530 position up to 430 position very well.
Yes, exactly.
Suture, manipulate. तीसरा क्यू फिक्स रेडी कर लो. पकड़ लो. So in the mattress it will not matter which one is the post, because both are the post. Both we have passed through the. So mattress I prefer almost in all cases where I feel that the tissue quality is not good. So there may be a possibility that one of my anchor is not holding very well. So at least the second thread is going to do my job. And the double loaded, which somebody was asking, I will only use if my lesion is extending. So if I feel that my Bankart lesion is extending more than 5:30, 6 o'clock, then that time I will use a double loaded anchor. And while I am using a double loaded anchor, I will take a bite from the posterior side rather than from an anterior side, what I was showing just now.
Yeah. So do you also take or consideration of the posterior part of the IGHL, like
for tensioning in this particular case?
Not in this, or in routine.
Routine. I never do PIGHL tightening, because that usually restrict the internal rotation. So I think a standard Bankart, just extend the lesion. If it's around 5, you can extend up to 5:30, so that the liberation itself will do some kind of a capsular ligamento-capsular complex release, and then you can shift whole of the complex superiorly and anteriorly.
And in this case, if you think it is a MDI sort of.
Yeah. So MDI with a unidirectional component, I think doing a posterior labral plication is never a good option. If she would have a posterior dislocation incidence, then probably you may have to go for a 360-degree rather than just confining yourself to anterior and posterior. So probably in this case, we may have to go for a rotator interval closer. The only disadvantage of doing a rotator interval closer is that it do some loss of external rotation. But if you see the recent study by Dr. Sugaya, he himself is starting doing again the rotator interval, that too in a high-end sports persons. But only thing that he does is, while he is doing a rotator interval plication, he keep the arm in abduction and external rotation, so it avoids the typical effect of that rotator interval closer leading to stiffness. So passing the next anchor, I would again prefer to shift myself to the posterior portal again, because now the vision would not be very good from this portal. So I will take the Vicinzer rod and I will visualize from the posterior portal. So my posterior portal will become, you see this is parallel to the glenoid, it is on the inferior surface. So what I was telling, you can take a bite from here. If you are using a double loaded anchor here, one pair is here, one pair is here. So you can actually use a curved suture lasso kind of a device here, tie it, and one passage can be here and one passage from the front.
Yeah, Dr. Brajesh has demonstrated that thing. Using double
So
loaded.
that is, yeah, so that is a specific indication that I will use a double loaded, otherwise a single loaded is sufficient enough. So I will shift my scope to the posterior portal now. So as of now I was doing all my visualization from the anterior portal. You see, it's looking like a normal shoulder now. Previously, there was a lot of capsular laxity. You see, even the subscap and everything is quite weak. You see the quality of capsule over here. There is a widened rotated interval, which itself suggests that patient has got a kind of a laxity. So in some such cases, I usually take a bite of a MGHL along with the labrum, but again, you see there is no MGHL per se. Can you appreciate this? There is absolutely thinned out MGHL, probably may or may not be present.
Yes, yes, we can see that.
Yeah. So I will take the next anchor.
Yeah.
Then you fix. Hold the. Hold. Hold the. So at this point of time, what I will do, I will put a cannula for the better management of suture on the anterosuperior portal. Wissinger rod. So see, my anterosuperior portal is little bit different. I am just medial to the AC joint. So you see, this is my anterosuperior portal. So this is the advantage of this anterosuperior portal is you are again parallel to the glenoid. So even if you are looking from the posterior portal and you want to retrieve the suture, if you are coming at an angle, it will be difficult to go up to this place and retrieve your suture. So I am more, this is parallel to the glenoid. One more Wissinger rod, please. And you see the direction of my cannula, the anteroinferior portal I make in a such a way that whenever I go, it is exactly 45 degrees, so that whenever I am putting my anchor, it is at the deadman's angle. So all instrument will automatically pass at this angle. Suppose this angle is basically close to subscapularis and high. If I make it low, then you cannot put anchor at that particular angle.
Yeah.
So this angle is very, very important while you are making your first anteroinferior portal.
That's very important trick.
So I will put cannula in my antros. No, direct ka zarurat nahi padega. Just cannula. Put it. So you can manage this without cannula as well, but cannula makes your life easy and comfortable. So I always prefer to use blue wala iska. You see, it's very difficult to pass this cannula, but in this particular case, so easy. Just going by hand. So you can see the different angle. This is 45 degree and this is parallel to the glenoid. All my two portal are anterior to the biceps. I never go posterior to the biceps because sometimes in suture management you can actually entrap the biceps. Drill. Thoda withdraw karo cannula. See, now my visualization would be better. I have already made the turf for passing the anchor. So this is almost around 330 position. Ek minute, okay.
So you do all your shoulder procedure in lateral decubitus?
Yeah, always. Bas.
So there is an extension rod or something which I can see in external picture. Can you show?
Just a minute. Yeah,
the
just give me a
setup?
minute. Yeah, I will show. Go. So you can see the shaft is moving up, and you can hear the sound if you are able to.
We can hear the sound, but shaft we cannot see.
Yeah, this shaft was moving up actually.
Okay.
So this is the second sound which indicate that even if you don't hear that second sound, that is absolutely fine. Slow. Yeah. Hold the cannula. So once I am taking any instrument out, it is very important to hold the cannula. Otherwise, every time the cannula, particularly in the left capsule, it is going to come and out. So this is my setup. You can see this is a lateral decubitus position. Okay. This is the traction, which
external
yeah,
zoom out,
external
please.
view, please. Ek kuch rod de do haath mein.
External camera, please zoom out.
So there are, this is the basically two-way traction. The first traction is for abduction and forward flexion. You can see there. So this is around.
External camera, please zoom out.
Zoom out, zoom out.
We are just able to see the shoulder only, not able to see the.
Zoom out किया?
नहीं.
पूरा दिखना चाहिए. थोड़ा सा zoom out कर.
Yeah.
So this is a rod, basically extension rod. From here, this is a traction for the abduction, and you can see this. This is on the light, this OT light. So on the OT light, there is a lateral traction. So what this lateral traction is giving, this is giving me advantage of opening the joint very well. So that is one more reason why you are seeing this joint very well, because I have given additional lateral traction. The advantage of this lateral traction, if you reduce the height of the table, the traction will increase more. So depending on the OT height table, I can adjust my traction as well.
Okay.
So again, the principle remains the same. The one which is close to the labrum, that you want to pass through the labrum. So what we are going to do, so this is out of which this is close to labrum. So this we want to pass through the labrum. So this I am going to take out from the anterosuperior portal and pass it. Why this is required? Because this is just for the suture management. So you see, once I am removing it, my second suture is not moving. Okay? So till the time my second suture is not moving, that means absolutely this is fine. But suppose if somebody is holding the other end and I am pulling it, probably it may dislodge the suture. So ask assistant not to hold any of the threads and just manage it by yourself. Okay?
Yeah.
The second thing is, while you are passing this, it is usually a sharp instrument, so ask your assistant to take that thread relatively away, so that once you are putting this passer, you should not damage the thread.
Okay. So this clicking sound is the beauty of Smith and Nephew anchors. May it be Q-Fix or SutureFix Ultra. That click indicates that the suture, the anchor is deployed.
Deployed,
properly.
yeah. So it's a just gentle movement of wrist supination and pronation. If you try to do too much, you can break actually this. Hold this.
Sheetal, what structure you took a bite into?
Yeah, this is probably part of a MGHL along with the capsule. Okay. Subscap is far away, don't worry about the subscap. But still there are some study, you can actually take some portion, inner portion of the subscap, particularly if the labrum quality is not good. So this is, you can see this is more of a part of IGHL only. This is more of an anterior band, anterior border of the IGHL. So practically I shifted the IGHL right from 530 position up to the 330 position, because that is the way only you can achieve the whole of the capsular shift along with the ligamentous shifting. So again, doing the conventional technique of relaying it, there are certain things. You can see this is the subscap. Tanmay?
Yeah, we can appreciate now. Yeah, that's probably the IGHL.
Right? So you can see whole of the capsule is closed now once I suture it. The only thing is, if I use a sliding knot, there are chances that it may cut out. So I will take that precaution, or you can take a mattress suture. Okay? So I will go ahead and suture this, and whatever remaining threads are there, I will pass one in the superior and one in the inferior cannula, and I will do a rotator interval closure as well.
Okay.
So Hill-Sachs, what I have seen in MRI, and even if you see the report, they have clearly mentioned it's an on-track lesion. So on-track lesion, don't try to do remplissage. There is nothing like a prophylactic remplissage. Okay, so this is my post. Again, I am going to take a alternate half inches. See? थोड़ा सा दूर. So now you can appreciate the anatomy very well. This was the IGHL. This was whole of the IGHL capsular complex. This is you can see this is the subscap, and this is the rotator interval. So what we are going to do is just plicate the probe दे दो नहीं और नहीं. So I think I am happy with my tension. Can you appreciate this?
Yes, we can. Yeah.
So labrum is very well in position. The whole of the IGHL and the capsule is tensioned. Only thing that is left is basically वो देना कुछ बचा हुआ टुकड़ा switch manipulator पे डाल के. So Smith's nephew has got this Q-fix with a very long thread that gives advantage. You can use it for some kind of a closure. निकाल दो. नॉट पुशर ले लो या थोड़ा सा कैंडुला अंदर डाल दो. कैंडुला अंदर डाल दो तो आ जाएगा. बस छोड़ो धीरे विड्रॉ करो. नॉट पुशर से ले लो. नहीं नॉट पुशर एक में माउंट करना पड़ेगा. या दूसरा हैंड पकड़ के रखो. Go inside. Yeah, leave it. छोड़ो. अंदर ले जाओ. निकाल लो. Hold one end. कोई भी end पकड़ लो. You see, now what I will do, I will remove the cannula. You can see, appreciate the subscap?
Yes, we can.
Yeah. So I will remove this cannula. I will remove the second cannula. So this I am going to tie just by passing a suture. देना मैं कुछ suture pass है. Suture manipulator. So one stitch is enough. If you feel that you want to put one more stitch, you can. Only thing you have to take precaution that there is no dimple. That means you are well below the deltoid. So there is no dimple which is coming. So I am doing this rotator interval closer. While I am doing the closer, I will just prefer to do some external rotation. Okay. Done. छोड़ दो हाथ को. I'm not sure what to call this. Is a very simple case or a difficult case. But only the principle remains the same. And even it would have been a Bankart lesion. It's if you're looking from a anterosuperior portal, just take your elevator, go expose your subscap, and do the same step what I've shown you just now.
Yeah, it's a difficult case made simple. SMS.
Yeah.
Sheetal made it simple.
Yeah. You can see now, once I had tension, you can see the some fibers of this MGHL. Can you appreciate this is the MGHL?
Yes.
So MGHL is now tensioned, IGHL is now tensioned, and probably some portion of SGHL which is also tensioned now. So there is a tensioning of all the three ligaments. Posterior, I would not prefer to go and do the tensioning posteriorly. See, I am able to go into the axillary pouch. This is the biceps, the cuff looks absolutely pristine, and the only indication for that this is a MDI, if you are able to see the posterior labrum very well while you are withdrawing. So you see I have withdrawn my scope and still I am able to see the posterior border of the posterior labrum. Can you appreciate this?
Yes.
So that indicates a MDI. Otherwise, once you try to see the posterior labrum, your scope will be out. So it's actually a legs joint. And Hill-6 I have shown, we don't need to do anything for the Hill-6. So any questions as of now, because I think I'm done.
It's very well done, Dr. Sheetal. What will be the rehab protocol in this case?
Rehab protocol, I will follow the same principle as the Bankart, because now the capsule needs to heal along with the labrum.
Yeah.
So probably initial 4 weeks I would like to immobilize just a flexion extension of elbow and the wrist movement. At 2 weeks I will start the gentle pendulum exercises. I would try to avoid the abduction axial rotation for some time, just to avoid all the capsule to get healed onto the labrum along with this whatever I have plicated. So abduction axial rotation strengthening would be allowed only after 3 months.
Okay.
And she just need counseling that, because there was a generalized laxity and the capsular plication has been done. Future she may require some, although there is no bone loss, so probably she should do well. She require a good rehabilitation, because she will have a probably chance of the dislocation the left side as well. So considering a MDI patient, the first step would be rehab. But if the patient has got a MDI with a unilateral direction or a unidirectional instability, that is an indication for surgery. MDI per se is not indication for surgery, but unidirectional component is definitely.
Yes, yes.
Okay?
So,
Thank you.
very nicely demonstrated surgery.
Yeah, fine.
Yeah,
Thank you.
yeah.
Just close
Right.
it.
Thank you, thank you.
I would like to thank Vinay, you are here.
Yeah, I'm here.
Thanks to anesthetic. Hypotensive anesthesia. Yeah, for hypotensive anesthesia, your whole of the OT team is excellent, and thanks to Smith and Nephew for this wonderful coordination in the program. Thanks to my both the fellows who has come from Bhopal, and my OT persons Narendra and Ashok, who has traveled to help me for this surgery. Thank you.
Thank you. Thank you, Sheetal.
So, any questions to Dr. Sheetal or to anyone? Hold on.
So, thank you very much all the delegates and the faculty. I would like to invite Umesh to say the vote of thanks. Yeah.
So, thank you everyone for attending this meeting. Special thanks to all the faculties who has, given their entire Sunday for this course, and a big thank you to Dr. Vinay Tantuway, who has been instrumental to us and helping us to organize this meeting and helping to, develop the scientific program. And then, though it's a marriage season, so we are getting the venue also. So thank you, sir, for helping us to getting the venue as well. Thanks to Dr. Sheetal Gupta. I know he was having a pre-commitment, but still he could make this meeting happen, and he came and demonstrated the surgery and taken a part of in the lectures as well. Thank you to all the delegates who has came on Sunday. Those who are still here, seeing entire program. So. A sincere thanks from Smith and Nephew, and we will be sending a link for the feedback, and we'll request to respond on that link, so that it will help us to improve our program for the future. Thank you. Sir, we have a felicitation for the
Let Sheetal come. थोड़ी देर जब तक ऐसे चिट चैट कर ले. हाँ? शीतल को आ जाने देते हैं 5-7 मिनट में.